হ্যাঁ আমার নিচে যে শেয়ারের অপশন আছে সেটা তো হ্যাঁ ইউটিউবে যে শেয়ারের অপশন আছে আসছে সেটা মানে শেয়ার করো আর লিংক কপি করলে ম্যাডাম পাঠিয়ে ঠিক আছে नेक्स्ट सवाल क्या है 10 9 10 10 11 बोला था अब 11 तो होगा नहीं 10 मतलब कहाँ छुट्टी हो जाएगा फिर उसको 9 10 11 12 13 तेरा गोवा से कब रिटर्न आ रहा देखिए लिस्ट में देखिए हम नॉट मार के रखिए हम स्टेट्स के देखिए हां बंद कर चाप अपने ऑन हो गया चाप करो ना सर उतना सर यूट्यूब लाइव में ना वही है सर खोल दीजिए हाँ हाँ प्रीतम ओपन नहीं कर दीजिए हो गया सर गाइड गाइड कर दीजिए हाँ हाँ ठीक है हाँ ठीक बैक कर निकल गया कर दिए के बाद तो फोन करता है उसको कहीं जाना है तो कहाँ दिखा रहा है रात का आया देख रहे हैं देखिए कानून बोले कौन सा नॉट ये है तप्पा तत्ता इधर क्रॉस मारा हुआ सर्जी करके ठीक है तब तक कलर कर दो तो नाम उड़ जाने से नाम आ जाता है नाम में से ऐसे हो दीजिए अरे मान आपको दिखाने से पहले हम सोचे होगा दूसरा जगह हटा देंगे कलर करने तो ज्यादा टाइम लगेगा नहीं मुझे हाँ अच्छा लगेगा आग लगा देगा आग लगा देगा विकी के पीछे दोनों बेड़ा रात का राजा विकी वजह कमेंट करो दोनों रात का राजा माइक অনেকটা বড় গাড়ি।
ঠিক আছে, সাউন্ড আসছে জুমে। হ্যালো, চেক। ঠিক আছে। হ্যালো, চেক। হ্যালো, চেক। মাইক টেস্টিং 1 2 3। চেক। হ্যালো, চেক। আসে। নেটের প্রবলেম। ঠিক আছে, তিনটে নিয়ে ঠিকঠাক করে নেবো। প্লে হচ্ছে। হুম। একটু বাড়ি অ্যাডজাস্ট করে গেল। আচ্ছা, এবার একবার এটাতে সুইচ করাবে। ঠিক আছে, আরেকবার সুইচ করে দাও। সুইচ করো। সুইচ করে দাও। তাহলে টিভি সামনে দাঁড়াবে।
Hello. So a very good afternoon to all of you. Finally, the big day has arrived. After 2 years of virtually organizing Bdcon, we are back again in a physical format, the format that all of us love. And we'll be having the formal inauguration later this evening at around 5 p.m. We'll start the scientific proceedings right away with the uniquely planned diabetic food workshop, a hands-on workshop. And to take us through this workshop, we have none other than a very experienced, a very energetic clinical podiatrist, Mrs. Rekha Srivastav. Without wasting further time, I would request all who are interested in the workshop to come and sit in the rows in front so that you can get a hands-on experience with diabetic food. And I would invite Ms. Rekha Srivastav to kindly come up and continue with the proceedings.
Thank you, sir. I am Dr. Rekha Srivastav, clinical podiatrist of ILS Hospital, Salt Lake, Kolkata. So today I am discuss about the most neglected part of our body, that is foot. And as we know, the diabetic foot is increasing worldwide. And so today I am discussing some aspects of the diabetic foot. So what is diabetic foot? Diabetic foot is the collection of foot problems which are not unique but occur more commonly in diabetic patients. It is one of the most devastating chronic complication of diabetes and is leading cause of hospitalization and lower limb amputation. More than 1 lakh of legs are amputated every year, and the number is increasing day by day. Almost 85% of these amputations are carried out due to neuropathy and infection, and this may be preventable by a little education. So education plays a significant role in preventing, diagnosing and monitoring and treating the diabetic foot disease. And education, not only the physician, but also the paramedic students and also the patient and their family members. So the fact is the foot ulcer is the most common and costly complication of diabetes, and it is the worst than the 5 most common cancer like bladder cancer, colorectal cancer, breast cancer, lung cancer. So it is the most costly and common than the 5 common cancers. In initial days, I started with the every 30 seconds is the leg is lost due to diabetes. But now the scenario has changed, and it is now the every 20 seconds a leg is lost due to diabetes. And in India, around 77 million of diabetic patients, and we have to take care of 154 million of diabetic foot. And so to take care of this feat, we have to need to increase the awareness among the mass of the people. So in India, there are some problems like we don't have any foot screening programs. We are organizing diabetic screening program, eye screening program. We have done the ECG camps, but nobody started the diabetic foot screening program. So, and also the lack of podiatry services. Only in few cities in Kolkata, very few organizing diabetic foot clinic are there. And there is no structure podiatry course. This is the main big hurdle of our city. So there is no structured podiatry course. And also people ask every time where we get the shoes, orthotic shoes and the diabetic shoes. So really it is a very big problem. We are not getting such type of diabetic shoes. And socio-economical factors encourages like barefoot walking, walking on the fire, and we are generally using Hawaii slippers in our indoor, and the married woman using the toe rings or the foot ornaments, which may be the cause of the ulceration. Lack of awareness of the seriousness and consequences of the disease, and very few have the health insurance, because in abroad they have the health insurance of the all disease, but in India there are very lack of health insurance, and the people have to pay from their own pocket. Now these are some diabetic foot cases. This is infected ulcer on the plantar surface of the great toe. Heel ulcer, it is more than 4 to 5 years non-healing. This is also neuropathic heel ulcer. You can see this is the maggots, the non-healing ulcer with the maggots, and this is fresh debrided ulcer, ulcer with the callus. These are all the neuropathic ulcers, and this ulcer happened due to the nail prick, and this is very common. And this is rodent bite, rat bite, and this is the ant bite. So these are very common phenomena in our country. So bilateral neuropathic ulcer, this is the bilateral great toe ulcer, and this ulcer happened due to the hurricane burn. In winter season, they in village they apply the hot fermentation with the hurricane and followed by this ulcer formation. And this is the ulcer on the first empty head on plantar surface of both feet. And this is a chemical burn. This is chemical burn, and somebody advised this patient to give hot fermentation by the potassium permanganate and followed by the chemical burn. These are the ischemic ulcers, tram cut injury, and this patient is having come with the this type of ulcer, and history is he is applying the very tight crepe bandage followed by the formation of the gangrene of the toes. So this is the infected ulcer followed by the hot bag fermentation. This is very common in our country. Almost most of the people having some pain in the foot, and they apply the hot fermentation, and they come with this type of presentation. These are also the limb-threatening diabetic foot infection, and as I told earlier, we generally walk in the temple in the barefoot, and followed by this type of blister and ulcers. These are the common deformities: clawing of the toes, hammer toes, overriding of the toes, hallus varus and hallus valgus, the common deformities. Thick nails due to fungal infection, recurrent fungal infection. This type of nail are coming to us, and it is very difficult to cut with the simple nail cutter. So in this case, we are using the podiatry kit, or for the nail cutting, we use the nail neglers. Ingrowing toenail and cracked heel. In winter season, we you also get this type of patient, and digital mycosis, fungal mycosis. So whenever a patient comes to a clinic, we definitely check the web spaces of the foot. So the risk categorization, so 0, 1, 2, 3, and 4. If there is no neuropathy, then category 0. In high risk, 1, if the patient is having neuropathy, but no deformity, no peripheral vascular disease, no history of ulceration, amputation, Charcot foot, or peripheral bypass. In high risk 2, there is neuropathy and deformity or peripheral vascular disease, but no history of ulceration, amputation, or Charcot foot. In grade 3, history of foot pathology, and in grade 4, active lower extremity disease. So whenever a patient come to our clinic, we have to check for the foot assessment, and we have to check the shoes and socks. We have to ask them to remove their shoes and socks for the foot assessment. So in diabetic patient, in non-diabetic patient, we generally examine from the head to foot, but in diabetic patient, we always ask to examine from the foot to head, and that is called in Sanskrit apadmastak. So foot examination can be done in 30 seconds, can be done in 2 minutes, can be done in 1 hour also. So in 30 seconds, we just check the foot, is there any foot problem, check the pedal pulses, protective sensation is intact or not, and if there is evidence of foot deformity. And the 2 minutes examination, examine the feet for the any ulcer, callus, blister, maceration, skin breaks, infection, examine the toenail, and examine the footwear also. So in our clinic, patient come along with this, you can see there's the high pressure areas, the heel area and the great toe. You can see there is complete bottom out of the outer sole, and this is the tied with the rope. This is also the tied with the rope. And this patient, a patient came with the pain in the great toe and redness and swelling. And when we examine her, then we find this type of stapler pins are pricked in the great toe. So the characteristic of the neuropathic foot, well perfused with bounding pulses, distended dorsal vein, and the neuropathic ulcer always occurred on the high pressure areas, and the plantar calluses, plantar ulceration, and wet infected gangrene may be there, and there is the loss of protective sensation. In neuroischemic foots are always cold to touch, pink, maybe pink in color, or some discoloration. Pulses are less or sometimes maybe feeble, and the ulcer are on the at the margins. So assessment of the neuropathy, there are many simple clinical tests like this monofilament, biothiometer, pinprick, tuning fork, neuropads. So in our clinical practice, busy clinical practice, we only use the 10-gram monofilament and biothiometer. So we don't go for the slide. We can perform on the practical. This is the 10-gram monofilament. We called it as a 10-gram monofilament, Siemens-Weinstein monofilament. So how we can check? We just apply this monofilament perpendicular on the foot and give the pressure of 10 gram so that it just buckles. And the sites of examination are the great toe, first empty head, and fifth empty head. Some says there are a lot of sites like great toe, first empty head, third empty head, fifth empty head, and heel area and dorsum. But nowadays we are just try to do in 3 sites: great toe, plantar surface of great toe, first empty head, and fifth empty head. And if there is any 2 in both feet, if there is any 2 are absent, then we can call as the neuropathic. So this is the monofilament test. By this test, we only say whether the patient is neuropathy or not, but only this is the qualify. But to quantify, we are using this type of the VPT or vibrothiometer. So can anybody who is diabetic can come as a volunteer? Anybody? Thank you, sir. Please come. Remove your shoes and socks. Yeah, both. So this is the VPT machine, and it's we measure it in the volts. Okay. So kindly, yeah, both feet. Okay. So we just increase slowly. Can you focus on this? Yeah. Yeah. So we just increase on in this and first, sir, up, yeah. Just increase. Are you feeling anything? Yeah. Some vibration. Okay. So just close your eyes. Okay. And I just feel like this again. Okay. So whenever this vibration just starts, just tell yes. Okay. Don't wait for the more vibration. Okay. So just close your eyes. So at the level of 10, he is able to perceive the vibration. So again, at the level of 11 or 12, he is able to perceive. 6. So this is totally normal. And if again I am checking in this feet also. Okay. Okay. Just close your eyes. Are you feeling? No. So every time SAM test is necessary. Okay. SAM test means I'm just stopping the vibration and give here. So if he is telling he is feeling the vibration, then it is the patient may be confused somewhere. Okay. So every time the SAM test is necessary. Yeah, at the level of 8. So that means he is not neuropathic. Sir, are you diabetic? Okay, but your feet is completely okay. Just stay here. Okay. So these are two tests for the neuropathy test. Now we can perform the ABI or ankle brachial index. It ready for that? So the vascular assessment, these are the some vascular cases. So diagnosis of the peripheral vascular disease, we have to check first the patient come with some clinical symptoms like claudication. Patient often complain, I am not walk more than 100 meters or less than 100 meters. So that means there is the claudication. Clinical signs, examination. In examination, we often check the peripheral pulses, dorsalis peris and the posterior tibialis. And the most common test in this case is bedside test, ankle brachial index. ABI is the key to early detection and the management of the peripheral artery disease. So how we can check this? So, sir, I'm checking your feet. Okay. Just see, this is the dorsalis pedis, and it is palpable. And here the posterior tibial is just laterally to the medial malleolus. It is also palpable. Okay. So can you remove first you check the dorsalis pedis and apply some gel. This is the handheld Doppler. See, this is the sound. Now we inflate the BP cuff. Release, release. Chant. Aste chant. So at the level of 120, we can feel the systolic pressure. So we only measure the systolic pressure of the dorsalis pedis. Similarly, we measure the posterior tibialis. Yeah, this is handheld Doppler. You can see now infiltrate. So release. Nama. Our Nama. So around 130. So 130 plus 120, and we have to see the brachial systolic pressure. One. In 3 to 13% of the patient, dorsalis pedis are not palpable. So in this case, we only take the posterior tibialis. Sure. The sound will operate. So it is again 120. So dorsalis pedis plus tibialis, the systolic pressure divided by brachial pressure. Or sometimes we just calculate the dorsalis pedis divided by the brachial pressure. So 120 by 120, it is around 1. Okay. So what is the normal value of normal ABI value? Okay, so just it. So the ABI is systolic ankle pressure divided by the systolic arm pressure, and the normal is 0.9 to 1.3 is normal. So it comes around 1, so it is the normal. And if it is less than 0.7, it is mild, less than 0.4 to 0.69, moderate, and less than 0.4, it is severe. And if it is more than 1.3, then it is compressible, non-compressible arteries. So further, if ABI is not measured, if ABI is not measured, then we can go for the further evaluation like arterial Doppler, TCPA2, angiography, CT angiography, and MR angio. So this is the simplest difference between the neuropathic ulcer and the ischemic ulcer. By the skin, if we see the skin temperature in the neuropathy, it is warm, and ischemic foot is always cold. Pain in neuropathic foot, there is no pain. In ischemic foot, it is very painful. Sometimes patient is crying with pain. Skin coloration, there is no alteration in neuropathy, but in ischemic foot, there is a pinkish or bluish color discoloration. In neuropathic foot, there is it occurs always on the high pressure area, so there is a formation of thick callus. But in ischemic foot, it always arises at the margins, so there is no callus formation. And the peripheral pulses palpable in neuropathic, but it is feeble or not palpable in the ischemic or ischemic foot. And ABI I already mentioned. So the basic principle of the diabetic foot management is the adequate debridement and infection control, adequate vascularity, and adequate offloading. So this is a simple neuropathic case. A patient came with the non-healing ulcer on the third empty head, and we just debride, just shave the callus and give this type of offloading. I will show you this type of offloading, and the ulcer healed just within the 2 weeks. So how to perform the callus? See, in this way, we just remove the callus. Yeah, change for it. Change it in the kitchen. You can't check change for it. Yeah, thank you, sir. So if you see how to hold the foot, just like in this way. Never put your hand like this, otherwise you will injure yourself. Okay, so hold this in this way and just remove the callus in very small pieces. Just remove the callus in very small pieces. Sometimes you can see I just make this like a hemorrhage. So you have to remove the hemorrhage inside the callus. And like this, you have to remove the callus. And after removing a little bit, you can just feel whether it is smooth or not. So if it is not smooth, then it will create more pressure and there is a chance of ulceration. So you can remove like this. Yeah. So like this, you can remove the ulcers. So in diabetic patient, the nail is nail cutting is also very difficult. So this is the nail niggler, or we call as the bone cutter. It is bone cutter, and after cutting the nail, you just file in one direction, not in the both direction. So next. So we have already shown how to check the ABI, and this is a simple case. Patient come to us with the gangrene of the third toe, and ABI is unrecordable. We performed the angiography. There is a block, and angioplasty was done. And now, after angioplasty, after revascularization, amputation of toe is done, and the ulcer heal in 4 months. You can see in previous slide, I show you the neuropathic ulcer heal in only 2 weeks, but in ischemic ulcer, it is healed in 4 months. Next. Now the offloading. The diabetic foot ulcer frequently occur on the weight bearing areas. As I show you, the neuropathic ulcer are occur on the weight bearing areas, and this is required the offloading. Offloading means to relieve the pressure at the pressure point. So the aim of the offloading is reducing the peak plantar pressure, both vertical pressure and the horizontal shears stress at plantar pressure, and at the same time allowing the ambulation. So offloading modalities, there are various types of offloading modalities like irremovable and removable. But frankly speaking, offloading always, before giving the offloading, always ask the patient what type of daily activity and what type of job he is doing, because offloading is according to their personal choice. So these are some irremovable, like total contact cast and total contact cast with window and instant TCC. And the removable devices are removable TCC, pneumatic walkers, crow, AFO, and other modified footwears, and most important is the indigenous offloading techniques. So these are the most common method of offloading. Bed rest, it is not practically possible. If we say, just lie down 3 months on the bed, then it is not practically possible. And wheelchair, but our homes are not so spacious so that we can move with the wheelchairs. Crutches, these are very good modalities, but the problem is it requires a lot of education and lot of experience to hold the crutches, and it requires a lot of balance in the hand. These are the other offloaded. This is total contact cast. This is the gold standard total contact for the offloading of the neuropathic ulcer. Felt foam dressing, half shoes. This is the gold standard total contact cast. We generally applied in the Charcot foot. And this case comes to us with non-healing neuropathic ulcer on the heel area for more than 4 to 5 years. And we give him modified total contact cast with window. In this case, what we have done, we make a insole, like just this MCR insole, and make a window at the ulcer area and give the cast. And every 4 to 6 weeks, we have to change the cast, because there are lot of exudates coming from the wound. So it may emaciate the ulcerated area. So we have to change, and ulcer is healed in the 6th month. Offloaded shoes. So this type of footwear, this is the front offloaded shoes. You can see there is no insole in the front area. Okay, suppose if the ulcer is in the great toe or in the forefoot, then we can give this type of footwear. We can provide this type of footwear. And this is the mid foot offloading. If the ulcer is in the mid foot, then we can provide this type of footwear. And this is the hind foot offloading. If the ulcer is the heel area, then we can provide this type of footwear. But the problem is this is applicable only if the patient is wear the footwear. Generally in our city, patient, they do not like to wear footwears in their home. So at that time, offloading is not done. Okay, and the hind foot offloading is very dangerous until and unless the patient is walk with a walker. We always advise to walk with a walker, otherwise patient may fall in the back. So always ask to walk with a walker. So this is an indigenous technique of offloading, and we are presenting some papers on this. This is based on the Samadhan system. In this offloading, what we have done, we just take a simple unsterile, just found in the bedding shops. Just we take 10 by 10 foam, we just roll it. We just roll it, stick with the micropore, and then roll with this simple gauge piece. So this is the indigenous technique of offloading, and apply on the foot. Suppose the ulcer is in the great toe, then we can give only the one offloading. And if ulcer is in the empty heads, then we can give this type of offloading. You can see there is no pressure at the ulcer area. Okay, and ask the patient to change themselves. We always teach the patient how to change their dressings. So this is the front offloading and mid offloading. And some patient, they are sitting on the floors by the cross legs, and there is a chance of formation of ulcer at the lateral malleolus and sometimes in the little toes. So you can see this type of ulcer, and in that case we only give this type of offloading with the foam. And always ask them to change their behavior to sit in the cross leg. So footwear, objective of the footwear to reduction of the shock and shear forces, accommodation of the minimal deformity like hallus valgus and hallus varus. So just accommodate the minimal deformity, preventing recurrence of ulcer, and footwear. First aid, prevent, therapeutic, and customize. So less than 5% of the person needed the customized footwear. Most of the person needed the therapeutic footwear, and the normal patient who doesn't have any neuropathy, or any deformity, they only require the normal footwear with a wide toe box or some kind of this sports footwear. So the characteristic of the diabetic footwear, you see, the to redistribute the high plantar pressure and reduce the shock and shear forces. And the this is the type of diabetic footwear. You see, the toe box should be wide enough. Okay, the toe box should be wide enough so that all the toes are lying just like this. No, there is no overriding or overcrowding of the toes. And the footwear should be with extra depth so that it can accommodate the insole, and the insole will be 8 to 10 mm thick. Generally in our shoes or footwear, this type of insole is not there. So in diabetic patient, this type of insole is very important so that it can reduce and redistribute the plantar pressure. And the heel counter should be rigid and the outer sole should be rigid so that no foreign body can prick. Okay, and always remind that the footwear should be Velcro adjustable so that with dressing it can accommodate. If there is no dressing, then you can wear like this. If there is lot of dressing, you can lose it in this way. Preventive footwear like sports shoes and shoes with the white toe box. Therapeutic footwear, these are all the therapeutic footwear with all Velcro adjustable, and it can accommodate the minimum deformities. And 5%, or you can say less than 5%, those required this type of the customized footwear. These are the different types of insoles. This is the silicone insole. It is very costly and may wear out within 1 or 2 months. So it is not advisable to each patient. This is Plastajot insole, triple layer Plastajot with the this arch support, and this is microcellular rubber. These are the different types of insole, and this insole is very costly and important. See, this is the healing sandal. This is healing sandal, and this is the healing insole. Suppose the patient's ulcer is in this side, then you can remove this part. So there is no ulcer. And again, when the ulcer is healed, then you can put this piece. So this is the ulcer management insole, healing sandals. So for the foot care, we always ask to check with type of mirror. So always ask, take the small this mirror and see the plantar surface of the foot. You can see, if you can, anybody can see this plantar surface of the foot. So always ask the patient to take not this type of mirror, at least a small mirror they can use to see the plantar pressure. And always check in between the toes. In between the toes, you should dry enough, and always check in between the toes. And the mass education is very important. We are organizing CME for the patient in every month and give this type of footwear and foot care teaching. So video is not running. Can you click once? This is not running. Okay. So we are giving the training to not only our paramedics, also the our patients and patient members. So regarding foot care and foot care, examine the foot regularly and see with this type of mirror, and regular wash with the normal water. And if you use lukewarm water, then again check the temperature before using it. and do not walk barefoot even in the in-house. So best time for the evening, in the evening time. So always purchase the footwear in the afternoon or evening time. Cut the toenails straight away and file with the nail filer. So this is our podiatry kit. You can see this is our podiatry kit, and this is the nail niggler. We are using this type of cutter to cut the nails. Okay. And after cutting the nail, you just sharp the margins. You just sharp the margins like this, and always in the single way, not like this and this. Okay. And do not use any type of this corn cap. You can see this is a patient using the corn cap followed by this type of maceration or emaciation of the toes. And use the moisturizer. In the season, we always ask to use any kind of moisturizer in the foot, but avoid to use in between the toes. These are some simple equipments. Those we are required for the to start the diabetic foot clinic. You can see most of them. Only this is the this is left. This is called the infrared thermometer or the glucometer of the feet to check the temperature of the feet. So this type of leaflet we give the patient how to take care of foot, and we first ask them to take care of feet just like your face, and what to do and what do not do. These type of leaflet we are providing. So initially we are for the newcomers, we ask them to practice on the potato or this Mausami lebu, or you can try on this type of models. So as I first told you that there is no structured podiatry course in our city. So first time in West Bengal, ILS hospital starts a podiatry course for the paramedic. This is the brochure. So ILS hospital first starts this course at ILS hospital Salt Lake, and you can send your paramedics for the training. See, it is the 4-month course. Once in a month their class will be offline, and once in a month there will be one class for the 5 hours. So that means total course is of around 20 hours. So ADA recommendation, all individual with diabetes should have annual foot examination, including assessment of sensation, vascularity status, and skin integrity. And patient with neuropathy should have visual inspection of feet at every visit with healthcare professionals. Most patient with one or more risk factors should be evaluated more frequently. And to summarize my talk, periodic examination of foot is mandatory in all people with diabetes. Early identification of foot problem can prevent major events or reduce costs. Identification of high risk foot is possible at primary care center, and education of physician, paramedics, family members, and all caregivers, they should need the education for the prevention of the foot complication. And educators and paramedics are the most important pillars in the management of the diabetic foot. And dear friends, foot care and footwear is not only important in this time, it is coming from the ancient era. So you can see the Bhagwan Krishna is taking care of the foot of Sudama, and Bharat helped to wear the footwear of Ram. So thank you for hearing me. So we always teach the patient family member do this type of dressing by any compounder or somebody. Thank you.
Swim Beta helps in the prevention and remission of diabetes.
Swim Beta reduces insulin resistance, fasting blood glucose, postprandial blood glucose, and HbA1c. Cresvin Beta, the beta cell savior, beyond glycemic control, is recommended in type 2 diabetes mellitus, pre-diabetes, and diabesity.
Thank you, madam, for that wonderful and insightful workshop. And it was indeed some great things we all learned from you. And hopefully this will help all of us in giving proper care to our patients. So with that, since we'll have our next session from 3 p.m. onwards, we'll have a short break. And following that, from 3, we'll start our next session. Since our next session is from 3 p.m., if anybody hands-on experience on how diabetic foot and its related things are done, madam is already here, so you can have a look at that. Thank you. Once again, thank you, Madam Raki Srivastava, for your wonderful, insightful talk and this workshop. I would now like to request Dr. Rajan Palui on behalf of Bengal Diabetes Foundation to kindly felicitate Madam.
Cresvin Beta helps in the prevention and remission of diabetes.
Cresvin Beta reduces insulin resistance, fasting blood glucose, postprandial blood glucose, and HbA1c. Cresvin Beta, the beta cell savior, beyond glycemic control, is recommended in type 2 diabetes mellitus, pre-diabetes, and diabesity.
Cresvin Beta helps in the prevention and remission of diabetes.
Cresvin Beta reduces insulin resistance, fasting blood glucose, postprandial blood glucose, and HbA1c. Cresvin Beta, the beta cell savior, beyond glycemic control, is recommended in type 2 diabetes mellitus, pre-diabetes, and diabesity.
Cresvin Beta helps in the prevention and remission of diabetes.
Cresvin Beta reduces insulin resistance, fasting blood glucose, postprandial blood glucose, and HbA1c. Cresvin Beta, the beta cell savior, beyond glycemic control, is recommended in type 2 diabetes mellitus, pre-diabetes, and diabesity.
We'll start off our next scientific session in around 5 minutes from. I'll request all the delegates. So please come to the central hall and take your position, please. Thank you.
Crispin Beta helps the prevention and remission of diabetes.
Crispin Beta reduces insulin resistance, fasting blood glucose, postprandial blood glucose, and HbA1c. Crispin Beta, the beta cell savior, beyond glycemic control is recommended. Type 2 diabetes, pre-diabetes, and diabetes.
Good afternoon once again. And now we'll resume our scientific sessions. So we have 1.5 day long scientific sessions and lots of interesting topics on diabetes, its dilemmas and treatment. So I would like to start by introducing our chairpersons for the next session. Dr. Amartya Shankar Chaudhuri, consultant endocrinologist at the Mission Hospital, Kolkata, Durgapur. Dr. Krishnendu Goswami, consultant plastic surgery department from the Mission Hospital, Durgapur, and Dr. Shobhik Roy, who is consultant physician at the DSP Hospital, Durgapur. I would now like to request all of them to please come on the dais. And I would like to request the chairpersons to please introduce the speakers for the session.
A very good afternoon to all of you. We had an excellent start for the conference with a great talk on the diabetic foot care, the nitty-gritties and how to prevent the small things, everything explained in detail. I must thank Madam for that. And to continue with the topic, now we will have a detailed discussion on the surgical aspect of the diabetic foot. We have with us Dr. Sudhir Kumar Jain, a rare, dedicated surgeon who cares only for the diabetic foot. As a surgeon, we all treat diabetic foot, but that's part of our practice. But we have with us Dr. Sudhir Kumar Jain, who treats only diabetic foot. I'm sure we all will be enlightened with his thoughts and insights. I would like to welcome Dr. Sudhir Kumar Jain to the stage.
I think I'm audible to everyone. It's a very difficult time now. You see, to open a scientific session like an opener is almost as difficult as to open a T20. You know, the opener gets a lot of problem in opening the this cricket matches also, and that opener batsman has to also face a lot of bouncers and you know, the furious pace of the fast bowlers. As the audience, I think they may do the same job. But the thing is that opener always takes some time to settle down. So I hope that if I'm not settling down well, please give me a little bit of more extension of time. But if I made out, then of course I will be sitting down with you. In any way, dear friends and chairpersons, sirs, the topic is challenges and solutions in diabetic foot. And I think nobody will like to have slides of left-hand side. The discussion should be more like a soap opera type of discussion. I think you will like all this thing. And neither I am here to speak on the diabetic food. I am here to speak on the diabetic foot. And I have seen in my 25 years of a long journey in the diabetic foot management, the beautiful diabetic foot of, and as well as the horrendous diabetic foot. So why diabetic foot knowledge is important? That's the first thing. Because this is the most dreaded, common, expensive and least understood problem. And it leads to loss of limb, life and productivity. And we can say it's a silent killer of the mankind. Everybody knows about all these data. So I'm not going to repeat, but only thing remember, if we are managing 80 million diabetic patients right now, in relation with the fit, it is 160 million fit at risk. So our work is more than what you are doing. I think we have to manage 160 fit of these diabetic patients. The lifetime incidence of diabetic foot in diabetic patient is about 25%. Prevalence of diabetic foot in India is around 5.1%, and 60% of non-traumatic amputation occurs in diabetes. 85% diabetic foot amputation takes place after a trivial foot injury, which is preventable always. And mortality after first amputation is around 20 to 50%, and 58% needs again the contralateral foot amputation. This is another very challenging task because the amputation is not the answer of the diabetic foot management. And around 35% of the income, monthly income, has to be spent by the diabetic patient if he develops a diabetic foot ulcer. The financial burden, if you consider that most of the patients, they don't have the medical facilities. It goes in lakhs when you manage a diabetic foot patient. And every 30 seconds, even some says 20 seconds, a diabetic foot is being lost in the world because of the infection. And this is the pathetic end. A diabetic foot patient, rather than taking the services of a trained surgeon, he took the service of a trained Indian Railway to get his foot guillotined because the cost of the amputation was too heavy for him. This is a true story, which we have read in one of the newspaper. Friends, what is human foot? It's a miracle, we can say, with having 26 bones, 29 joints, 42 muscles, 44 tendons, 100 ligaments, and it travels around 1.5 lakh kilometer in its lifespan, which is around 4 times the circumference of the earth. Now, what is the diabetic foot then? Well, in brief, any ulcer infection below the level of the malleolus ankle in a diabetic patient who has got neuropathy and some sort of vasculopathy with metabolic consequences is called diabetic foot. Pathophysiology, I think you know better than me. If you summarize, there is a neuropathy leading to deformity, dryness, loss of sensation, vasculopathy, loss of blood circulation, and hyperglycemia that leads to the high blood sugar, and the bacteria likes the sugar to eat and they flourish like anything. So one of the neuropathy is sensory neuropathy, what is called loss of protective sensation. So patient doesn't know when the trauma has occurred. And in our Northeast, we have found that around 92% of patients, they belong to the neuropathic category. The second neuropathy is motor neuropathy, which leads to the deformities of the foot. This deformity with limited joint mobility problem, it leads to high pressure joints, and then it leads to callosity. The callosity gets burst and leads to ulceration. So that's a very much, we can say, preventable thing it was. Biomechanics, in a short, we can say that the pressure exerted on a particular part of the foot is equal to the force divided by the area. Now, as the deformity develops, the area will shrink. And ultimately, the force in a particular the lack of sweat, leading to cracks and fissures, and there invites the infection inside. So we have seen the autonomic, the motor, and the sensory neuropathy. So what we observed in a study we did, some of the intrinsic factors are there, which are related with the patient or his foot. And there are some extrinsic factors which are not related with the patient, but the environment or the ambience in which the patient lives. But the ultimate causative factor are these. May it be neuropathy, may it be vasculopathy, may it be anything, what precipitated the infection inside a diabetic foot are these things, you can just imagine. They lead to the actual entry of the infections or makes an entry through which the infection enters. They can be avoided, isn't it? So why there is diabetic foot infection? There should not be at all. It is we are treating the infection, but we are not preventing infection. We are not preventing diabetic foot to occur. What we have seen in young male, it is very, those who are aggressive, very lack of, there is time, they don't have time to consult a doctor. They don't take proper care of the foot. They use some improper footwear. There is a poor compliance. They have to remain busy in earning because they are the sole earners. The infection in diabetic patients who are young is usually devastating. But the good thing is that they recover fast because the comorbidities in these patients usually is less. Obesity, which leads to the out of touch syndrome, a pot belly persons can't bend forward and can't see what is happening in the foot. And if the foot is insensate, then again the problem is multiplied. Of sight, the blindness. So insensate foot injured, patient doesn't understand, out of the brain it was, and then he can't see also. So that is the problem, because the retinopathy in most of the patient you find is coexisting. Socioeconomic status, as we can see, the patients which comes to us so late, riddled with maggots and all these things, because they live in a humid atmosphere, they can't take care of the foot and all these things. So that is one important issue, the socioeconomic status. Now, dear friends, this is a slide which may give you some amount of the lack of awareness among the public. What they think, you should sugar control by eating less. You eat less, your sugar will control. That is one of the myths they have. If there is no pain, there can't be any septic. Diabetic food is incurable, like a cancer. You go on doing dressing. Diabetic food management is a dressing work. This is simple dressing, you do the dressing, it will work. And diabetic food sepsis to be treated by with blood sugar control and antibiotic ointments. More costlier, more better. More costly antibiotic, more costly ointment. Walking, running, jogging, good for diabetic, even when the foot is affected. Massage and hot fermentation, good for relieving pain and improving circulation. Foot bath, putting the foot inside a betadine, is quite often is seen and advised by the doctors also. Put the foot, sorry, I am sitting. Pata, gorom jole dhukaya rakho, what you call betadine hip bath. This is very popular among the doctors and the patients. This should never be done. Corn cap for removing of the corns. And canvas soft shoes are very good for the foot. Acupressure sandal, acupressure boards are very useful. They control the blood sugar. And after healing, there is no recurrence. Now, X-ray normal means it is toes are viable. Even if the toes are gangrenous, X-ray is showing a normal X-ray, it is normal. Moving toes means it is still alive. And taking tetanus toxoid, they are now immune to the infection. That means they will think that septic will not occur because I have taken the tetanus. So that is a level of awareness, what I should unawareness. And blood flows through the nerves. Somebody has got some problem with the circulation, he will say, my nerve has become weak, and he will go on taking this methylcobalt and all these things. He won't think of the vasculopathy is again an element. And they think that keep the wound open, let it become air flow, and it will dry up, it will heal it faster. And another thing is that without sugar control, no foot surgery is possible. You have to control sugar, and then only you have to go for a surgery. My dear friends, in India, we have seen this thing, the tradition, that even the animals, the Indian animals, Indian human beings, they all walk barefooted. No matter how many times you say them that you use proper footwear, they will never. The footwear visiting are the most good sandals. They are the most suicidal sandals and shoes for the patient of diabetes. The prick injury, which are forgotten for about 8 hours. You can see the needle pricked in the sandal, and she goes on walking for 8 hours without the knowledge because she was having loss of protective sensation and ultimately leading to the sepsis. And this is something of tobacco and smoking that, but possibly if you are using them, and if it is, it may also exaggerate the neuropathy also. Now, torturing the feet is quite common. The masjid people, the Muslim brothers sit in the namaz positions. Body warming. Bihu Gap means our festival in Assam, that when they sit in front of the fire. And temple visit without sandals. Recently, I am managing 4 or 5 patients who visited this, that Shivaji temple, and they got the burn injury because they were not using the shoes, and because they were asked not to use shoes, it will again, the gold will give cuts. And this is what you find in intratrigo, the fungal infection between the toes, mostly seen in the housewives, those who are working for pretty long time in the bathrooms and the washing utensils. Rodent bite quite often seen. And the lesson we have found that if you have this problem, you should pet the cat and net the bed. If you are using a mosquito net in the night, it is very hardly for the mosquito, for the rat to go and bite your insensate foot. So that happens. Overnight, what happens? Everything was fine. The next day morning, patient wake up and he found that all the toes are bleeding. Now, who came? A bhoot or a rat? So he remains in dilemma, and you have to think always, overnight developing something which it is a rate, 110% rate. And you find almost every month about 6-7% of rat bite. This is, of course, exaggerated picture to make you aware that even the cockroaches take this dinner, sorry, I mean the night watchmen, they come and they can even bite your toes. Superstition is quite is prevailing everywhere. This all, you know, that hair and the tabiz and gandak. And this is what they have tried with the chili. They use chili for healing. So I have coined a word called chili in healing. So this is the status of the awareness before they come to us. And this gentleman has gone beyond that to control both the diabetes with Karela and to take care of the food. He put the Karela inside the shoes. These are not fabricated, my dear friends. This is I have seen it. This is the level of awareness. And then we think that prescribing is prescription given is the most important thing. But remember that only paperwork doesn't work. You see the number of papers and documents the patient has brought to us, but see the condition of the patient's foot also. So I have coined a word called investigophilia. What you have to do is that when the patient comes with a lot of, bundle of investigations, the value is only much that you take a weight on a weighing machine and you say it's 250 grams. You just throw it out. Now you see the person who has gone to a doctor, a diabetic patient, he should have been examined. His feet has to be checked and touched this at least, but without touching, asking for MRI, CT scan, this NCV, this thing, that thing, does it justify? So paperwork doesn't work, and this is what is the value of the paper when the patient arrives to us. That is the only value. Everything done, but what was not done, that nobody has touched his feet, nobody has seen his feet. Dear friends, this was a patient who was treated but not motivated. A blanket of prescription has been made on the top of the patient's body, and see the condition of the feet. And this is what we require a MRI, CT scan, and all these things in this rotten foot? Nothing. Everything is visible. Why you ask a patient to go for MRI and CT scan if a person arrives in this condition? What's the fun? To take the commission. My dear friends, this is what you call the futile and fatal attempt. Trying with various ointments, especially the T-bags and the various antibiotics injections to treat a sepsis. Do you think it will work? Never. And the best, of course, antibiotic in our hand is a surgeon's knife. It is for us, of course. What we need is not to put pressure. If you ask a diabetic foot patient to do sirsasana, not to put pressure on the foot, that's good enough. That's good enough more than the giving antibiotic and ointment, because putting pressure means pumping infection inside in an insensate foot. So that's the thing. You just ask the do sirsasana. And this was the story of our various colleges and hospitals, that when you see a patient's number of the sequence in which the diabetic foot is managed in OT, it is the last one, and to be done under local anesthesia, and the work is this only. And previous to that, there is a lot many left poly, appendix, and gallbladder hernia. So this is the level of what I should be the care which we are giving for diabetic foot patients. And this is the fate of the diabetic foot surgeon. The anesthesia will turn his face away from the surgeon who is doing a very filthy work, dirty work, unnecessary work, and the sister will run away from the scenario. He will give you the dressing material and he will run away, because it is a dressing work. Why the surgeon is wasting time in this particular condition? We have done a study and we found that in PG's postgraduates, 89% they consider that this is simple a dressing work. And in nursing status, we found they told 98% only dressing work. There is nothing called surgical exploration. And why the postgraduates are not interested, I think it is because there is no endoscope business there. There is no scope for endoscope, so why we should make interest there, all this thing. Diabetic foot surgery is not a keyhole surgery, not fascinating. No? And outcome is very uncertain, is very filthy work, needs prolonged treatment, financial gain, hoga, nahi hoga. Work dignity is not there. And dressing work is a dressing work. Why you are wasting your career, my dear friends? And if you want to evaluate an intern, you just give him to treat one diabetic foot patient who who harbor so many comorbidities. If she or he can manage this diabetic foot patient, you can give a degree of MBBS to her or him. It's a fact. When we are measuring a diabetic patient, you can say so many comorbidity with which he or she is there. Ask one intern to manage. If second manage, okay, you have given the MBBS degree. Fine, dear friends, this is my future plan. The diabetic foot surgery dedicated full-time job, not a part-time and time pass job. So if this happens, I may have to create this type of sitting arrangement and eating arrangement and giving prescription management also, maybe in future. So what investigations? Just say, most of the investigations are not available. They are expensive or not affordable. They are inconclusive, consume time and this thing and makes us mislead us. What is practical advice? Blood biochemistry will let the endocrinologist, let the physician decide the routine blood and CBC, whatever he likes. Neuropathy. Now, why we have to go for NCB and neuropathy? When the patient is come to you late with lot of infection and he's coming on walking, and that means he doesn't have pain, it is neuropathic. If the foot are deformed, it's a motor neuropathy. So why you go for all these tests? Ischemia, if you don't feel the pulses, is ischemic. And if you find that the bone can be touched with some instrument, is osteomyelitis, why you need MRI CT scan? Well, this is an iceberg phenomena. You see this, do not rely on what we see. This gentleman, you see, the small infection that was seen. Now, this gentleman has so much of problem that started from the toe to the knee. We have to explore. This is what we call necrotizing fasciitis, and ultimately he regained his dignity, of course. So if you consider the small thing, it doesn't mean small, it may be very extensive inside. This necrotizing fasciitis is a very bad thing. Externally, you don't see anything, any ulcer, any wound. But if you see inside, gradually what happens, you see, the blister formation takes place, then gangrenous patches occurs. And this is how a volcano he was harboring. It was totally explored, debrided, source reduced, and ultimately he survived. So we have to think that even without ulcer, a patient may have severe sepsis in the foot or the leg. They are all deformed foot, no problem. They are all functioning foot. They can be used, no need for going for an artificial processes. So what's the problem with that? Because artificial process is not the answer for our Indian context. Now, if you see the delaying factors, patients are responsible, no doubt, because there was no pain, business busyness, slow learner, internet knowledge was there, this ointment will work, this antibiotic will work. For the internet, they get a lot of knowledge. No money, I don't have money. No awareness, no access to any medical service. But you remember the physician and surgeons are also responsible. We should do blood control first. We should try with antibiotics. We should give ointments, investigations. So I think that to a certain extent, we are also responsible for this day. 92% patients we see are neuropathic. And most of them are in grade 3 and 4, what we call Wagner's, the higher grades of infections. And this is the awareness level. 96% of patients who came to us with diabetic foot infection were consulting doctors, but 76% were not aware of what is diabetes, what is the foot care. So that's a very, what I should say, the etiology wise, okay, these are some of the etiological factors that I have seen. And most of the patients we treat, diabetic foot patients, they are psychologically upset. And we have to manage them very like a, they're very good human nature has to be put forward before you put your doctorate knowledge. And these are the mortality. You can see that the other than septicemia, the patient has succumbed. So that you have to remember that it is a multi-systemic problem and patient may die of some other disease also. Now we have our own answer to this problem because you can't follow the all Western protocols and these things. So what we did, we made this treatment is a teamwork. Every consultant, every physician, every surgeon, every person can contribute something to it. Patient don't have to run from one department to another department, one chamber to another chamber, this to that. Rather, the physicians, surgeons, and everybody, plastic surgeon, they should run and to a fixed patient. So that is very, very important. This is the word another I have point that is called footballing a diabetic foot patient. That's what I have seen in medical colleges when I was working there. A patient when come with a diabetic foot, he will be said, okay, you have a infection, you go to the general surgery. Surgery will say this will need plastic surgery, you go to plastic surgery. You have both bone involvement, you go to orthopedics. You have vascular problem, you go to cardiothoracic. You go for endocrinology because you're diabetes. You go, your problem is with the heart, you go for cardiology, nephrology, and even ultimately one of my patients landed up to the psychiatrist. You are bothering us, go to psychiatry department. This is fact, my dears. This is fact what I have seen in the various hospitals and where I work. This is what you call footballing with a diabetic foot patient. You have to admit this. This is bitter truth. Again, right? And you manage diabetes. Constant hammering, repeated hammering required. Why it happened, how to get cure, and how to remain cured. We treat in under 3 headings. Why it happened, etiology. How to get cure, okay, we will make you okay. But how to remain cure is another problem. So these 3 headings has to be taken care of when you're doing. A foot temple has been created in front of our OT, and there is an ideal of a foot, not of Shiva and Ganesha or Hanuman. A foot has been kept there, and everybody goes and pray there also. And the thing, okay. And this is the Indian scenario, no? Don't throw garbage, fine will be 1,000 rupees. You will see most of the garbage will be thrown in that area. So what we do, we don't give this, do this, don't do this. We try with some controlled horror tactics. You see how we did? We have big billboards and banners in front of the patient waiting lobby. Says, keep your feet happy today or be ready to happy with in future. Choice is yours. Fine. The second says, love your feet today so that you don't have to hate them tomorrow. It works. Controlled, this is a controlled horror tactics. We have also a project called Project Charan Sparsh, the Hindu tradition of touching foot. When you are welcoming a person or when you are seeing a senior or anyone. So that is called Charan Sparsh. And there is a stepwise, some steps within 30 seconds, you can finish touching the foot in various levels and various stages. Now, what we say, that every doctor, every physician, when a diabetic foot patient comes, ask him to take out your shoes, lie down, take your socks off, touch his foot. The moment you touch, his mentality towards the foot will change. Automatically change. Oh, sir has touched. What's there? The load many factors, early conditions, like you say, the deformities, the fissure, the cracks, the dryness, the swelling, everything you can diagnose with the feet, with the hand, because your hand remains sensitive. So what we say, let the patient touch his own feet, number 1. Let the doctors touch patient feet, and number 3, let the relative touch the patient feet. So this is what will happen. Everybody will be touching everybody's feet. No handshaking, no this and hi, bye, and this is good morning, everything. No? So that's the way that we should revive our tradition. That is a Project Charan Sparsh. There is a Facebook there by the name of the same, which we have started and is getting good results. The way of welcoming a patient in is touching the foot, not by good morning, while the patient is standing up with infected foot and you are shaking hand. This is not the way. Let him sit in the wheelchair and say, touch his feet. That's the thing. And we always involve the attendant. We celebrate Diabetic Foot Day. This is being created by our own. This empirically one date has been chosen, 23rd April, which we magnify our diabetic foot activities. And what we think that in near future, maybe every day we should celebrate like a Diabetic Foot Day. This was the first time I think we have started recently. I think some organization started it, but you can choose your own day. It may be twice in a year, thrice in a year, and ultimately every day should be Diabetic Foot Day. That is what we think of. Written few books, and I have brought, but this is only in Hindi and Assamese. We don't have English versions. That's one. Talking is very important. You see, not talking is a problem. So you talk with the patient. Baat karne se baat banti hai. 70% of my time goes in talking, why it happened, how to be cured, how you will remain cured, how many sons you have, what you are doing, what foot we are using. So ultimately the patient gets, scared. Or why? What type of doctor he is? He's asking some unnecessary work. But that is important. That is very important. So talking, that is a forgotten art of the science, this medical, that should be done. That's very important. And they are almost, the depressed persons. Talk with them. That's very important. And touch the foot and touch the footwear. And you should apprehend the patient. All right, this doctor has touched my foot and he's asking my footwear to be also touched. What is the reason? Because by looking at the footwear, you can diagnose a lot many problems which the footwear is creating. What you call pedograph, na? Putting pressure and taking these measurements and giving in a graph and this and that and asking for 5,000 rupees doesn't require. You check the footwear of the patient, it will tell the story of the foot, what is happening in the foot. So that's important. And don't blame them. You have done the you motivate them, hug them. If possible, hug them. You know, now by MBBS, hug them. Hug them, it works. You said they are all depressed. They are all discharged from the financial, mentally, everywhere. Touch them, hug them, it works. This is what we try with the spreading the knowledge on Facebook page, which is totally dedicated for the diabetic foot patients. We do a lot of media work also. Speak whenever possible. Right now, I'm also doing the same work here. And we have another options of giving a good foot award once in a year. It matters are 50 rupees, 100 rupees, 200 rupees. A patient who has kept his foot most well, in a good position, the diabetic patient, you give him a 200 rupees price for your good foot maintenance. This is how you can motivate them. And being in medical colleges, sir, for 25 years, I am still having access to all the medical colleges in Assam. I am to go to Jorhat Medical College on 14th on World Diabetic Day. And you try to motivate these young generations that diabetic foot is a very important discipline, is a very important subject you should think of. Well, my dear friends, I think I have not made you bored, and let me conclude. Diabetic management, diabetes and diabetic foot are taking epidemic form. Diabetic foot is a real threat to mankind. There is a lack of awareness about diabetic foot among patients and doctors. Diabetic foot management is an art and science. Diabetic foot chapters and training to be included in undergraduate, postgraduate curriculum. To prevent a foot amputation and its dreaded consequences, we should pay more attention on prevention of diabetes, which I am trying to do now. Done almost 25 years in managing, saving food and this thing. What I have done? Nothing. It should have not happened. 85–90% of food can be prevented. So one should always try to save a diabetic foot, because a functioning foot is far better than a sophisticated ultra-modern processes in Indian context. If I say from Dil se, get yourself motivated before you motivate others. Use brain knowledge through heart care and concern. Cure must be everlasting. Invest time and resources in prevention. What we know beautifies when we deliver to common people. And be Indian, think Indian and do Indian. Motivate before you blame. Role of physicians, I think for you and all. Be the captain. You won't take the captaincy from you. You will be the captain, my dear friends. You physicians always remain the captain. Detect early at risk fit. And manage minor surgical work, which you can do very nicely. I think recently it was just previous to this, I was talking. Callus cutting, nail cutting, intertigo care, dressing work, and after healing phase, all these things you can do. Care of the fissure and cracks you can do by yourself. Fit care advices you can give. Footwear advices you can give. And refer early while keeping captainship intact. Your captainship never will be taken away by a surgeon. I am the first person to say, this endocrinologist, he is going to look after you. He is the captain. You ask whatever question you want to ask other than the foot. So you can keep your captainship intact also, and you can refer it also. And never refer with a common comment that problem will be solved with dressing only. That's another problem which we face when the patient comes to us, that somebody has sent this patient to you because you do a very good dressing. It's not like dressing only. Oh, dear friends, this is 2 last slides that let's wait before it is late. The handkerchief which I removed from one of the patients who ultimately went for a amputation. No, it was saying, I think something was written, "I miss you." So that handkerchief which he was carrying has been proved. Yes, now the foot will be missing from him. So importance of foot is only felt when it is lost. So dear friends, stop occurrence to prevent recurrence. It's a theory. If you don't want if there is no problem is arising, there will be no chance of any recurrence. And be a hero among the mass. If you treat a diabetic foot patient, you are no way you are down, you are inferior to a plastic surgeon or a onco surgeon or this. You are also a hero. Hero for that family, for that patient and for, I think, the whole of the nation. So, dear friends, if last I say, how is the Jaws now after listening to this, my long, lengthy, if I ask you, how is the Jaws? Thank you very much. Thank you very much. Nice.
Thank you, Professor Jain, for an amazing presentation. And I think we'll have question and answers at the end of the session. So
I
you
don't
can,
think there are any questions, but I am ready to give answers.
anyways, thank you. So we can move on to the next session. Can we have the next faculty slide, please? So the next talk of this session, we have holistic management of type 2 diabetes, role of sitagliptin. For this, I would like to welcome Mr. Dr. V.K. Dhandania. Dr. Dhandania is a senior consultant physician and diabetologist at Ranchi. Sir, please.
Good afternoon. Thank you, chairpersons, for that very kind introduction. After 25 ball century by Dr. Jain, it becomes very, very difficult to follow up for the last couple of overs which are left for me. And the way he has presented is really remarkable. He really presents from his heart, and he has got a very, very big corner for diabetic foot patients. I heard him recently, even in Diabetic Foot Society of India and even in Chennai. He's a real, very, very dedicated soul for diabetic foot patients. I'm going to talk on a topic, role of sitagliptin in the management of type 2 diabetes continuum. And we all have been using sitagliptin for last 10 years or more. We are using more and more sitagliptin these days because it has come to a price control, and that has really helped both the doctors and the patients in the treatment of type 2 diabetes management. We are seeing a lot of diabetic patients recently, and I'm sure everyone is feeling the surge of diabetes after COVID. Post-COVID, there's an increased surge of diabetes, especially in the younger population. And the recent IDF Atlas very categorically places our ranks as a second position, which is really not good. And even the projection is very, very so we should all try to treat diabetic patients, first prevent the complications, and second, even prevent newer onset diabetes as well. Recently, we have started in our clinics that whenever a attendant comes with a patient in the clinic, the attendant undergoes a 2 minutes counseling and a blood sugar test and a BMI test. And we tell them, you have a patient in your family who is a diabetic, so you equally have a very, very high chance of getting diabetes. Your BMI is 26 and 27, try to bring it down. And you have a blood sugar random, which is beyond 140, so you should be very, very cautious. And little talk about diet and little talk about exercise and regular exercise. So probably this is going to be a little addition in prevention of new onset diabetes in the community. The number is expected to reach 124 million by 2045, and this represents 10.4% of the India's population in this age group. So this is an exponential increase, and there is a very characteristic which has been seen today: lower BMI, increased body fat, and a very early onset. I mean, it's been seen that it's 2 decades earlier than the West. And the increased clinical and biochemical measures of insulin resistance and systemic inflammation, things like CRP, HSCRPs are increased. And a lot of patients have acanthosis at a very early onset of the disease, coupled with one of the highest global rates of pre-diabetes progression to type 2 diabetes. Almost 14 to 18% of our pre-diabetic patients progress very fast to diabetic to frank diabetes compared to Finland and US, where it's 6% and 2.5%. So it's very important that when you see a pre-diabetic patients, don't give them a casual advice, intensify your advices as far as lifestyle management is concerned. The young population is mostly affected, and there's a very early onset. You need to treat them very aggressively. They are really very, very careless, as we heard in the last lecture. Once they are controlled, they forget to follow up. tell them you have to live more life with diabetes. If I get diabetes at the age of 25 and 30, I have to live at least 40 to 45 years with diabetes later on. So my chances of getting both micro and macrovascular complications is very high. So we need to intensify treatment from the very early onset of disease. Young adults with diabetes and especially young women have a 14-fold increased risk of MI compared to patients with usual onset type 2 diabetes. So this is the Defronzo octet, which we have been seeing since 2009 when it was first spoken at the Benton's Best Lecture Award for Defronzo. And we all know that DPP-4 inhibitor is one drug which takes care at all levels from glucagon secretion to insulin secretion to incretin defect. So there's a lot of this octets is been addressed by DPP-4 inhibitors. And how do you differentiate between DPP-4 inhibitors and GLP-1? Except for semaglutide, most of the GLP-1 are injectables. And both of them basically increase insulin secretion. Glucagon secretion is been suppressed. Postprandial glucose has been reduced by both of them. Appetite, there is no effect of appetite by DPP-4 as compared to GLP-1. Satiety, there is no change of satiety by DPP-4, whereas GLP-1 actually increases satiety very, very early. So it helps in weight loss. Gastrointestinal adverse effects, there is rare to none. Sometimes patient starts getting GI side effects after 6 or 8 months of therapy. And GLP-1 basically causes early abdominal fullness and nausea. Gastric emptying is delayed by GLP-1 receptor agonist, but there is no effect by DPP-4. DPP-4 are body neutral, whereas GLP-1 receptor agonist actually causes weight loss. And another advantage is that the CV outcome trial, we see benefits with GLP-1 receptor agonist, which we don't see with DPP-4 inhibitors. DPP-4 inhibitors are actually having non-inferiority in the CV outcome trials. Now, what is the role of SGLT2 inhibitors in the era of role of DPP-4 inhibitors in the era of SGLT2? We have a lot of data to support sitagliptin versus metformin, and we have very interesting data. When HbA1c is lesser, you get lesser reduction in HbA1c by the drug. But when your HbA1c is more than 8% or more, you get better HbA1c reduction by sitagliptin, almost 1.2%. So the incidence of even hypoglycemia is less with sitagliptin compared to metformin. The incidence of GI-related side effects is less with sitagliptin compared to even metformin. Sitagliptin is very well tolerated. And if your patient gets GI side effect with a combination of sita and metformin, you can try stopping metformin and continue with sitagliptin. Most of the times patients start tolerating this particular drug. Sitagliptin was found to be non-inferior to metformin in improving HbA1c in treatment-naive type 2 diabetic patients, which was generally well tolerated with lower incidence of GI-related adverse experiences. Even with sitagliptin versus glimepiride, if you see there is a very similar efficacy as far as HbA1c reduction is concerned, but as the incidence of hypoglycemia is much less, and the incidence of weight gain is much less with sitagliptin compared to glimepiride. So hypoglycemia was reported in 7% in sitagliptin group compared to 22% in the glimepiride group. Addition of sitagliptin to ongoing metformin monotherapy provided similar A1C lowering after 30 weeks of treatment compared to addition of even glimepiride. So even in combination with glimepiride metformin and combination of sitagliptin metformin has a very, very similar efficacy. Now we have been using this fixed dose combination since long time, sitagliptin and metformin, and it's a very robust data, a very good HbA1c reduction. When you have someone with a median HbA1c of more than 9.7%, your HbA1c reduction can be as good as 3% in this class of patients. So this is what is very, very important to understand, that the fixed dose combination gives a very robust A1C reduction with higher value of HbA1c at baseline. Body weight change from baseline was also seen after probably more than 5 or 6 months of therapy, very marginal 1.6 kgs, which was not very, very significant. Patients can have abdominal pain, diarrhea in some patients with this combination. The greatest mean HbA1c reduction was 3.6% with this fixed dose combination. And in type 2 diabetic patient with a baseline of more than, with a baseline of 7.5 to 9, substantially more achieve the A1C goal of less than 6.5%. So patients who have a very, we have a very good number of patients who are at the time of diagnosis who fall into this group of 7.5 to 9%, and they can do remarkably good with this combination of drugs. Even sitagliptin can be combined with pioglitazone. Who are intolerant to metformin, you can give this combination. We have very good data to suggest that there is a very significant HbA1c reduction of almost 2.4% versus 1.5 with only pioglitazone. And both fasting and PP as well as HbA1c reduction is there, and there is hardly any adverse effects with this class of combination. And if you recently, the defronzo combination was actually with metformin and a pioglitazone and a GLP-1 receptor agonist. If your patient is not affording GLP-1, you can use sitagliptin instead of GLP-1. They all act at the level of beta cells. They actually improve the beta cell function. They take care of the insulin resistance, and this combination is a very, very robust HbA1c reduction without causing much of hypoglycemia. So sitagliptin monotherapy in elderly patient, this is a drug of choice. DPP-4 inhibitors are very, very safe, and it can be used in almost each and every elderly patients with and without comorbidities. And if you see the reduction in A1C is very, very good. And the best part is it does not cause even much of hypoglycemia. You can safely use in all your patients who are elderly. And it can be used at a very early onset of disease as well, from the onset of disease. So you can see that HbA1c less than 8%, between 8% to 9%, and more than 9%. At each HbA1c, you get a very good reduction in HbA1c. And even patients feel very, very comfortable, and you are very sure of not having much of hypoglycemia with this class of drugs. And even patients who have a lower eGFR, you can use drugs, DPP-4 inhibitors like linagliptin very, very effectively in elderly population. So patients in the sitagliptin and placebo groups had similar rates of adverse events overall. Serious adverse events were reported in 6.9 to 13.5% respectively. No adverse events of hypoglycemia were reported. So sitagliptin treatment significantly and rapidly improved glycemic measures and was well tolerated in patients even more than 65 years of age. So this is the total number of patients who were studied, and there was hardly any side effects. When compared with sitagliptin and dapagliflozin on patients who were already on metformin plus minus sulfonylurea with mild renal insufficiency, again in this class of drug, if you see that the adverse effects which was seen with this DPP-4 compared to SGLT2 inhibitor was very, very mild. And in type 2, all the type 2 diabetic patients, even the elderly with mild renal insufficiency and inadequate glycemic control on metformin plus minus sulfonylurea, treatment of sitagliptin proved efficacious and safe compared to dapagliflozin in glycemic control. So to conclude this part, extensive clinical trial and real world data has firmly established the glycemic efficacy of sitagliptin as monotherapy, initial combination therapy, or add-on combination therapy with other OH in adult patients with type 2 diabetes. The safety and efficacy of sitagliptin can be seen in obese patients, elderly patients, patients with varying degrees of renal impairment, along with type 2 diabetes. And sitagliptin is generally well tolerated, with most adverse events being of mild to moderate intensity, and relatively few patients discontinuing treatment without these effects. Even the CV outcome trials, which we know from sitagliptin, is the TCOS study. And TCOS study very clearly suggested that that sitagliptin is non-inferior, and it can be used in all your type 2 diabetic patients with comorbidity like CAD, even with reduced ejection fraction. There is no contraindication of sitagliptin. But if you see the FDA black box, it actually gives a warning for almost all the DPP-4 inhibitors for risk of heart failure after the saxagliptin data. So among patients with type 2 diabetes and established cardiovascular disease, adding sitagliptin to usual care did not appear to increase the risk of major adverse CV events, hospitalization for heart failure, or other adverse events. The complementary glucose lowering activities is also very, very interesting with DPP-4 and SGLT2, because they have different mechanism of action, and they actually have synergistic benefits which they give. SGLT2 inhibitors, we know it has a side effect of basically increasing the glucagon, which can be actually taken care by DPP4 inhibitors. DPP4 inhibitors actually act at the level of islet cells, whereas SGLT2 inhibitors are independent at the level of beta cells. So they have a synergistic effect. One actually reduces weight, and when one is weight neutral, so you can have a synergistic benefit in most of our type 2 diabetic patients in combinations with metformin early in the course of disease. So SGLT2 inhibitors plus DPP4 inhibitors, change in HbA1c from baseline versus DPP is a very, very robust data again is of as far as reduction in HbA1c is concerned. And again, there is a change in HbA1c from baseline. Again, if you if you use someone with a HbA1c of 8.5 and beyond this combination of drugs, you get a very, very good data. Very almost 60 to 70% of your type 2 diabetic patients can achieve a target of less than 7%. So this is a change in A1C from baseline according to baseline A1C versus DPP. The combination is definitely better than the individual drug. So you can see right here, patients who were only on DPP4 inhibitors, and when the combination was started up, they had a much better HbA1c reduction. Same with SGLT2 inhibitor, when you give as a therapy alone, without DPP4 inhibitors and in combination, you get a better HbA1c reduction. So we all know that this combination is very, very useful in clinical practice. Even the chances of adverse effects is less, and the chances of genital side effects is also less. So this combination is very, very useful, and we have been using this for last, I think, 4 to 5 years, definitely as a fixed dose combination. So relatively lower risk of UTI, lower risk of genital infection, and the adjusted mean change from baseline A1C for entire patient population, if you see, is much, much high. So this is why this combination is coming up very, very strongly. And the important thing is the cost of therapy has also come down, and the availability of this combination has become much, much more. Earlier, the multinational never have a penetration in the periphery as far as the availability is concerned. So with more and more companies coming up with this combination, we have good availability and more uses of these drugs. The benefits can be provided to more and more patients at a very early course of the disease. So adverse events were balanced between the groups, and discontinuation rates were low. At week 48, signs and symptoms suggestive of genital infection were more frequent with DAPA than with the placebo, and signs and symptoms suggestive of UTI were balanced between DAPA and placebo. So this result suggests that in patients with type 2 diabetes, inadequately controlled on CETA plus or minus metformin, add-on treatment with dapagliflozin provides additional clinical benefits and is very well tolerated. So decision making is very, very important in clinical practice, and this is how we can actually initiate with lifestyle modification along with metformin in treatment-naive patients where metformin is contraindicated, intolerant, and HbA1c is more than 8%, or in treatment-naive with metformin and uncontrolled on metformin monotherapy. So these are the patients who can be very well started on this combination of SGLT2 inhibitors and DPP4 inhibitors. Secondly, uncontrolled on metformin plus second-line drug, you can always add on this drug DPP4 or SGLT2 when HbA1c is more than 7.5. So for example, patient is on sitagliptin and metformin, your HbA1c is 7.5 and more, you can add on an SGLT2 inhibitors. So vice versa for SGLT2 and metformin. So these are very good indications in clinical practice where it can be used at different times at different HbA1cs. So to conclude this presentation, DPP4 inhibitor, sitagliptin, is widely used in the management of type 2 diabetes. It can be prescribed very safely at all stages of diabetes with and without comorbidities. It can be combined with almost all the available OHAs except semaglutide. It can be even used safely in hospitalized patients. It has robust safety data in clinical practice. DPP4 inhibitors should not be prescribed in pregnant and lactating mother, and it is contraindicated in patients with pancreatitis. So I thank you all for your patient listening, and I thank the organizers for this opportunity. Thank you very much.
Thank you, sir. Thank you for your very informative deliberation. Our next speaker in this session is Dr. Anirban Majumdar, and he'll be speaking on anemia in diabetes. Dr. Anirban Mukherjee Majumdar is a professor in KPC Medical College and Hospital, Kolkata. And Dr. Majumdar, please.
Good afternoon. I convey my sincere thanks to the organizer for this invitation. Today, I'm going to talk about the anemia in diabetes, very small topic. And what I mean to say that all of us actually don't recognize anemia among our diabetic subjects. It remains undetected and therefore untreated. So this slide is basically my take-home slide. Number one, that we should check anemia among our diabetic subjects, which usually we don't do. And second, that if you have detected that there is an anemia, we should treat the patient. And third, if you treat the patient, you can actually improve the quality of life. So this is the message I would like to convey to all of you, that please check anemia. We are actually more or less bothered about the heart, kidney. So these are the big issues. Anemia is a very small issue, but we usually don't recognize this anemia. It remains undetected and therefore untreated. Now, if we look into the relationship between anemia and HbA1c, that is another important issue that we have to understand, that especially if a patient has got a iron deficiency anemia, then HbA1c level is slightly higher because the red cell lifespan is higher if the patient has got a iron deficiency anemia. So when you are actually diagnosing a diabetes on the basis of HbA1c, be very careful, because there is a possibility of overdiagnosis. And second, when you are actually targeting HbA1c as far as your diabetes management is concerned, and if you have iron deficiency anemia in the backdrop, you may land up into hypoglycemic episode because your target is too tight. So therefore, be careful about the anemia, correct it. Commonest one is definitely the iron deficiency anemia. So correct the iron deficiency anemia, very easy. I think all of you are aware how to correct iron deficiency anemia. But the issue is, I am standing here in front of you just to raise this awareness that be very careful about the anemia and please correct it. Now, I will talk a little bit about the prevalence and then what the anemia can do as far as diabetic complications are concerned. Little bit of pathophysiology, my 4 cases, and the take-home message. So number one is the prevalence. I think this is basically data from India. So I usually always try to show the data from India only. I don't prefer to show the Western data. So if you look into the data, the prevalence is roughly around 20 to 50%. And if it is pregnancy, then the possibility may be much higher than even 50. So therefore, it is quite prevalent. So whether you patient have diabetes or do not have diabetes, there is a lot of patients who actually we have anemia in our community. Now, the possibility of anemia goes up if a patient has got a diabetes. Possibility of anemia is even higher if a poorly managed diabetes, and possibility of anemia is yet higher if the patient has got a background renal disease. So therefore, already there is an anemia. If there is a diabetes, possibility is more. If poorly controlled, possibility is higher. If there is a chronic kidney disease or nephropathy, the possibility is even higher. So this is the screening, and this is the diagnosis. This is the category, mild, moderate, and severe. I think all of you are aware, so I'll not go in detail. Now, coming to impact of the anemia on diabetes complication. Now, we are actually very much concerned about our kidney and the heart and the big issues or big complications of diabetes. But if we look into the data, it can tell you that if a patient has got anemia, it actually associated with progression of diabetic nephropathy. We are trying a lot to reduce the progression of diabetic nephropathy by giving this drug or that drug. We are talking a lot about SGLT2 inhibitor, but here is one simple method by which we can reduce the progression of renal disease by correcting the anemia. Second important issue is what we always think about is the retinopathy among our diabetic subjects. So correct the anemia because it will prevent the progression of retinopathy. And third, which we always talking in all our CMEs, is the cardiovascular disease. And you can see that the anemia is a very important risk factor for the development of cardiovascular event. So to prevent the complication, to reduce the progression of the complication, we should be aware about the anemia and we should correct the anemia. Now, looking into the mortality data, the patient who have anemia, they have a higher mortality compared to those who do not have anemia. So therefore, not only associated with complication, not only associated with quality of life, not only associated with morbidity, but the anemia is associated with mortality as well, and that need to be understood. Now, looking into pathophysiology of anemia, why a diabetic patient have anemia? Definitely chronic kidney disease, one of the very, very important and common cause. With the progression of the renal disease, anemia increases. Lower the HbA1c, lower the eGFR, higher is the possibility of anemia. Having said that, there are many other pathophysiology also which contributes to the development of anemia apart from the reduced production of erythropoietin by the kidney because of the nephropathy. So there is some hematinic deficiency. Now occurred blood loss, celiac disease if a patient has got a type 1 diabetes. Systemic inflammation, we are talking a lot about the systemic inflammation, especially in the backdrop of obesity. And very importantly, two things we have to remember that when you're using this renin-angiotensin system blocker, the RAS blocker, they are associated with anemia and also the pioglitazone if you're using. Now, the issue is I'm not telling that you should not use the RAS blocker if a patient has got anemia. What I would like to highlight that when you are using RAS blocker, be careful that it can also precipitate or can actually contribute to the development of anemia, and be careful and correct the anemia if the patient at all develops it. Now, after the bariatric surgery, nowadays we see a lot of patients after bariatric surgery in the follow-up. And patients with bariatric surgery, they are very prone to suffer from micronutrient deficiency, and anemia is one of them. So if we are following a patient of bariatric surgery who had diabetes, so quite naturally we should be careful about the anemia because iron absorption is low and that needs to be corrected. Now, coming to the important point which I was discussing is the use of angiotensin converting enzyme inhibitor or ARB as far as the hemoglobin level is concerned. As I've told you, they have an important contribution as far as the development of anemia is concerned. So looking into the pathophysiology of the anemia in the diabetes background, it is not just erythropoietin deficiency or the action of the erythropoietin, but it is also because of the use of some drugs, say for example, ACE inhibitor, ARB, metformin, because most of our patient actually receives the metformin, which can cause vitamin B12 deficiency. There are inflammation. You are using the RAS blocker. The patient has got a chronic inflammation. The patient has got a chronic kidney disease or nephropathy. So all these factors in combination actually contributes to the development of the anemia. Now coming to my 4 case studies, because I am telling 4 because these 4 is actually almost all cases of anemia that I see in my clinical practice. So if we understand these 4, I think you will be able to manage more than 95% of the cases. For rest 2 or 3% case, I'll send it to the hematologist. I'll not treat. So 4 cases we should treat and should know how to treat. This is a simple 34-year-old woman, diabetes for the last 4 years, hypertensive, mother of 1 child, on metformin and glimepiride and telmisartan, mild dyspnea on exertion, BMI 29, quite heavy, blood pressure normal, and this is basically the biochemical reports. And you can see the patient has got a HbA1c 8.7, so the patient is definitely suffering from anemia. You can say glycemic control is fairly good, creatinine is normal, thyroid function normal, ECG normal. Now, how we should approach? Now, there is an algorithm how we should approach. The first thing we should check is whether the patient has got a microcytic anemia, macrocytic anemia, or normocytic anemia. Very simple, just ask for an hemogram and you will get the what is the MCV, mean corpuscular volume. If it is a microcytic anemia, the first panel, then we should consider the iron deficiency and thalassemia. These are the 2 important differential diagnoses. If the patient has got a macrocytic anemia, then common cause is the vitamin B12 or the folate deficiency. And third, in the middle panel, if the patient has got a normocytic anemia, there's a possibility of iron deficiency anemia, vitamin B12 deficiency also, but commonly it may be because of the anemia of chronic disease. So because of long-lasting diabetes, possibly the patient has developed normocytic anemia. And then we will come to the patient again. Coming back to the patient. Now, if you look into this patient, you find that this patient has got a mean corpuscular volume is 74.7, indicating we are actually dealing with a microcytic anemia. And with the background of microcytic anemia, you can see that the serum ferritin, we don't have any pointer. So if you look into the serum ferritin level, it is 9, it is very low. So if the serum ferritin is very low, so it indicates that the patient is suffering from iron deficiency anemia. So that is very simple. There is no any rocket science behind it, but the issue is we don't look into it, and we don't recognize it, and we don't treat it. That is the issue. Now, when you are treating anemia, this is again an Indian publication. So this is a position statement. So this statement said that we should not overcorrect the anemia, though it should be individualized on the basis of the age, sex, and clinical status. But we should target hemoglobin around 11 to 12. Don't try to overcorrect the anemia. And especially if the patient has got a backdrop of diabetic kidney disease, the overcorrection, or if the hemoglobin value is more than 13, there is a possibility of higher mortality and higher cardiovascular event. So don't try to overcorrect the anemia. 11 and 12 is a very good target as far as the correction of the anemia is concerned. So don't overcorrect, and don't go beyond 13 gram% if the patient has got a backdrop of diabetic kidney disease. Now, how to treat iron deficiency anemia? I think all of you are aware. Just few points to highlight. We have a lot of options as far as oral iron preparation is concerned, and you all must have treated your patients with oral iron therapy. They are quite cheap, they are very effective, but they take long time to get the anemia corrected. And at the same time, that sometimes some of our patients actually can't tolerate the oral iron preparation. So nowadays we have the injectable iron preparation as well, and this is actually one shot, just one IV preparation, one IV injection. So you can give it within a gap of 7 days by up to 1,500 milligram. That is usually the usual dose for the correction of anemia is 10 or so. So it is very quick, easy. However, the anaphylaxis is a possibility, reaction is a possibility. It requires the supervision. It is a costly. So these are the few advantages and disadvantages of the oral iron preparation and the intravenous iron preparation. Now coming to the second patient, it is almost same. There is no difference as far as the general data of the patient is concerned. As far as the lab value also, you can see the hemoglobin is 8.7, same like the previous patient. Now, if you look into the further detail as far as the complete hemogram, now patient has got again the microcytic anemia 74.7, but this patient has got a normal serum ferritin 167. So one thing is sure, that this patient is not suffering from iron deficiency anemia. So therefore, what is the next differential diagnosis if the patient has got a microcytic anemia? So this patient has got a microcytic anemia, but not iron deficiency. And as the second differential diagnosis is basically thalassemia. So we have to look for hemoglobin electrophoresis, and this patient has got a beta thalassemia minor. Let me tell you that this is the area where the thalassemia is quite prevalent, and we see a lot of thalassemia minor or thalassemia trait in our clinical practice. So if the patient has got anemia who is not responding, or at the very beginning, if you find that the patient has got anemia, but the patient has got a normal serum ferritin or higher serum ferritin, possibly we are dealing with thalassemic trait, and be very careful that whether you are dealing with thalassemic trait or not. In this case, iron supplementation is not required. It is useless. This is number one. Second is you should give folic acid supplementation. Iron supplementation only required if the patient has got iron deficiency as well. But the very important is to counseling of the patient. If the patient is young, especially in the childbearing age, you should counsel the patient as far as the importance of thalassemia is concerned. To the case, this is 62-year-old presenting with fatigability, dizziness, and dyspnea during moderate effort, diagnosed with diabetes in 2010, and was receiving metformin 1 gram twice in a day, sitagliptin, beta blocker, no alcohol abuse or smoking, heavy 29, and you can see this patient again age hemoglobin is 8.7, but the issue is other reports are normal, glycemic control is fairly good. So again, if you look into the hemogram of this patient, you can find that the mean corpuscular volume is 109.6, indicating that we are dealing with a macrocytic anemia and serum ferritin is normal. So if we find that there's a macrocytic anemia coming back to the slide, then you will find that the cause of the macrocytic anemia is either vitamin B12, folic acid deficiency, it may be drug-induced liver disease, hypothyroidism. These are a few important differential diagnoses as far as the macrocytic anemia is concerned. So when you are looking into a macrocytic anemia, this patient was receiving metformin for a very long period of time. And if we check the vitamin B12 deficiency is there, the liver function test is normal, thyroid function we have already checked and it was normal. So possibly we are dealing with a vitamin B12 deficiency. Now, what we should do, should we stop metformin? You may stop metformin, but as you can see, if we're giving the vitamin B12 replacement injectable, then you may not stop the metformin, because metformin actually is associated in the intrinsic factor as related absorption of vitamin B12 from the intestine. So therefore, when you are giving vitamin B12 injectable formulation, then you may not stop the metformin, but you may stop the metformin for a period of time and treat the patient with injectable vitamin B12 replacement. Now, the people have looked into the relationship between metformin and the vitamin B12 deficiency. So it was found that in diabetes, those who receive metformin, up to around 10-20% patient can develop the vitamin B12 deficiency. It is because of the malabsorption and large doses. And if you're using it for more than 4 years, the possibility is much higher. And if there is a 13% increased risk of vitamin B12 deficiency per year when you're using metformin therapy. This is a very interesting study, which has looked into a mastermind study, which has looked into the data from the 3 RCTs, that is ADOPT, UKPDS, and GODOT studies. And all 3 RCTs have evaluated as far as the impact of the metformin as far as development of the anemia is concerned. And they have found metformin is basically associated with increased possibility of developing anemia when you are using in the backdrop of diabetes mellitus. Coming to my last case, case number 4, a 54-year-old woman with diabetes, hypertensive, once on gliclazide, linagliptin, amlodipine, mild dyspnea, quite heavy, BMI 29, age again 8.7, but very, very interesting, important is that the creatinine 2.71. So this patient has got a chronic kidney disease, and which has actually led into the anemia. We all know that the lower the eGFR, higher is the possibility of anemia, and also higher the urinary albumin excretion, higher is the possibility of anemia. So 2 important risk factors for the development of anemia in the backdrop of diabetic kidney disease. One is low eGFR and another is proteinuria. So they are closely linked with that of the development of anemia and level of anemia. Now, why there is an anemia if the patient has got a chronic kidney disease? One of the most important explanation is definitely the decreased production of erythropoietin that is there. But at the same time, there is a excess production of hepcidin molecule by the liver, which actually associated with iron absorption from the intestine. And third, uremia itself actually depress the hemopoiesis from the bone marrow. There is a possibility of blood loss because of GI hemorrhage or during dialysis. So these are the 4-5 factors which actually contributes to the development of anemia. Now coming back to the patient, this patient has got an eGFR of 19. The transferrin saturation is normal, and serum ferritin is 219, indicating that there is any iron deficiency in this particular case. So this patient has got anemia because of chronic kidney disease with enough iron store. Now, how we should treat? Now, again, as I must highlight the point that we should not overcorrect the anemia. Our target is that the hemoglobin should be around 10 to 11.5, not 13, not beyond 13, because it is associated with more mortality and cardiovascular event. Be very careful that whether the patient has got an adequate iron store or not. So we can start erythropoiesis stimulating agent. We have 3 important agents. One is epoetin alpha, second is epoetin beta, and third is darbepoetin. So either of these 3 agents we can use, provided the patient has got an adequate iron store. That means transferrin saturation more than 20%, ferritin more than 200, and hemoglobin at least below 10. If the hemoglobin is more than 10, don't give erythropoietin stimulating agent. It is not a very good drug because it has got a lot of side effects. So be very careful when you're using an erythropoiesis stimulating agent. A side effect is increase in the blood pressure, rapid rise in hemoglobin, thrombosis, cardiovascular event, and malignancy. So it is not a very safe drug. It is not very prudent that we should use it randomly for all patients who have mild degree of anemia in the backdrop of chronic kidney disease. So be very careful when you are using this drug. So if we look into the evidences for correction of the anemia in chronic kidney disease, there is no conclusive evidence that correcting anemia improves the clinical outcome in patients with chronic kidney disease. And darbepoetin alpha in type 2 diabetes, there is a very interesting study. TRIT did not reduce the risk of either of the two primary composite endpoints, death, cardiovascular event, or death or renal event. So therefore, the mortality data is not there in favor of erythropoietin stimulating agent. However, there are some studies which shows that the quality of life improves with the use of erythropoietin stimulating agent. So quality of life, renal factor, the hospitalization for the heart failure, and neuropathy, these improves. So it means that some of the complications of the diabetes improves, the quality of life improves, but there is no evidence that erythropoietin stimulating agent is associated with improve in the mortality. So that are the limiting factor as for the use of erythropoietin stimulating agent in the backdrop of chronic kidney disease. So my last slide, take home. Again, my first slide is basically the take home. Please look into the anemia, recognize and correct, because that has got immense impact as far as the quality of life, the mortality, as well as the complications of the diabetes. So in patients with diabetes mellitus, prompt detection and correction of anemia is important to reduce the risk of diabetes complication and to improve the quality of life. The iron deficiency, thalassemia, vitamin B12 deficiency, and diabetic kidney disease are the common cause of anemia. I've shown you 4 cases and 4 important causes, and I think more than 95% patient will be in either of these 4 important differential diagnoses. And treatment with oral or intravenous iron preparation and erythropoiesis stimulating agent needs to be individualized based on the patient clinical status and comorbid condition and the risk. And excess correction of anemia with erythropoiesis stimulating agent, especially in the backdrop of chronic kidney disease, can have severe adverse outcome. Be very careful about that. And thank you very much for your patient listening.
Thank you, sir. Sir, I would request you to kindly stay back. We have the question answer session. Can we have the faculty chairs, please? I'd also request Professor Sudhir Jain, sir, and Dr. Nadenia to please come up for the question and answer session. If any questions from the audience, if not, then I just want to ask Professor Majumdar for a basic, very practical question. So you have very nicely elaborated regarding the vitamin B12 deficiency we sometimes see when we use metformin. The prevalence is not very high, around 10 to 20%, which you have shown. So is there any rationality in using vitamin B12 supplements in almost all patients who are on metformin? There are some fixed dose combinations with metformin with vitamin B12. There are some preparations which are in the market. Any rationality in using these?
Yeah, I think 1 or 2 companies has got this preparation available, the vitamin B12 and metformin combination. But as I told you, the absorption of the vitamin B12 is basically depend on the intrinsic factor. And when you were giving metformin actually impairs interacting with the intrinsic factor also. It has got some other mechanism, some impact on the gastric mucosa by which the absorption is retarded. So giving vitamin B12 orally possibly will not correct the issue. This is my opinion. I don't know whether they have come up with some studies which showing that the oral supplementation is also very beneficial. There is no harm in giving it if the price remains the same. But there may not be much benefit if you are using oral vitamin B12 in the backdrop of metformin therapy.
So one more thing which I would like to add is anemia could be the first sign of chronic liver disease in NASH patients, especially with diabetes. And stool for occult blood and further evaluation with endoscopy can be one factor of compensated liver disease and diabetes. And one more thing, sir, pioglitazone also is a very notorious drug to cause anemia. How do we actually need to stop it, or we need to give something to correct anemia?
The pioglitazone actually is associated with hemodilution. It is not that total amount of hemoglobin is going down, but quite naturally, if there is a significant hemodilution, so pioglitazone can have some impact, because we know that the thiazolidine has got many other side effects also. So we should be careful. And if it is anemia, if you find that this patient has got the iron deficiency as a contributing factor, that much we can correct.
Usual to asking a surgeon to a physician. Such a nice presentation. I am a surgeon, of course. Now, those who are on metformin, do you think the B12 should be supplemented irrespective of the blood sugar? So only
because the prevalence of the vitamin B12 deficiency, those patients who are receiving metformin is not very high, very low. So giving vitamin B12 to everybody is useless. So if the patient develops vitamin B12 deficiency, then we should supplement. Otherwise, I don't think it is necessary, not recommended by any august body. That vitamin actually has got no value as far as the management of diabetes is concerned. The recommendation is, if there is deficiency, we should correct.
Sir, those patients who are undergoing dialysis, and we frequently have to give iron and erythropoietin both. So in this case, what preparation of iron will you prefer?
So I think that you can give oral iron therapy as well, but as I've mentioned, that the oral iron is not much absorbed sometimes. Sometimes the patient has got a lot of stomach issues with the oral iron. Because iron is basically gastric irritant, and when you are advising give oral iron, it should be given little bit of empty stomach. Either you should give 1 hour before the meal or 3-4 hours after the meal. Otherwise, iron will not be absorbed much. So quite naturally, when you are giving in an empty stomach, possibility of irritation is higher. But we have to give it in an empty stomach, because otherwise the absorption is not there. So this is basically a double-edged sword. So therefore, in a patient who is uremic, who is receiving dialysis, the gastritis is always there. The patient always receives some proton pump blocker or something, because the uremia itself causes gastritis. So giving oral iron can actually further aggravate the situation. So if you find the patient can't tolerate, give it intravenously if the patient has got iron deficiency. Nowadays, we have this iron carboxymaltose. So that is very convenient, useful. As I've showed you, 750 milligram is basically 1 ampoule. So if you give 2 ampoule, it is 1,500 milligram. Though some of the guidelines suggest you should give 750 milligram, give a gap of 7 days, give 750 milligram. But sometimes I give to 1,500 milligram in one shot, because the company, the product literature shows you can give it 1,500 milligram simultaneously. But it should be diluted in normal saline with 100 ml or 150 ml, and should be given under supervision with some duration of time, say for half an hour or 1 hour.
Almost all diabetic foot patients are also anemic. So.
Yes, definitely. So, yes, that is a good advice. But again, absorption of vitamin B12 is questionable.
Sir, most of the diabetes patients who are having long-standing diabetes are already having gastroparesis and they are constipated. Yeah. And if they are having anemia along with that, those complaints, how to deal with those patients? Because adding iron supplement will further worsen the constipation.
Give intravenously.
Intravenously.
So, if suppose a patient who is on metformin developed B12 deficiency, what do you recommend? Stopping the metformin or just to increase?
That is, I have said that you can stop metformin, but just by stopping metformin, you will not be able to correct the vitamin B12 deficiency. So you have to give vitamin B12. So when you are giving vitamin B12 in an injectable formulation, whether giving you are orally metformin or not, it hardly have any impact.
Now, since the mechanism is that it interferes with the intrinsic factor,
yes.
Then if you continue that, then even increasing the dose will not helpful in this patient.
No, you have to give it for a period of time, and then you can stop. But usually vitamin B12, that you have rightly pointed out, the vitamin B12 is not much stored. It is not a fat soluble vitamin. It is a water soluble vitamin. So therefore, if you are not giving continuously, again the vitamin B12 deficiency can happen. I agree with this.
And is there?
Yes, you can continue, but sometimes dietary vitamin B12 may not absorb. And vitamin B12 mostly available in the animal source. So if the patient is vegetarian, the dietary supplementation may not give adequate support.
Now, one more is that if the metformin is continuing, as per the mechanism, it will impair the absorption. So if vitamin B12 deficiency, it should be corrected by injectable.
Injectables, yes.
My question is, suppose if there is a mechanism that metformin interferes the absorption, then why all patients are not developing anemia?
I don't know.
So long-standing use of PPIs can
It
be a
also
culprit.
depends on the dosage, as you have rightly mentioned. Most of our Indian patients cannot tolerate 2 grams of metformin. Mostly they are on 1 gram or even lesser doses of metformin. That might be one of the reasons why not all patients are. So any other questions? I think we are already just one last question. We can have.
Or hydroxycobalamin, which form should be given?
Yes.
Methylcobalamin or hydroxycobalamin? Because most of the
There is no hardly any difference.
No difference. So,
Thank you. I think we are almost 5 minutes behind schedule. So I thank all the speakers for their excellent deliberation. It was really a pleasure having all of you here. And with this, we come to end of this session and we'll move on to the next session. Thank you. Thank you.
Yeah, and I would just, sir, I would request all to just stay on the dais for just a few minutes. And I would request our chairpersons to kindly felicitate our speakers for the day. Yeah, I would like to request Dr. Amartya Shankar Chaudhary to kindly felicitate Dr. Jain. It's a pleasure on behalf of Bengal Diabetes Foundation also such gifts from sir. And now Dr. Amartya Shankar Chaudhary to felicitate Dr. Jain, please.
Right on the day when I was invited, then received, then workman observed where you are at something according to the place. So
And I would like to request Dr. Goswami to kindly felicitate Dr. Dhandania, please. And lastly, Dr. Shobhik Roy to felicitate Dr. Anirban Majumdar, please. And on behalf of BDF, I would like to request Dr. Rakesh Kumar to kindly come and celebrate our chairpersons. Felicitate our chairpersons, please. Certificates. So with that, I would like to conclude this session, and now we move over to our guest lecture for the day, Padma Dr. Sushoman Banerjee Memorial Lecture. Sir is no more with us, but he was an inspiration to all of us, and he has been very actively involved in all our previous conferences. So in his memory, we have the next session, and we have the chairpersons for the session, Dr. Amitabh Vishwas and Dr. Shomik Goswami. Please, sir, come on the dais.
Good evening, everybody. Dr. Sushoman Banerjee was the very first concept of the Bengal Diabetes Foundation's annual conference, which has started 2016. He was the honorable chairman. And this year, we know that he is no more with us. So in his memory, we have kept this Dr. Sushoman Banerjee Memorial Guest Lecture. For this lecture, we invite Dr. Professor Shamur Banerjee to come on the dais, please.
So Dr. Amitabh Vishwas will felicitate Professor Shamur Banerjee with a Uttori. So there's a citation to be read before Professor Banerjee proceeds with the first Dr. Sushoman Banerjee Memorial Guest Lecture. The Dr. Sushoman Banerjee Memorial Guest Lecture is our homage to Padma Shri Dr. Sushoman Banerjee, also known as 1 rupee doctor, who was an eminent Indian physician from Bolpur, West Bengal. Bengal Diabetes Foundation is privileged and proud to award the Dr. Sushoman Banerjee Memorial Guest Lecture to Professor Shamur Banerjee. Professor Banerjee is an eminent expert in diabetes with special interest and pioneering work in gestational diabetes. After completing a glorious tenure at Nilratan Sarkar Medical College, Calcutta, as Professor and Head Department of Internal Medicine, he is presently rendering yeoman service at Bdcon Institute of Medical Sciences, Kolkata, West Bengal. Over to Professor Shamur Banerjee to regale us with his pearls of wisdom.
Thank you, Shomik and Amitabh. I'm really very much perturbed and very much surprised. In this remote area, Amitabh and his team has organized so nice conference. The audience is 4 to 5 times than the Kolkata audience. Every week I do program. Last week I did a program. I'm not going to name the program. 8 or 9 people within the hall. How many awake? I'm not going to give the number. Amitabh, of course, has invited me earlier. I could not make it point. Today I had a also program at Jaipur, but as he has invited first, I selected for that. There are other interests. Here is my student, Subhajit Dotto, and very learned student who promised me that she will come here, receive me, accompany me in lunch. Sunita, she has just come to receive me. Okay, thank you. They are very big. Regarding Sushoman, I see him like this. He was always laughing. I'm very lucky that his daughter was my student. And 3 months back, probably, Bardhaman, there was a program on diabetes. I came and he was the chairman of my program. He took 10 minutes to speak about me. I always requesting, Sushabanda, please stop, please stop. No, let me tell you, and I'm going. He came on that day from the dialysis bed and attended the program at night. This proves his stamina, stimulus, and intensity for learning subjects. Very nice man, very beautiful man, always positive person. I'm very happy and glad that this team Durgapur team has arranged dedicated, probably first time any oration after Sushabanda, if I am correct. You were first to introduce any oration, not in your program, but in India probably. I'm going to discuss some points on metformin. How I look at, I don't give any prescription other than metformin, if not strongly contraindicated. I gave a lecture, the topic was whether contraindication of metformin should be contraindicated. The renal failure, eGFR is coming down now to 30. I'm 100% sure if I live for 10 years, it will be taken away. Lactic acidosis, I will show. Megaloblastic anemia, with due regards to Anirban, I will show the data. What is the incidence and what are the problems with megaloblastic anemia? So what is the journey of the metformin? 100 years. 1922, metformin was first synthesized. But clinical research, etc., took time. And it was introduced in all the country around about 1970s. And for that reason, they have taken it as a 75 years of metformin, etc. But actually it was born for 100 years. But USA did not approve. They approved in 1990s. And then their roaring started. How beautiful is this? This is isolated from Galega officinalis. Sorry. And it was invented by Gene Stern. Metformin in clinical practice. Metformin, the first line glucose lowering drug to control hypoglycemia in type 2 diabetes. Metformin is safe, small risk for hypo, weight neutral, and some GI adverse effects. Inexpensive, reduces microvascular complication and lowers cardiovascular mortality compared with sulfonylurea therapy. Guideline for metformin use in type 2 with mild to moderate renal impairment and congestive heart failure have changed. It can be given in congestive heart failure, of course, with some limitation. Very briefly, it counters insulin resistance. Sulfonylurea do not ameliorate insulin resistance, rather increases. Metformin is a very strong drug acting on insulin resistance, which is the root cause of type 2 diabetes. Anti-hyperglycemic A1C lowering efficacy 1.8, no weight gain, cardiovascular protection. In myocardial infarction, I will show details, can improve some lipid parameters, anti-hyperinsulinemic, possible further benefits in cancer, NASH, but GI intolerance. GI intolerance can be predicted very quickly. Pharmacogenomic is coming. As you do the urine culture to know the drug, pharmacogenomic can tell that if the OCT21 gene is positive, the patient will have definitely GI intolerance, wherever dose, wherever time you give. In those cases, you will not give. Fortunately, in our country, incidence is 7 to 8%. Contraindication, renal hepatic predisposition to hypoxemia, risk lactic acidosis, monitoring hemoglobin, possibly B12 folate, we are not doing routinely. Administration of multiple last tablet, that is a problem. The 1 gram tablet is very. The dose for the sustained release, 1 gram twice daily maximum. Short acting, 853 times daily. I now don't use other than long acting. The sustained release dose is not only less, but a portion go to the jejunum, has got its other mechanism of action. They act as a GLP-1 like activity, and by altering the bacterial flora also act as the alpha glucosidase, Voglibos like activity, and gastric intolerance is less. What are the effects other than glycemic? Today I am not going to say you that metformin controls blood sugar. I am not that fool. I'll only discuss extra benefit. Amelioration of insulin resistance, antioxidant activity, advanced glycation end product, improve microcirculation, reduces inflammation. Metformin king is always king. The three medication, metformin, EMPA, and liraglutide, have shown a specific benefit for cardiovascular outcome in patients with type 2 diabetes who are at high risk for cardiovascular events. What are the benefits of the metformin on the heart? Sorry. And the benefits are diabetes-related death reduction by 42%, all-cause mortality by 36%, any diabetes-related endpoint 32%, myocardial infarction 39%, stroke by 41%. To compare with sulfonylurea, these are all on the adverse side. And metformin prevents cardioprotection efficacy is up to 39%, the green bar on the left side. It is comparable with beta blockers, comparable with simvastatin. These are the extra benefits which we come across. Rich study in patients with diabetes and documented atherothrombosis. The use of metformin was associated with a significant 24% reduction in all-cause mortality after 2 years of follow-up. The final endorsement for metformin in vascular intensive metformin seems to reduce the risk for any clinical endpoint related to diabetes, death related to diabetes, all-cause mortality and myocardial infarction. Showed a significant reduction from baseline for A1C, BMI, weight, cholesterol, LDL-C, triglyceride, insulin, diastolic blood pressure, and increases the HDL-C. This is about the curve, favorable effect on the metformin outcome after coronary intervention. The blue one is the metformin, and the other is the other anti-diabetic therapy. This is about all-cause mortality in patients with diabetes, stable coronary artery disease, post-ACS, congestive heart failure. In all points, they are working as better if you compare with sulfonylurea or other drugs. I just reminding you, this is the data before comparing with SGLT2 inhibitor or GLP-1 analog. Myocardial infarction, the reinfarction rate is less, symptoms of angina is less, acute cardiovascular events are less, and death is also less. Proven vascular benefit of metformin, improvement in endothelium dependent vasodilation, decreased plasminogen activator 1 activity, and increased tissue plasminogen activity. These are the markers for strokes and the vascular complication. Improved clinical outcome associated with metformin in patients with diabetes and heart failure. It has been combined with sulfonylurea. It exerts secondary prevention in cases of heart failure. And what is the conclusion? The latest data by 2022 October. This is a very current data for 1 month only. Metformin may also be an effective treatment for atrial fibrillation by targeting its 30 different genes. In patients with stable congestive heart failure, metformin associated with better overall prognosis than other glucose lowering agents. Stable heart failure should not be considered contraindicated to the use of metformin in patients with type 2 diabetes. Stage 1, stage 2, you can use. 3-4, be cautious, not give, because there are chances of hypoxemia. Improves endothelial vascular reactivity and 36% improvement in the endothelial function, and also in the lowering of the cholesterol of the different lipid markers. In first degree relative of type 2 diabetic patients with metabolic syndrome, metformin improved vascular endothelial reactivity by 36% and also improved the forearm blood flow level. Impact of metformin on the clinical and metabolic parameters of women with polycystic ovary. I've got opinion difference with some people. In PCOS, many people start with hormones. If you give progesterone, that will aggravate the insulin resistance with the cause of the PCOS. I'm showing you the latest data, and this data is published in 2022 by Abdallah et al. It lowers the mean body BMI, LDL-C, testosterone. There is higher testosterone level in PCOS. Androstenedione down 17 HP, fasting blood sugar, and increases the pregnancy rate in 564 women with PCOS. Those who are using with estrogen progesterone combination, they are keeping the lady as sterile. With metformin, chances of fertility will be more. New users of metformin are at lower risk of incidental cancer. What are the cancers people are trying to search out? This is the breast cancer, colorectal cancer, and bronchogenic carcinoma, etc., etc. I'm not telling that metformin is an anti-cancer drug, but if it is proved, you will get an anti-cancer drug in a price of 3 rupees, then 30,000 rupees. The data is going on. In women with GDM, pregnancy, metformin alone or with supplemental insulin is not associated with increased perinatal complication as compared with insulin. Also, women preferred metformin to insulin treatment. But unfortunately, you have part of the country, you have just heard of the diabetes pregnancy study group for which I was the past president. The government guideline is you can use from the second trimester. They are waiting for Indian data. Nice guideline. They have all accepted. You can use from the very beginning. Metformin is not teratotoxic. If you give metformin, the chances of obesity in the mother, chances of macrosomia in the child, and also future cardiovascular complication of both mother, child, and recurrence of diabetes will be less because metformin will reduce the insulin resistance, which is the cause of gestational diabetes. Type 1 diabetes, metformin improves insulin resistance regardless of baseline BMI, weight, fat mass, insulin dose, and aortic and carotid health in adolescent. Metformin may hold promise as a cardioprotective intervention. Till date, there is not much strong data that metformin will lower blood sugar effectively because type 1 is not a disease of insulin resistance. It is an insulin deficiency. But in long term, the child lives long, cardiovascular complication will be less. Pediatric, where we use for weight loss, particularly those children who are taking antipsychotic induced obesity. Metformin on BMI and glucose tolerance in obese adolescents with PCOS and pediatric patients with type 2 diabetes are improved. In elderly patient, there is no problem, only take care of the GFR. 2 studies in Japan and Poland confirm efficacy and safety comparable to that of non-elderly. Many drugs do not work with the elderly age group. In risk registry, I just mentioned patients ages 65 to 80 years, 2 years mortality rate reduced significantly. In age above 80 years, no significant difference in benefit or harm. Observational data suggested that use of metformin is not harmful in elderly diabetic, but may instead be associated with more favorable outcome, including overall mortality compared with other glucose-lowering agents. Thus, old age persist should not be considered a contraindication to the use of metformin in the absence of any other absolute contraindication. We are having some reservation for using SGLT inhibitor above 80, but data are coming, probably they are not that dangerous. Metformin prevents or delays the development and progression of osteoarthritis. It has been proposed as an effective drug to prevent or delay musculoskeletal disorder, including osteoarthritis, the occurrence and development. Metformin can activate the pathway and expression of both MPK and SIRT1, so as to protect the mitochondrial function of the chondrocyte, thereby promising osteoblast formation. Diabetes prevention program, DPP study, you know, that with metformin, prevention of diabetes was possible in pre-diabetes group up to 31%, intensive lifestyle at 51%. Intensive lifestyle is practically impossible, even doctors do not do. But if you ask them to take metformin, they will do whatever is doable, that is mostly acceptable. DPP study showed that the treatment with metformin was one of the highly effective means of delaying or preventing type 2 diabetes. This is about the Indian diabetes prevention program. My good friend Ramchandran did that study and has shown that metformin improves absolute and relative risk reduction with metformin was 26.4%, whether lifestyle was properly followed or not. The metformin used at lower doses was equally effective. Sometimes patients cannot tolerate the full dose as lifestyle modification to prevent diabetes in Asian Indians at risk. Metformin in pre-diabetes, ADA 2013 data. They say metformin therapy for prevention of type 2 diabetes may be considered in those with IGT, IFG or an A1C of 5.7 to 6.4. Incidence of lactic acidosis is so much threatened topic. This is a data 77,601 patients. Out of them, only 35 case of lactic acidosis. This go-to calculation, it is below 0.001, which is practically goes below P. To P value statistically positive, there should be more than 5 out of 100. And none of them were fatal 23 were linked to a comorbidity. Majority lactic acidosis or other having hypoxia or renal failure. No significant difference in the incidence of lactic acidosis. You compare with the sulfonylurea-induced hypoglycemia, the rate is much higher. Benefits in CKD, reduction of atherosclerosis from continued health registry. 2-year mortality rate with metformin versus other agents was significantly lower in patients with eGFR of 30 to 60. Actually, metformin suppresses the renal nephrosclerosis, so prevents worsening into end-stage renal disease, even greater than those observed in patients with eGFR of 60. So GFR more than 60, the prevention of renal damage is better if you use in 30 to 60. Metformin at least a similar reduction in mortality as in overall population. So what FDA has given the guideline, you can use metformin up to 45 GFR. If below GF goes below 45, reduce the dose by 50%. If you start metformin, GFR is below 30, in those cases, don't start. And if it goes below GFR 30, then stop. But I am sure this GFR level will again come down. 5 or 7 years back, it was said the moment GFR is coming down from 60, you stop. In patients in chronic respiratory insufficiency, severe chronic respiratory insufficiency is a contraindication because of the risk of hypoxia and lactic acidosis. Experimental data show that metformin can reduce both ARO inflammation and remodeling, at least partially, through the introduction of the AMP activation while decreasing oxidative stress. So in COPD, metformin is doing better than doing worse, but don't give when there is gross hypoxemia. This is about the effect on muscle. Actually, they are improving the sarcopenia. I am not going to details. By inhibiting lipogenesis, increasing the fatty acid oxidation. It also acts on the adipose tissue and improves the adipose tissue insulin resistance. Metformin causing vitamin B12 deficiency. Whatever data has come, they have measured serum B12 level. Serum B12 level is not reflecting the active molecule. It is the holotranscobalamin. You will have to measure the holotranscobalamin and methyl doing active molecule. If it is reduced, then you take for granted that there is deficiency of B12. Measurement of cyanocobalamin will not help you. There is no evidence that pathological levels of biochemical markers of B12 are more common in metformin treated compared with non-metformin treated patients despite lowering B12 in serum or plasma. Metformin lowers serum vitamin B12, but improvement in intracellular B12 content and intracellular B12 markers. So outside metformin, B12 may be less. Intercellular activity is good. So what is my problem? If I don't sow my money outside and have my money to maintain my status, what is the problem? A combined assay of B12 and methylmalonic acid can identify the deficiency. Again, I repeat, if you measure B12, useless. You go for methylmalonic acid and holotranscobalamin. Taken together, there is no evidence that pathological levels of the biochemical marker of B12 are more common in metformin treated compared with non-metformin treated patients, despite lowering B12 in serum. Low B12 pathological lesions usually do not come. Hepatic dysfunction, hepatic failure can dramatically hamper lactate removal. So your chances of lactic acidosis, it will be aggravated. Hepatic failure as seen in advanced cirrhosis, a severe liver hypoperfusion is considered a contraindication. Mild cases you can use. In liver disease, given its effect on insulin resistance, data shows suggested of benefit in hepatitis C virus. You know, HCV is related to diabetes and non-alcoholic fatty liver. By virtue of its inhibitory effect on the mTOR pathway, there is good evidence for a chemopreventive role against hepatocellular carcinoma among patients with diabetes and chronic liver disease. Metformin continued patient even with cirrhosis provide benefit. Then few running data, continuation in cirrhosis significantly improves survival of patients with diabetes. Attenuates experimental autoimmune arthritis. As MPK activator reduces stroke incidence and severity, cerebral stroke. Controversial results about the effect of metformin on stroke outcome during the acute phase. Post-stroke chronic treatment promotes long-term functional recovery and brain. Some recent developments. Metformin, an old drug for the treatment of diabetes, but a new drug for the protection of the endothelium, attenuates lung fibrosis developing via NOx4 suppression. Metformin and aging, improving aging outcome beyond glycemic control, acting on the telomeres. Metformin reverses development of pulmonary hypertension. Metformin attenuates pressure over-induced carotid hypertrophy via MPK activation, sensitizes neuron to insulin and also reverses Alzheimer's disease. Protective effect of metformin against tuberculosis. This data is published from Manipal University. In tuberculosis, if metformin use offers some advantage. Sanjay Kalra published that metformin may be considered an appropriate primary prevention strategy against malaria in persons with diabetes or pre-diabetes who live in or travel to malaria endemic zone. Thyroid function, effect of metformin on the hypothalamic pituitary thyroid axis in patients with type 2 diabetes and amiodarone-induced hypothyroidism. This is the name of the paper. Metformin may bring clinical benefits to this patient with amiodarone-induced thyroid toxicosis and poor tolerance of exogenous L-thyroxine because of its effect on the hypothalamic pituitary thyroid axis activity. Metformin improves erectile dysfunction in an angiotensin II model of erectile dysfunction. This is in, of course, experimental animal. Metformin associated with a decreased risk of atrial fibrillation, probably by attenuation of atrial cell tachycardia. Lowers risk of venous thrombosis, embolism after initiation of metformin than sulfonylurea. By increasing nitric oxide viability, limiting interstitial fibrosis, reducing the deposition of advanced glycation and cell apoptosis, remodeling and hypertrophy, cardiac are properly done in cases of left ventricular damage. Greatly desirable for multiple sclerosis therapy, including accident, antioxidant and anti-inflammatory or antiplatelet function. Metformin role in the treatment of Alzheimer's disease, amnestic mild cognitive impairment and Parkinson. Also confirm the long time use of metformin in diabetic patient contributes to better cognitive function compared to participant using other than B12. Metformin chronic therapy associated with a lower risk of hemorrhoids, bleeding piles. So more or reverse the growth of life-threatening hematoma in tuberous sclerosis. In early Huntington disease and epilepsy, metformin-dependent suppression of the mTOR pathway, neuroprotective. Animal models helps on the stroke and epilepsy. Someone is interested in speaking, they can come to the dais, I don't mind. Peripheral nerve regeneration augmented by metformin. Reduce mortality in women with obesity or type 2. In cases of COVID-19, sex-specific finding is consistent, leading to reduction of TNF-alpha in females over males and suggests that metformin conveys protection in COVID-19 through TNF-alpha effects. In GDM, associated with a better postprandial control than insulin for some males, a lower risk of hypoglycemia. With insulin only, there are more chances of macrosomia. Perinatal outcome, better. Metformin is associated with a reduced risk of total joint replacement in patients with diabetes. A bad information for those who are going for knee replacement. Then coming to the magnitude of effects on metformin or survival of a patient. Metformin, the survival is much better. If you treat 1,000 patients for 1 year with metformin in place of diet, and there will be 5 fewer deaths. 3,000 patients for 1 year with metformin in place of sulfonylurea insulin, and there will be 3 fewer deaths. In besides diabetics, so what are the where we can think of metformin? Polycystic ovary, female infertility, insulin resistance syndrome, cancer and cellular immunity, weight gain due to antipsychotics, prevention of aging, NASH and diabetic cardiomyopathy. But the frustration is, despite guidelines, only 57.8% of individuals began diabetes treatment with metformin. All the guidelines has shown to start with metformin if not contraindicated. Recent guideline 2022, if patient has a cardiac or renal problem or obesity, you can think of SGLT inhibitor. India is a country for more insulin resistance. I personally believe metformin should be there, combined with SGLT inhibitor thereon. And the earlier study which I show you, this was a Western study. Beginning treatment with metformin was associated with reduced subsequent treatment intensification. But the Indian study, this was done by us from NRS Hospital 2030. For the hospital practice, first column, metformin was used in 33.52, which should be at least up to 80%. 20% I accept the contraindication. Private practice, it is less, 29.60%. So this is our acceptance level after taking. I'm not going to tell that you use metformin for blood sugar only. I have shown so many protective data on the brain, on the kidney, on the ovary, on the brain, on the peripheral nerves, etc. In conclusion, I'd like to mention all the major support data support the foundation, metformin as foundation therapy for type 2 diabetes, all the guidelines. Evidence based for metformin is 70 years young, but new data gives insight into how the drug reduces mortality from all causes, not just of cardiovascular origin. Contraindication need to be liberalized to stop patient being denied to metformin. Again, I repeat, majority of the contraindication of metformin is contraindicated. A vast number of studies have highlighted the therapeutic potential of metformin for a variety of insulin-resistant and pre-diabetic states, obesity, polycystic ovary, GDM, cancer, and neuroprotection. These are all helpful. A greater understanding of the molecular pathway involved will help to guide novel application of metformin. I am very eager to say whether they are really suppressing or preventing malignancy, because cost will come to 4 rupees or 5 rupees per day from 30 or 40,000 of the costly cytotoxic. Finally, I just come to the lighter terms. I think you know, this is Hema Malini. When we were student, our friends has all heartthrob for her. One of my friends that he will commit suicide if for 1 second he can go in front of Hema Malini. I asked why? What is the utility of living more? You know, Hema Malini was so commanding, so demanding. 74 years have passed. This is earlier age. But you look at the 74 years photo, and I believe that are they becoming more attractive and promising? And I just tell probably metformin is becoming more and more attractive, not only used as blood sugar lowering agent in all other activities. So thank you metformin, and long live metformin. And I am just grateful to you for making my 9 books on diabetes successful. I have been commended by all my fellows to make it 10 digit. I'm trying for the nephro diabetes. Probably it may be successful next year. And in the book of the oral hypoglycemic agent at the left end, this was my most successful and demanded book. There is details of metformin here. You can get it from Amazon. Thanks to Amitabh and his team, Soumik, he gave me the chance as scientific coordinator. And thanks to Durgapur people for doing this excellent program. Thank you again.
We are thankful to Professor Shamor Banerjee for that wonderful exposition, and it gives us the conviction that the Golden Voyage will continue for many, many more years. So we'll now hand over the citation which was read out before the lecture, the formal citation for the first invitational memorial guest lecture. And as is customary in an invitational lecture, there won't be any questions.
বলো আমার ক্লাসের বন্ধু আমার নমিনাল অ্যাপাসি স্টার্ট হয়ে গেছে
তুমি চিনতে পারছো না তাহলে
আমার নমিনাল
দেবু শ্যামল ডক্টর ঘটক
2 বছর বা 2 বছর
3 বছর পর এবার
পুরো নামটা কি
That was indeed our pleasure to have Sir amongst us today, and it was a wonderfully insightful deliberation. So with that, I would take a short break today, and we'll have a small tea break of 10 minutes. Following that, we'll be having our inauguration. So I'll request all the delegates to have a short break and a tea break of 10 minutes, and following that, please come back here for the inauguration of this year's Bdcon 2022. Thank you. Hello. Check. থাকবে না যাবো
Beta helps in the prevention and remission of diabetes.
Cress-1 beta reduces insulin resistance, fasting blood glucose, postprandial blood glucose, and HbA1c. Cress-1 beta, the beta cell savior beyond glycemic control, is recommended in type 2 diabetes mellitus, pre-diabetes, and diabesity.
Cress-1 beta helps in the prevention and remission of diabetes.
Cress-1 beta reduces insulin resistance, fasting blood glucose, postprandial blood glucose, and HbA1c. Cress-1 beta, the beta cell savior beyond glycemic control, is recommended in type 2 diabetes mellitus, pre-diabetes, and diabesity.
Cresvin Beta helps in the prevention and remission of diabetes.
Cresvin Beta reduces insulin resistance. Fast
Cresvin Beta helps in the prevention and remission of diabetes.
Cresvin Beta reduces insulin resistance, fasting blood glucose, postprandial blood glucose, and HbA1c. Cresvin Beta, the beta cell savior, beyond glycemic control, is recommended in type 2 diabetes mellitus, pre-diabetes, and diabesity.
Good evening to all of you. Our chief guest has been arrived, so I request all of you to please move inside hall. Hello. Requesting all delegates to please come inside hall. শুনতে পারবে এই মধ্যে কিছু? Hello. Hello. Program is about to start. Requesting all delegates and pharma friends to please move inside the hall for the official inauguration of this Bdcon 2022.
All the delegates are kindly requested to step inside the hall. We'll now have the official inaugural ceremony of the Bdcon 2022. All respected delegates are kindly requested to come inside the hall so that we can start the inauguration ceremony. The chief guest has already arrived.
Good evening, everybody. I would request everyone to kindly be seated. Thank you, everyone. A very good evening to everyone, and a very warm welcome to our esteemed speakers, guests, delegates, and our members. I feel immense pleasure to be here and welcome you all at the 7th Bengal Diabetes Conference, Bdcon 2022, theme being Decoding Dilemmas in Diabetes. We have lived through the pandemic, experiencing lows and highs, losses and gains, and yet have managed to walk through and reach the light. The 2 years have emanated rays that made us feel the essence of learning, of education, and of knowledge, with more power bestowing strength to curb the uncertainty. Having said that, Bdcon has been virtual for these 2 years, with the feeling to grow, to share, and to learn. And today, we are here connecting in person and feeling more grateful about the present. With warmth in my heart, I, Anupreksha Biswas, once again welcome you all on behalf of Bengal Diabetes Foundation to the 7th Bengal Diabetes Conference here in Durgapur. Bengal Diabetes Foundation has worked in creating a space which provides and spreads awareness through various events such as Diabetes Mela, camps where necessary tests and investigations are conducted for all, World Diabetes Day, Walkathon, and many such awareness camps which helps in reaching out to people. I would now like to invite the members of the Bengal Diabetes Foundation on the dais, who every year have remarkably worked towards the success of the scientific conference and this gathering. I would like to call Dr. Shamul Kundu, Organizing Chairman, Dr. Amitabh Biswas, Organizing Secretary, Dr. Shomik Goswami, Scientific Chairman, Dr. Amarto S. Chaudhary, Joint Secretary, Scientific Co-Chairman, Dr. Rajun Palui. Thank you. I would now request Shri Brijendra Pratap Singh, Director in Charge, Burnpur and Durgapur Steel Plant, to please come on the dais, and would request the members to raise a warm welcome. I would request our Bengal Diabetes Foundation members to kindly raise the warm welcome to our chief guest. Thank you so much. I would now request all the members along with Shri Brijendra Pratap Singh to light the lamp with Saraswati Vandana to be bestowed with the blessings to follow the inauguration.
तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना
So now, following through, I would request Shri Brijendra Pratap Singh to kindly share a few words and inaugurate the conference.
All the dignitaries on the dais, off the dais, organizers, doctors, and everyone present here, ladies and gentlemen. It's my proud privilege to be the part of this very important conference organized here on diabetics, prevention and cure. And I would like to thank Bengal Diabetic Foundation for calling me here and making me part of this important conference. I would also thank Dr. Bishwas for calling me here and his team for organizing such an important conference where the speakers from and renowned doctors from all over India are present, sharing their experiences, latest research, latest papers on the prevention and cure of diabetics. We all know diabetic is an global emergency. Every second person after the age of 40, 45 suffering from diabetic, around 1.5 million people dying out of the disease of diabetic throughout the world, or maybe related diseases. During the time of COVID, we have felt that the people suffering from diabetes were more prone, having less immunity. This is a disease which is a major area of concern, and major improvements are required as far as the prevention and cure is concerned. Lot of things have been talked about the causes of the disease. Apart from being hereditary, as far as we know, I am not a doctor and doctors can better tell. As far as I know, what I can speak here, the major causes maybe high amount of stress, less amount of physical activities, and all that you must be knowing much better and giving more advices to us also. But the change in the lifestyle is one of the most important thing in the today's modern world, full of stresses, less of physical activities. It is more prone to be diabetic, and we are seeing that every second person after the age of 40-45 is getting affected by this deadly disease. It is heartening to know that Bengal Diabetic Foundation is last 10 years working towards the prevention and cure of the disease. My sincere compliment to this foundation for their great job which they are doing. They are also organizing health camps and other free checkups for the people in and around Durgapur and South Bengal, which is a great noble cause. Last 7 years, they are also organizing this conference, and this conference today and tomorrow is also a part of it. There are a lot of knowledge sharing will be there, and a lot of experience sharing will be there, and good for the people who are present in this conference. I would like to convey that I would also like to give my full-fledged support to Bengal Diabetic Foundation for the noble cause in which they are working, in whatever way myself or my organization will be doing for their noble cause, and my sincere compliments in their future endeavor. So once again, thank you for all your jobs, all your noble causes which you are doing towards the society. Thank you very much.
Thank you, sir. Thank you for your kind words and your time. Now I would also call Dr. Shomi Goswami, Scientific Chairman, to share a few words.
A very good evening to all the dignitaries on the dais and off the dais. I'll just share a couple of thoughts or facts with you. In these difficult times, it's always difficult to organize a conference, but we have again pulled it off. Possibly after 2 years, we are back in a physical format. If you go through the brochure, you'll find that there are 24 different sessions that will be dealt with. And out of that, except for 123 sessions have topics which have nothing to do with a particular drug. So I think that is something which we have managed to pull off, thanks to the able captainship of Dr. Amitabh Biswas. I have been more of a non-playing captain, staying several hundreds of kilometers away. We have a very able organizing team, some of whom are on the dais, some of whom are sitting amongst the audience, who have put in a lot of time and effort to organize this conference. The success of a conference depends on active participation, depends on good scientific topics. We have some of them covered today, more will be coming, and we have some more tomorrow as well. I would request all of you to participate actively and enjoy the scientific feast. And of course, a big thanks to everyone and anyone who has contributed to this conference happening today, both the sponsors, the delegates, as well as to all members of the organizing committee. With that, I hand it back to our master of ceremony.
Thank you so much, sir. Before we begin, so a basic schedule for today, we'll be followed with 2 sessions, post which we'll have a dinner. So for the scientific sessions, I would now hand over the dais to Dr. Piyush Rajan Nayak to conduct the following scientific sessions. And a very big thank you to all the delegates on the dais. Right now? I would kindly request everybody to please stand up for the national anthem.
अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे।
So before I hand it to Dr. Piyush for the scientific sessions, just a gentle reminder to everybody present in the hall, kindly maintain silence while the sessions are on. Also, kindly turn your mobile phone's ringtone into a vibration mode. Thank you so much.
Hello. So, very warm evening to all of you. This is a very, I am feeling proud to stand here before introducing myself and the chairpersons. So, this scientific session is very important for all of us and all the doctors and all the delegates, those who are present here. So, before starting, I just want to say that kindly maintain decorum and switch off or put your phones in vibration mode so that it will not create any kind of disturbance. For starting session 2 will be starting now, and I introduce a chairperson, Dr. Sunitra Mandal, who is consultant endocrinologist, Health World Hospital, Dr. Urmi Sanyal, consultant Obs Gynec, Mission Hospital, and Dr. Pradeep Ganguly, who is consultant diabetologist from Bolpur. So I request all the chairperson to come to the dais, please. So Dr. Sunitra Mandal, Dr. Urmi Sanyal, and Dr. Pradeep Ganguly. I request all the chairpersons to kindly introduce our speakers for today's session. Those are Dr. Utyog Gupta, Dr. Bodhan Das Munsi, and Dr. Hars Durgia. So over to you, sir.
Good evening, everybody. So endocrinology is a very subtle subject. And so when a patient comes with a thyroid function report, there can be any permutation and combination of the TSH, T3 and T4. And it's very necessary to read between the lines. So for this, a pleasure to welcome Dr. Utyog Gupta. He is a very well-known name in the field of endocrinology, consultant endocrinologist at Medica Super Specialty Hospital, Kolkata. And so he'll be talking or making sense of funny thyroid function tests.
Thank you. Good evening, all. At outset, I'd like to thank Team Bdcon for inviting me in today's talk. And thank you, chairpersons, for the kind introduction. Okay, so today we are here to discuss making sense of funny thyroid function test. It's not funny, it is discordant thyroid function test, because we know the interpretation of thyroid function test is relatively straightforward. Sometimes when T4 and TSH results do not come as per expectation, then those discordant situations arise. We will start with few scenarios. These are not typical cases, these are real life cases we have faced in last 1 month. Number one is a 38-year-old female, primary infertility, IVF pregnancy at 9 weeks gestation, have some non-specific complaints and undergone a thyroid function test, found to have raised T4 level, which is excess out of range with suppressed TSH. So she had the provisional diagnosis of gestational thyrotoxicosis and referred to endocrinology. So the question is, what else? Second case is a 52-year-old female, 52-year-old male, non-diabetic, hypertensive. He is ill, having multiple problem, acute exacerbation of COPD, LRTI, congestive cardiac failure, leukocytosis, deranged vital parameters, deranged blood sugar levels, and it found to have low T4 level and low TSH. So our internal medicine resident has kept a provisional diagnosis of whether central hypothyroidism is there and referred to us. Third case presented in a gastro OPD, a known hypertensive patient presented with some GI complaints, and as weakness was there, he had undergone again thyroid function test from gastro and found to have excess free T4 level with normal TSH, as TSH is inappropriately normal here. So whether patient is having any central cause of excess TSH, and that's why he was referred to us. So we will discuss these case scenarios with the following heading: brief overview of thyroid physiology, what are the potential interference or confounding factors, how to interpret the TFT or thyroid function test, followed by conclusion. So this is the basic thyroid physiology we are familiar with. We know in response to, just as a recap, in response to TRH from anterior pituitary, TSH is secreted, and TSH causes secretion of and T3 from secretion of T4 from thyroid gland. It is to be remembered that action of thyroid gland is mediated by thyroid receptor alpha and beta gene, which encodes for 3 types of nuclear receptors: alpha 1, beta 1, and beta 2. This knowledge is important to understand thyroid hormone resistance. Thyroid receptor alpha is present in CNS, cardiac, and skeletal muscle. Beta 1 in liver and intestine, and beta 2 in hypothalamus and pituitary. And also, deiodinase is an enzyme which converts centrally and peripherally T4 to T3, which mediates its action. And when we go for a thyroid function test, we generally prescribed both T4 and TSH. And we know that T4 and TSH goes in opposite direction, because there is a log linear relationship which shows that when there is some degree of change in thyroid function, there is some degree of change in thyroid function, so there is much excursion or deviation in TSH values, though T4 and T3 can be within normal range. With this background knowledge, we will see what are the potential confounding factors we should keep in mind when we go by our clinical OPD. Number one is, when we go for thyroid function test, it is very common that altered binding of thyroxine due to thyroxine binding globulin level alteration, because we know thyroid hormone high protein bound. It is bound to thyroxine binding globulin, albumin, and transthyretin. In all hyperestrogenic states, there is increased thyroxine binding globulin level, just as pregnancy, PCOS, where the patient is on oral contraceptives, biliary cirrhosis, etc. And all these cases, there is excess total T4 level. Vis-a-vis, in decreased TBG binding is seen in androgen, glucocorticoids, nephrotic syndrome, systemic illnesses. In these cases, total T4 can be inappropriately low. So these are the cases where you can go for free T4 measurement to interpret the result. Another similar condition is familial dysalbuminic hyperthyroxanemia, where there is altered binding between T4 and its binding protein TBG, causing a similar scenario. There is excess total thyroid hormone level, though the free hormone concentration is within normal range and TSH is within normal range. So when you come across an excess T4 level, we can keep in mind that whether these conditions do exist or not. Pregnancy, as we have shown in the first case, is an important condition. Two things we have to remember: that number one, as we have mentioned, pregnancy is a cause of excess TBG level. As TBG is more, so total T4 level is 1.5 times the normal range, normal reference range during pregnancy, and up to 1.5 times raised T4 level should be inferred as normal T4 level. In first trimester, there is excess HCG, and this HCG act on TSH receptor, causing excess T4 and T4 secretion or thyroid hormone level, and there can be suppressed TSH also. This is seen in first trimester. From second trimester onwards, thyroid function goes again in the previous normal range. So when you interpret thyroid function test in the first trimester, there can be this thyrotoxicosis like picture that we should keep in mind. Assay interference is by far most neglected yet very important in endocrinology. Very briefly, we will not go into details. When we measure TSH and thyroid hormone, there are basically two types of assay. When we measure large molecule like TSH, we generally go for sandwich assay or immunometric assay. The picture is shown here. In small molecules like T3, T4 level, we generally go for competitive immunoassay. This is the principle of sandwich assay or immunometric assay, where there are two antibodies. Can we have the pointer? These are two antibodies. One is the capture antibody, which is bound to a solid phase, and another is signal antibody or detection antibody. So basically, both these antibody bind to different epitopes of TSH, and TSH here acts as a bridge between these two antibodies, and this is detected in immunometric assay. If there is heterophile antibody, then there can be positive as well as negative interference. Positive interference, as it is shown here, that this heterophile antibody acts as a bridge between these two molecules, and there can be excess signal even in absence of TSH. So false high value. Similarly, if there is blocking antibody, then this blocking antibody blocks this capture or detection antibody, and that can cause false low value or negative interference. So when we interpret sandwich assay, we should keep in mind this interference of this heterophile antibody. Thyroid hormone assay, as we have mentioned, we generally go for competitive immunoassay, where the analyte or the labeled molecule competes with the TSH in blood, compete with the hormone, that is T4 in the blood, to compete with the detection antibody. And the amount of labeled antigen displaced, that denotes the hormone concentration. There can be several immunoassays, two-step, one-step, or label antibody. Will not go into details. The best is if we go for equilibrium dialysis, where we can measure free hormone concentration, or LC-MS/MS, but those are not readily available because that needs a lot of expertise and infrastructure that is not everywhere. So the commonly used is immunoassay for measurement of thyroid hormone. And these are the potential interfering factors that can cause interference regarding interpretation of or discordant result of total T4 and T3 levels. Some we have discussed. Common one should be remember is interference due to heparin, because heparin, both unfractionated and fractionated heparin, increased lipoprotein lipase level that causes excess fatty acid from triglyceride to fatty acid conversion, and this fatty acid displaces T4 and T3 from the TBG or binding sites, causes excess free hormone level. So these are the case where thyroid function test should be done prior to administration of heparin or by measurement of total rather than free T4. Amiodarone is a potential confounder, very commonly used drug, which contains 37% of iodine by weight. As there is excess iodine due to Wolff-Chaikoff effect, if you give amiodarone, there can be transient increase in TSH level. There can be a hypothyroid-like state. Along with during progression of time, after 3 months approximately, it again comes down to normal if there is recovery from Wolff-Chaikoff effect. If that doesn't occur, then patient can lead into amiodarone-induced hypothyroidism. Amiodarone inhibits type 1 dehydrogenase, so T4 to T3 conversion is less. There can be excess T4 and low T3 level as well. Amiodarone has potential to cause thyrotoxicosis. Amiodarone-induced thyrotoxicosis is very common. There can be amiodarone-induced thyrotoxicosis type 1 and type 2. Type 1 occurs, the pathophysiology is similar to Graves' disease, and we have to stop amiodarone and we have to treat as well. Type 2 amiodarone-induced thyrotoxicosis, which is more common. This is destructive thyrotoxicosis. So you can continue amiodarone and you may use prednisolone as well. So several alteration in thyroid function test result can occur in this. Non-thyroidal illness, again a very important condition. It is wise not to interpret thyroid function test when patient is critically ill, as we often do in our clinical setting or in our inpatient ward. Non-thyroid illness can present in all sort of bizarre presentations. General dictum is the T3 becomes low initially. That's why it is called low T3 syndrome or sick euthyroid state. If it is severe, it can cause low T4 and low TSH as well. During recovery of sick euthyroid state, TSH can be high also. So all form of permutation combinations can be there. And in a critically ill patient, unless it is strongly indicated, do not go for thyroid function test or interpret with caution. So briefly, TFT patterns, there can be several permutation combinations of this FT3, FT4 or TSH level. These are the causes. We will not narrate this chart. We will take these causes individually. This is very simple. TSH is low and T3, T4 is high. So it is thyrotoxicosis, very simple. And two principal causes are hyperthyroidism and thyroiditis. We will not again go by the individual causes, and to distinguish between two causes, we have to go for an iodine scan. In thyroiditis, there is reduced uptake, and we know in hyperthyroidism, there is excess uptake in the thyroid gland and salivary gland uptake is low. So in thyrotoxicosis, next step is thyroid scan ideally. Primary hypothyroidism, very common and easy scenario. We should go by the causes of hypothyroidism, not difficult to interpret. Problem occur when there is low thyroid hormone level, but TSH is not high as expected. It is either normal or inappropriately low. The primary reason is the most common is non-thyroidal illness, as we have said. So when you come across isolated low T3, T4 level, think of non-thyroidal illness first. And if it is not there, there can be other causes as well. Recent overtreatment of hyperthyroidism or central hypothyroidism or isolated TSH deficiency. So less TSH from pituitary and as a result, less thyroid hormone level from thyroid gland. Vis-a-vis excess T3, T4 level, but TSH is inappropriately normal or on the higher side. Again, confusing scenario. First thing comes in our mind is TSH secreting pituitary adenoma, but the most common scenario we face, this is, as we have said, is assay interference. Several forms of assay interference can cause this sort of discordant values. Poor compliance to thyroxine therapy can lead to this kind of thyroid function test. Drugs, non-thyroidal illness, these are important causes. So once you exclude assay interference, confounding drugs, non-thyroidal illness, then only go for differential of TSH secreting pituitary adenoma or thyroid hormone resistance. This is the differentiating points or a scenario, how to differentiate between these two conditions. This is hardcore endocrine topic. Very briefly, in resistance thyroid hormone, you can have a positive family history, and if you get a large pituitary adenoma during your MRI examination, it becomes very easy to go for a diagnosis of TSH secreting pituitary adenoma. Biochemical test, either excess alpha subunit or alpha subunit of TSH molar ratio, that is not easily available. SHBG is easily available option. We can go for it, which is more in TSHoma, but we should remember as growth hormone decrease TSH level, growth hormone decrease SHBG level. So combined growth hormone TSH secreting pituitary adenoma, it can be inappropriately normal. And TRH stimulation, if we go for TRH stimulation, that there is exaggerated or response if resistance to thyroid hormone is there. I will not describe the protocol. In TSHoma, it has blunted response. T3 suppression test, again, resistance to thyroid hormone, it gets suppressed. TSHoma, no suppression. If we administer somatostatin analog or octreotide for long time, then in TSHoma, there is suppression in the thyroid hormone levels. MRI pituitary, we have already discussed. So these are very briefly how to differentiate between resistance to thyroid hormone and TSHoma. These are some genetic disorder too, we have already discussed, where you can find excess T3, T4 level where TSH is normal. First and second, we have discussed. Third, MCT8 mutation, this is transporter mutation. So along with typical clinical feature of mental and psychomotor retardation, you will have normal or low T4 level where T3 is more. Selenoprotein is a part of deiodinase enzyme. So decreased conversion of T3, T4 to T3. So excess T4, low T3 and normal TSH along with classical features have selenoprotein deficiency. If TSH is isolatedly increased or decreased with normal thyroid hormone levels, then it is pretty easy subclinical hypothyroidism as well as subclinical hyperthyroidism. But along with that, you should remember the other causes or confounding factors as we have described as well. So to briefly, this is the way. Once you come across a discordant thyroid function test, do not jump into conclusion. Go by the clinical history. If any suggestion is there, see whether that important potential confounding factors that are present or not. And subsequently, you should reassess the thyroid function test according to your assessment. And you should go by the causes of the discordant thyroid function test. So the number one case, it can be a gestational thyrotoxicosis, but in first trimester, HCG effect is more common. The second case, patient is critically ill, so do not jump into the diagnosis of central hyperthyroidism. Non-thyroidal illness is the most common scenario. And third case, though it can be TSH secreting pituitary adenoma, but when there is excess T4 level or this sort of discordant level, you should repeat your thyroid function test, preferably using a separate assay platform. To conclude, or in briefly, the message in short is repeat your thyroid function test once before jumping into conclusion of TSH secreting adenoma, which is relatively rare in comparison to assay interference. A very few words about some antibodies, thyroglobulin antibodies, only important during management of differentiated thyroid carcinoma. Thyroid autoantibodies, anti-TP antibodies, message is you should remember it is present in a significant portion of general population also. Graves' disease, if you are suspecting, you should go for TSH receptor antibody test. It is for diagnosis of Graves' disease, and in pregnancy, it has relevance to see whether there is fetal affection or fetal thyrotoxicosis is there or not. So to conclude, in most cases, the results of thyroid function test are pretty straightforward. Combined measurement of TSH and thyroid hormone should be incorporated for screening. This is extremely important. We generally learn in our medicine textbook to go for TSH only, but go for T4 and TSH both. Discordant thyroid function test not infrequent, and a structured approach, careful clinical assessment and knowledge of the conditions and judicious interpretation of this thyroid function test avoid inappropriate management or incorrect diagnosis. So it is basically a balance between T4 and TSH, and you have to understand the physiology. Thank you all. Thank you for patient hearing.
Thank you so much, Dr. Saha. That was a very elaborate and also at the same time very lucid presentation. We will take all questions at the end of the 3 talks.
Good evening, everyone. Preconceptional counseling is extremely important to us obstetricians. If the mother and her family is well counseled, then we can expect a safe pregnancy and a healthy baby. So to discuss the topic of preconceptional counseling in a type 2 diabetes mellitus mother, I would like to take the pleasure of inviting Dr. Bodhan Dash Munshi to the stage. He is at present working as the assistant professor in Kalyani Medical College.
Good evening, everyone. I would like to thank the organizers, the chairpersons, and members in the audience, and the senior teachers who are present out here. Okay, my practice in Durgapur started with the story of this 28-year-old newly married woman with type 2 diabetes planning to conceive. And so does my talk out here. And how was the management done? That's what I'm going to elaborate over the next 20 minutes. So let's give a pseudonym to the patient who had come. Let's name her Karina for the sake of a discussion. And let us see the transition of the lady to the mother, the journey from the lady to the mother. So let's analyze the history which was given. A 28-year-old type 2 diabetes mellitus lady who has just been married. So if Karina conceives right now or conceived then what should we term the diabetes status post-conception? Any answers? So the word pre-gestational or pre-existing diabetes mellitus is the term which is used. So this brings us to another question. If there is something called as pre-gestational, there must be something called as gestational also. So let's think about the term pre-gestational diabetes mellitus. Pre-gestational diabetes mellitus is any diabetes which has been detected prior to pregnancy, or if it gets detected in the earlier part of pregnancy, if the diagnostic values are of the non-pregnant levels, then we can diagnose it as pre-gestational diabetes mellitus. During any stage of the pregnancy, we can do so. Let's talk about it with the numbers and the figures and why we're discussing it out here. It constitutes about 1 to 2% of all pregnancies and 13 to 21% of diabetes in pregnancy. And as we are discussing it in Durgapur, we must know that its prevalence is more common in the low and middle income countries. Now, why discuss PGDM over here? The reason is we want 2 generations to be healthy. For one generation which has come to, or which had come to me, it was my responsibility to lead to a healthy second generation. Why should we know about it? Because type 2 diabetes mellitus in a lady can have adverse effect
on the maternal and fetal outcomes, some of which include the congenital malformations, the early pregnancy loss, preterm birth, and etc. Why does this happen? What constitutes the core basic pathogenetic mechanism? The underlying hyperglycemia or the raised blood glucose. So, for today's discussion, our focus will be on the preconceptional phase of pregestational diabetes mellitus and the management of glycemic control therein. However, is Karina's story complete with only the preconceptional PGDM discussion? I think the answer from the audience will be no. And we also need to discuss certain aspects of glycemic management during pregnancy, that is during the antepartum, intrapartum, and also the postpartum period. However, for sake of time, I'll be discussing only the preconceptional phase in details. So when Karina presented to the OPD, what was to be done? As clinicians, first is history, second, a detailed clinical examination. But wait, there are certain other things which needed to be done. What was it? A referral to an ophthalmologist for a dilated retinal examination, looking for a thyroid abnormality if present, and ordering certain tests for monitoring the blood glucose, including the glycemic values, HbA1c, creatinine, and the urine ACR. So, from my OPD, where is Karina supposed to go? Am I the only person who is supposed to manage Karina during this period, from her ladyhood to the mother or would-be mother? No. There are multiple players in the team. Those, the physician team, considering constituting the endocrinologist, diabetologist, or any person who has expertise in managing diabetes in pregnancy, or not or, and the obstetrician, the other team members, vital and should not be forgotten, the dietitian, diabetes educator, ophthalmologist, and as and when required, other members of the medical team. So now, Karina starts her preconceptional counseling. First stage, to explain to her the effect of diabetes mellitus on pregnancy and also the effect of pregnancy on diabetes mellitus. Coming to the effect of diabetes on pregnancy, there is a state of hyperglycemia, and one of the reasons is decreased insulin. As we know, glucose can travel across the placenta, however, insulin might not. So because of this, there is increase in substrates such as glucose, amino acids, and lipids, which cross across the placenta. The mixed nutrients evokes an increased insulin response from the fetal pancreas, which leads to growth, causing macrosomia, and the complications which follow therein. The neonate can be born with hypoglycemia and future possibilities of obesity, impaired glucose tolerance, and diabetes mellitus development in the child. The maternal medical risks, the obstetric complications, and the fetal neonatal risks are something which Karina needed to know. Amongst them, important ones include fall in sugars, just like any diabetes management, hypoglycemia concern. The other two, microvascular complications, which become important not only for a pregestational or the preconceptional phase, but also during the pregnancy and subsequently, are the diabetic retinopathy and diabetic nephropathy, if they have developed in the lady. Our history started in a type 2 diabetes mellitus patient. Remember, diabetic ketoacidosis as depicted here is more common in type 1, but it can happen in certain situations in type 2 diabetes mellitus patients also. The obstetric complications, which Karina needed to know. There was probable macrosomia. Macrosomia probably associated with a difficult delivery. So induction might be difficult sometimes. leading to instrumental delivery or to cesarean sections. During the childbirth, she can have problems. There might be complications in the form of shoulder dystocia. And the other problem which should be remembered in any pre-existing diabetes mellitus patients, the metabolic abnormalities. Also, the progression in pregnancy and its manifestations therein, such as the preeclampsia. Fetal and neonatal risks are important and need to be remembered because we are talking about 2 generations. So we as doctors have responsibility not only for 1, but 2 generations. And the complications which can happen in the would-be child need to be explained to the mother, would-be mother also during this phase of preconception. Now, what can be the goals of preconceptional care in Karina? The first step, as started in the OPD, was with the patient education and the counseling. Now, the details of counseling and education will also include the glycemic management. The glycemic management, including the monitoring and the optimization of the glycemic levels. Last but not the least is also the management of the abnormal glycemic levels which might exist before conception and during pregnancy and also in the post-delivery phase. Let's come to the targets. As doctors, we need to know what are the targets. So pre-conception, what is the target HbA1c? The answer is it's less than 6.5. To explain to Karina, we needed to tell her that it should be as close to normal, which might be lower, but that should not cause any disruptive hypoglycemia. And why is that? Because good glycemic control is associated with reduced risk of congenital anomalies, preeclampsia, macrosomia, preterm birth, and other complications. Now, the glycemic targets preconception. There is debate regarding the exact levels, but just to mention from one of the sources or one of the references, the pre-meal capillary blood glucose can be 80 to 110, while the 2-hour postprandial glucose can be less than 155. This is slightly on the lower levels compared to the standard patients, means the patients who are not trying to conceive. This is taken from an up-to-date source. So the glycemic targets during the preconceptional phase have been explained, but Karina also needs to know from now itself, or needed to know from the beginning, what could be the targets during pregnancy. Again, the guidelines mention different values according to the country or the continent we live in, but because we are in India, that's why the fasting levels as per the ICMR 2018 guidelines, the target was fixed at less than 90, 1 hour postprandial at less than 140, 2 hour postprandial at less than 120, and there should not be any hypoglycemia. Without it, if less than 6% HbA1c can be reached, that's best. However, if that cannot be reached and there is risk of hypoglycemia, then anything less than 7. So targets, then comes the monitoring. The monitoring can happen in the lab, but pregnancy is vital and precious for both the mother and the would-be child and the family. So anyone who is trying to conceive can go for aggressive measures. So a self-monitoring of blood glucose or a CGM, continuous glucose monitoring, more so in the type 1 diabetes patients who are on multiple subcutaneous doses of insulin, is something which needs to be remembered. Now let's take a look at 3 situations where Karina could have been. Karina has diabetes, type 2 diabetes, not on medication, only on diet and lifestyle, but her glycemic control is poor or glycemic control is deranged. So apart from diet, lifestyle modification, we can introduce drugs. Now comes the $1 million question. Which drugs? Since afternoon, we have been discussing multiple agents in multiple situations. But over here, two drugs need to be remembered as broad categories: the biguanides and insulin. The second scenario, where Karina is again on multiple OHs as discussed, there might be controlled or uncontrolled glycemic levels. What is to be done? Because we are advising for conception, so a regimen which would be acceptable during pregnancy, the form of insulin and metformin, and avoidance of the other agents should be adopted. The third scenario, where Karina is on treatment with insulin and metformin. However, the glycemic levels are totally uncontrolled. So it requires aggressive insulin management, might be multiple subcutaneous doses, or use of insulin pumps if required, with monitoring as strictly as possible for the optimum outcome of the would-be mother. The other aspects which are the pillars of treatment of any patient with diabetes mellitus include the diet, weight optimization or weight management prior to pregnancy, and a proper exercise prescription. Medical nutrition therapy, depending upon the body weight, the calorie requirement is given, and it has to be distributed in adequately sized meals with snacks in between, with appropriate distribution of carbohydrates, fats, proteins, and other components. The weight gain. If the picture in the beginning was that of someone who looked obese. So before pregnancy, weight loss, before actually conceiving, weight loss should be advised in ladies with type 2 diabetes mellitus. And during pregnancy, the advice for weight gain should be based on the pre-pregnancy BMI as depicted. Now, all physicians, all doctors sitting out here, and all members of the treatment team, the drugs in contention for discussion. The drugs which can be used safely include the rapid-acting analogs, especially Lispro and Aspart, the basal insulins, NPH, and the short-acting regular human insulin is also used, but rapid-acting analogs, according to the guidelines, are more preferred. Now that leaves certain other drugs like glulicin, digludec, and glargine. Well, there is data on its use and successful use. Digludec is undergoing a trial nowadays against NPH, and the data should be out in a few days. Though I've mentioned the word glyburide, but it's important for every student or every PGT out here to remember that it's insulin and metformin from pre-gestational phase or the preconceptional phase till completion of pregnancy. Now, the concerns for us of every day. Karina has to be educated about hypoglycemia symptoms identification and its appropriate management. And she should not conceive till appropriate glycemic control is achieved. According to the NICE guidelines, a HbA1c greater than 10, the lady or Karina should be advised not to conceive till adequate control is achieved. So what are the other drugs which can be given to her to ensure a better outcome? Folic acid supplementation. The dosing varies across guidelines. The recently published ADA gives at 400 micrograms per day, while the 2015 NICE guidelines updated again with minor corrections in 2020 gives it as 5 milligrams. And there should also be intake of iodine, 150 micrograms per day with in the form of potassium iodide. Dyslipidemia in type 2 diabetes mellitus patients require discontinuation of statins. Always, while discontinuing or using one drug, risk versus benefit has to be noted. And patients who are at high risk of myocardial infarction and stroke, their lipid control requires a revision. Blood pressure or hypertension control is also important, and that requires targets pre-conception or early pregnancy, there is minimal data. But if it is during pregnancy, the latest guidelines give it between 110 to 135 millimeters of mercury, while diastolic is between 85 mm of Hg. Discontinue drugs which can have embryopathic effects or which can have teratogenic effects. Amongst the antihypertensives, AC inhibitors or ARBs, that is commonly the ramiprils and the telmisartans, should be discontinued in this patient and the appropriate agents chosen. Though I have mentioned aspirin, but its role is only there after the lady conceives. Two diseases or two microvascular complications which I talked about initially, the diabetic kidney disease. Now remember that pregnancy does not increase the risk of development of diabetic kidney disease. However, if there is pre-existing diabetic kidney disease in the form of moderate albuminuria or overt renal failure, then permanent worsening of renal status can happen post-pregnancy. So this knowledge has to be given to Karina. And what are the risk factors in that? The uncontrolled hypertension, elevated serum creatinine, and an elevated urinary protein more than 3 grams. That might require a super specialty referral to a nephrologist. And remember the use of the correct choice of drugs. Cause and effect, moderate albuminuria, overt nephropathy, resulting in preeclampsia, and the child being born IUGR, IUD, preterm birth. Retinopathy and pregnancy should never be forgotten. Proliferative retinopathy is the topic of concern. As mentioned, dilated retinal examination screening should be done. However, the treatment for proliferative retinopathy should be started before conception. Important to remember to counsel Karina is that during her pregnancy, monitoring and follow-up, pre-pregnancy, post-conception, first trimester, again, if proliferative is present between 16 and 20 weeks, and then again at 28 weeks, and also post-pregnancy is important. The pre-gestational retinopathy status and the degree of glycemic control along with the risk factors determine its severity. The monitoring of the fetal well-being is taken care by the multidisciplinary team, OBG, and ultimately our target from the preconceptional counseling to the pregnancy, antepartum, intrapartum, postpartum with its glycemic monitoring, management of hypertension, and postpartum management is a healthy baby from a healthy mother. So the story of Karina will continue next time, with a journey maybe through during and the post-pregnancy story. This is in a nutshell about the preconceptional counseling of pre-gestational diabetes mellitus patients. Thank you for a patient hearing.
Thank you, Dr. Bonhan, for such an elaborate discussion. We'll take questions at the end.
Thank you.
Increased bone fragility and increased risk of bone fracture are now recognized complication of diabetes. But this increased risk is independent on the reduction of BMD, that is bone marrow density. Actually, there is quality of bone is deteriorated due to certain complex molecular and structural mechanism. Now, our next discussion is risk. Next topic of discussion is bone fragility as a complication of diabetes, risk factors, and assessment. The speaker is renowned endocrinologist, Dr. Harsh Durgia. He is DM endocrinologist, and he is presently at IPGMER, Institute of National Importance at Pondicherry, He is postdoctoral fellowship in diabetology, IPGMR. He is MD in general medicine, Ahmedabad, and areas of interest is a diabetes super specialist at Rajkot. I welcome you, Dr. Durgia, for your presentation.
Thank you, respected chairpersons, for kind introduction. Good evening, everyone. At the outset, I would like to thank Bengal Diabetes Foundation for this invite. I am Dr. Harsh Durgia, and I would be talking on this topic, that is bone fragility as a complication of diabetes, risk factors and assessment. So this will be the presentation. First, we will be discussing about the epidemiology, like how common is osteoporosis in patients with diabetes. Then we will see risk factors, like the risk factors between type 1 diabetes or type 2 diabetes, do they vary, and if they vary, how they vary. And then we will see how to assess the bone fragility in patients with diabetes. So to start with, the pooled relative risk of any fracture in patients with type 1 diabetes is around threefold. That is, the relative risk is around 3. And the relative risk for hip fracture is around 3.78, and for spinal fracture it is 2.88. The similar analysis in type 2 diabetes gives the relative risk of 1.3 to 1.8 in patients with type 2 diabetes. So definitely diabetes is associated with greater risk of fractures, with a relative risk of anywhere between 1.5 to 4. And fracture risk, this risk is definitely more in type 1 diabetes than type 2 diabetes. This risk extends throughout the lifespan, and it starts 10 to 15 years earlier than non-diabetic population. And it is also related to duration of diabetes. And considering the prevalence of diabetes, as we know that the prevalence of diabetes is increasing day by day, it becomes very important to be vigilant about this serious yet neglected complication, that is bone fragility. So let's see the risk factors. But before that, just a word on how insulin will affect the bone metabolism. Insulin promotes bone formation. It exerts direct anabolic action by activation of its cognate receptors. It has the effect on osteoblasts. Along with that, along with insulin, amylin is co-secreted, and it also has shown to have effect on bone mineral density. Plus body mass index, that is BMI, has a positive correlation with BMD. So what it means is that obesity or overweight is a protective factor as far as the bone mineral density or osteoporosis is concerned. So the increased risk of fragility fracture is dependent on type of diabetes, glycemic control, and presence of complications. Type 1 diabetes has shown to decrease BMD ranging from 8 to 67%, with hip being the worst affected, followed by the vertebra. And why it is so? Because of insulin deficiency. We know that type 1 diabetes is a state of absolute insulin deficiency, and insulin is an anabolic hormone for bone. So insulinopenia will lead to the bone loss. Plus, along with that, there is a high proportion of vitamin D deficiency, and low IGF-1 levels in these patients will lead to the low bone mass. Poor glycemic control during adolescence can affect BMD. We know that adolescence is a period of bone accrual, which leads to the peak bone mass. So if the glycemic control is poor during that phase, it leads to the effect on bone accrual, which leads to the lower peak bone mass. On the other hand, bone mineral density is increased in patients with type 2 diabetes. And major reasons behind this is hyperinsulinemia. Again, type 2 diabetes is a state of insulin resistance. Insulin levels are increased. There is hyperinsulinemia, so it leads to the higher BMD. Along with the, we know that majority of the diabetic patients are obese or overweight. So that also can be one of the reasons why BMD is higher in these patients. So this takes us to the diabetic paradox of bone fragility. That is the risk of increased bone fracture in background of higher bone mineral density. And it has been proven beyond doubt that in various meta-analysis also that BMD is higher in type 2 diabetes, and it has a positive correlation with body mass index and HbA1c levels. So coming back to this diabetic paradox, So as we have seen that BMD is on the higher side. So quantitatively speaking, bone is good, but qualitatively it is poor. So there is an alteration in bone microarchitecture leading to poor bone quality and increased cortical porosity, which may be responsible for the increased fragility fractures as far as type 2 diabetes is concerned. So it has been proven, even in studies, it has been shown, like this study was published in 13 in JBMR, and they have shown that there was a greater relative porosity, 5-fold increase in the relative porosity at distal radius in patients with diabetes as compared to the non-diabetic patients. And this cortical porosity is still worsened if the patient is having microvascular disease, such as peripheral vascular disease also is there. It will worsen cortical porosity still more. Additionally, sclerostin is also found to be increased in patients with type 2 diabetes. And what is sclerostin? It is a glycoprotein secreted from osteocytes, and it acts as an inhibitor of bone formation. It acts in WNT beta-catenin signaling pathway, and it inhibits osteoblast formation. And levels of sclerostin have been found to be increased in type 2 diabetic patients. Along with that, hyperglycemia leads to the oxidative stress, leads to the increase in reactive oxygen species, which will lead to the formation of advanced glycation end products. And these advanced glycation end products will act on, will lead to the defective collagen cross-linking, and this will inhibit the adhesion of osteoblast to bone matrix, plus binding of AGE to its receptor in pre-osteoclast will increase the cytokine secretion, thus reducing the osteoblastogenesis and increasing the osteoclastogenesis, thus leading to increased bone fragility. Along with this, diabetes mellitus is also associated with the increased risk of falls. The risk ratio is around 1.64, and it is more pronounced in patients who are on insulin. And the factors leading to increased risk of falls include hypoglycemia in patients who are treated with insulin or sulfonylurea, peripheral neuropathy leading to loss of protective sensation, numbness, motor neuropathy, foot ulcers. All this will increase the risk of falls. Retinopathy by causing vision impairment will lead to fall. Vitamin D deficiency by causing proximal muscle weakness and sarcopenia can increase the tendency to fall in this patient group. Now coming on to effect of anti-diabetic medications on bone metabolism. So starting with metformin, it favors bone integrity. It is neutral, or it has shown slightly beneficial effect on fracture risk. Sulfonylureas on a standalone basis, they are neutral, but they can cause hypoglycemia, which can lead to fall and lead to fragility fracture. Thiazolidinediones, they have some real effect on bone metabolism because they cause activation of PPAR gamma in mesenchymal precursor cells, and this may reduce their differentiation to osteoblast, because pioglitazone, we know it shifts mesenchymal precursor cells to the formation, to the differentiation of adipocytes. So it should be cautiously used in patient population in which the fracture risk is increased, for example, postmenopausal females. DPP4 inhibitor, no known effect as far as bone physiology is concerned. GLP-1 receptor agonists, short-term studies have shown that it leads to the preservation of bone mass. And SGLT2 inhibitors, so initially there were some signals that it increases fracture risk with in the canagliflozin cohort, but later they are disproved in meta-analysis, and other SGLT2 inhibitors have not shown to increase fracture risk. Insulin, again, it is like sulfonylurea, it leads to hypoglycemia leading to fall and increasing the fragility fracture risk. So to summarize the risk factor part, in type 1 diabetes, the insulin levels are low, IGF-1 is low, amylin is low. Along with that, body weight is low. So this leads to the reduced bone mineral density. There is increased tendency to fall because of the hypoglycemia. We know that hypoglycemia is part and parcel of type 1 diabetic patient's life. So hypoglycemia, disease complications such as retinopathy and neuropathy, poor bone quality, and type 1 diabetes being an autoimmune disease There are other associated autoimmune diseases such as hypothyroidism, celiac disease, hypogonadism, all contribute to the increased skeletal fragility as far as type 1 diabetes is concerned. On the contrary, in type 2 diabetes, bone mineral density is increased, but bone microarchitecture is affected. The cortical bone quality is poor, cortical porosity is increased, plus risk of fall is always there. Anti-diabetic medications that we have discussed like pioglitazone, sulfonylureas or insulin can all lead to the increased fracture risk in patients with type 2 diabetes. Now moving forward to assessment of bone fragility in patients with diabetes. So in routine practice, what we do is we do DEXA scan for measuring bone mineral density. We do FRAX score calculation and bone turnover markers. And this is the WHO definition of osteoporosis. Like it is defined on DEXA scan, it is defined as T-score of less than or equal to minus 2.5. Osteopenia is defined as T-score of -1 to minus 2.5. Now the question comes, when to screen for osteoporosis in patients with diabetes. So in patients who have history of fracture, whose age is more than 50 years, there are clinical risk factors for fractures in diabetes such as low BMD, recurrent fall, or patients with diabetes duration more than 5 years, or on medications such as insulin or thiazolidinediones, HbA1c more than 7, or if patients have other microvascular complications such as neuropathy, retinopathy, or nephropathy. So from the point of view of clinician, the predicting the individual fracture risk is currently mainly restricted to the quantitative analysis of BMD by using DEXA scan. And about 70% of the variability in bone strength is determined by its density, that is bone mineral density. But in type 2 diabetes, what happens is this gap is even more pronounced. We have already discussed that quantitative analysis by BMD will be higher. So this gap is more pronounced in type 2 diabetes. So this is just an example. This is a CT image of a 54-year-old male with uncontrolled, poorly controlled diabetes. And as you can see, there is a vertebral compression fracture of first lumbar vertebra. But on DEXA scan, the T-score was -1.3. So it was paradoxically better as compared to what X-ray is depicting. So in such cases, vertebral fracture assessment, that is VFA, can be useful. It is an additional tool which helps in imaging the thoracic as well as lumbar vertebra to evaluate vertebral fractures. VFA compares well with conventional radiography, but at a low radiation dose. Now, like we have seen, the quantitative analysis of bone mineral density of bone is not very helpful as far as diabetes is concerned. So moving forward to qualitative analysis, so the measures, the techniques that can be used to measure microarchitecture of bone include bone biopsy, quantitative CT, high resolution peripheral quantitative CT and MRI, and trabecular bone score. Mainly, this is research based, but we will be discussing about the two techniques, that is high resolution peripheral quantitative CT and trabecular bone score in short. So among these techniques, TBS is readily available clinically. It is a non-invasive technology which permits efficient and accurate clinical evaluation of skeletal microstructure. It's a textural index. It can be done it can be calculated using lumbar spine DEXA image with the help of an additional software. It provides an indirect index of trabecular microarchitecture, and contrary to BMD, spine TBS tends to be lower among diabetes patients than control. So it is a better measure as compared to the DEXA BMD. Now coming on to the high resolution peripheral quantitative CT, it's an imaging modality. It's able to characterize three-dimensional cortical and trabecular bone density and microarchitecture of the peripheral skeleton. It quantitatively assesses the geometry, microarchitecture, and biochemical properties of bone. Several techniques have been proposed to quantify cortical bone structure and porosity from HRCT images. Microfinite element analysis is one of this technique, which is used to calculate estimates of bone strength and load distribution. But this is mainly of research purpose, not available readily in clinical practice. So just to show a couple of images, on your left side, the image B is of the normal subject. On the right side, the image C is a HRQCT image of a diabetic patient, and you can see the trabecularization of cortical compartment in that image. Similarly, in this image on the left side, you can see the control subjects with the normal cortical porosity, like normal cortex, and on the right side is the diabetic patient with fracture, and you can see the increased cortical porosity in that image. So this, like HRCT, is more of a research-based thing. So how to diagnose patient in our day-to-day practice? And we know that quantitative analysis by BMD, DEXA, they are falsely high in patients with diabetes. And even FRAX will underestimate the fracture risk because diabetes is not a direct variable to FRAX. So just to these are the parameters involved in FRAX, and as you can see, diabetes is not included as an input variable in the FRAX tool. So what to do? So as per the evidence, published evidence, like this study was published 10 years back in JAMA, and what they have noted is for a similar fracture risk, diabetic patients had a higher T-score than compared to the non-diabetic patients. So for hip fracture, the estimated mean difference in T-score for women was 0.5. So in simpler terms, what this means is osteoporosis in type 2 diabetes can be diagnosed at a T-score of -2 as compared to the -2.5 in patients without diabetes. So this is for DEXA. Moving forward to FRAX, this was a nice article by Leslie et al. Published in 2018 in JBMR. It was a registry-based cohort study involving 44,000 males and female of more than 40 years of age. And out of this, 4,000 subjects had diabetes. So what they have proposed is the adjustment to improve the performance of FRAX. They have proposed 4 amendments, that is rheumatoid arthritis input to FRAX, TBS adjustment to FRAX, reducing femoral neck T-score input by 0.5 standard deviation, and increasing the age input to FRAX by 10 years. So just to show you, again, coming back to the FRAX FRAX tool. So what they are saying is, in the column of age, you can increase the age by 10 years. So suppose the patient is 50 years of age, you can put 60 here to minimize, to mitigate the effect of diabetes. Or you can put yes in the column of rheumatoid arthritis, even though patient is not having RA, but you can put yes over there because they have considered RA as a diabetes equivalent. Femoral neck BMD reduction by 0.5 in T-score, and the 4th parameter is TBS based. So what they have concluded, so each of these proposed method was found to improve the performance, FRAX performance. However, they noted that no single method was optimal in all settings, and ultimately incorporating diabetes directly into FRAX would likely be preferred. But unfortunately, at like current scenario, we don't have diabetes as a direct variable. So till diabetes, like it becomes available, we can use this type of adjustment to improve performance of FRAX. These are the 4 adjustments. Any of them can be used. However, in this study, they have noted that the rheumatoid arthritis input is better out of all 4. So to summarize the assessment, in patients with diabetes, if the patient is having hip or vertebral fracture, there is no doubt it is osteoporosis, go for the therapy. If the patient is having no fracture, see whether the patient is having clinical risk factors. If there are no risk factors, then yearly clinical assessment or BMD every 2 years can be done. If patient is having other fracture or diabetes specific risk factors are there, or if the patient is more than 50 years of age, go for DEXA. If possible, include VFA and trabeculobone score. T-score less than -2, start therapy. Just to re-emphasize again, in diabetes, fracture risk at T-score -2 is equivalent to -2.5 in non-diabetic patients. Or you can calculate FRAX as we have discussed with the adjustment. And if the FRAX score is more than country-specific intervention threshold, go for osteoporosis therapy. How to manage? Just a couple of slides on this. So if the patient is having coexistent type 2 diabetes and osteoporosis, management of osteoporosis remains the same as in non-diabetic patients. It includes bisphosphonates, denosumab and teriparatide. Manage and monitor as per guidelines. monitor blood pressure, manage, like see whether the patient is like vision is impaired or patient is having neuropathy. If patient is having CKD, MBD, treat it. Modification of lifestyle, motivate patient to do physical activity, to lose weight if the patient is obese, exercise, and if found deficient, calcium and vitamin D should be replenished. Ask them to reduce alcohol consumption. And management of type 2 diabetes. This varies a bit if the patient is having osteoporosis or if the patient is not having osteoporosis in that case. So like the management of type 2 diabetes, preferable options are metformin, DPP-4 inhibitor and GLP-1 receptor agonist. Try to avoid thiazolidinediones. Use insulin and sulfonylurea with utmost caution, like it should not cause hypoglycemia because it can increase the risk of falls. So to summarize, diabetes is an independent risk factor for fragility fracture. Conventional methods such as like quantitative analysis by DEXA, FREX may underestimate the risk. So proper adjustment should be made while using these methods for diagnosing osteoporosis in this population. Newer modalities such as TBS may be useful, and anti-diabetic medication should be chosen very carefully in patients with bone fragility. So with this, I end my talk. Thank you for the patient listening.
Thank you, Dr. Durgia, for your lucid and elaborate presentation. Now it is the session for question and answer session.
So thank you very much, all the speakers, for their excellent talk. Now we'll go for the question and answer session. That will be for around 15 minutes. So if there is any question from the audience, you can go through the questions. So I request all the speakers to come to the dais, please. Dr. Utyo, Dr. Bodhian, and Dr. Hers, kindly come to the dais. So if you have a question, you can ask your question to our speakers, and the chairperson can also give their opinion.
Dr. Munshi, in Indian setting, which protocol should be followed for the diagnosis of GDM?
So as of now, the DIPSI criteria, the Diabetes in Pregnancy Study Group of India, diagnostic criteria, which is a one-step method, is very useful because of its advantages, which is there. The intrinsic advantages include that the patient or the lady, pregnant lady, when she's coming, in our setup, in an Indian setup where she can come from a far distance without having adequate intake of meals. She might be landing up in a center or an institute which is 3 to 4 hours away. So in such a place, when she comes, the one-step method where the 75 grams glucose is administered and the postprandial or the 2 hours value is checked is useful. But obviously, the relative advantages and disadvantages of every method is there intrinsically, as has been studied across studies. So that's common, that can be used. All depends on the setting and also on the patient's feasibility, also suitability, feasibility. That would be the preference.
Thank you, Dr. Budhan. A follow-up question for this GDM patients. Many times, few GDM patients are diagnosed very late in the course of pregnancy, that is 8th month or close to the 9th month. So in those cases, shall we directly go for the insulin, or we should follow the protocol of medical nutrition therapy or like that, anything?
So again, theoretically, it is known that from the 16th to 36th week of pregnancy, the insulin requirement increases because of the insulin resistance, which is introduced and worsened by the placental factors, which is in play. And subsequently, from 36 weeks onwards,
the requirement again can go down because maybe of the increased sensitivity, various factors which are there. So again, it depending upon the patient's profile, the complications profile, and again the plan which is there for the delivery. I think the OBG expert will be able to say when the planning after the maybe the 40th week or means by 40 weeks plus 6 days, the delivery has to be completed. So any glycemic control which has to be achieved either with the help of insulin or metformin or should be done in its appropriate form. Insulin, obviously, if quick glycemic control has to be achieved immediately, and also to prevent the complications which can happen late, such as the fetal macrosomia. So assessment of the fetus again becomes important. Whether the early intervention might be required, instrumental delivery might be required. So these factors, because your question was more of GDM. My topic was more of a PGDM. So those are the different subtle differences.
Thank you, Bodai. So any more questions from the audience?
Harsh, nice talk. Just wanted to know if saroglitazar and pioglitazone, is there any difference with respect to their effect on bone?
On bone, sir. Like pioglitazone, it is known that it is like PPR gamma activation is there. Saroglitazone, I have not gone through the studies, but as the mechanism is partially same, so it may have the effect on bone metabolism similar to the pioglitazone.
Okay. You told that there were 4 methods to refine the risk prediction, and that I'm not sure if I heard it right. Does inputting diabetes as rheumatoid arthritis perform better than actually measuring TBS, or
no, like work? What they have like theorized is that you can adjust like this diabetes, you can mitigate the risk of diabetes by involving any of the 4. So one is you increase the age by 10 years. Other is you reduce the T-score by 0.5. Third is that this one, rheumatoid arthritis, you put yes. So like in a way, previously we used to learn that diabetes is the myocardial infarction equivalent. So here it is like rheumatoid arthritis is a diabetes equivalent in fracs as far as like what they have told us.
Because one of the 4 happened to be TBS.
Yes, TBS adjustment also they have given.
And does that mean that it performs better than TBS in terms of risk prediction, refining risk prediction? In that case, TBS as such is not very commonly available.
Yeah.
If we can simply put yes for rheumatoid arthritis and it performs better than TBS,
yeah, exactly,
it would nullify one of the major indications for TBS.
What they have inferred in this study is that out of all these 4, the best is rheumatoid arthritis, the yes for rheumatoid arthritis performs better. So the thing is, in routine practice, we can just take T-score as -2. That is one thing. Or while calculating fracs, you can put yes for rheumatoid arthritis. That also can be helpful.
Okay, so that was about risk refinement or risk prediction refinement. Having diagnosed bone fragility, does diabetes per se make you choose one anti-osteoporotic medication over other?
No, like there is no difference as far as treatment of osteoporosis is concerned.
Treatment is the same.
Yeah,
risk is different.
But if the osteoporosis is there, the treatment of diabetes may vary. Like because you should avoid using pioglitazone. You should avoid using agents that cause hypoglycemia. But if there is utmost need and if you don't have choice, you have to use, but one should be cautious while using such molecules.
Thank you. Thank you.
Yes.
Actually, I have a question. I'm the odd one out here, and so many eminent colleagues of mine are here. I have to ask this. It's a bit ahead of the preconceptional stage. It's a perfect scenario where the patient is counseled and the blood glucose levels are, at levels that is very good for pregnancy. But what if one patient lands up in your clinic? Any of you can actually answer this, with a HbA1c level of more than 10, around 11. Actually, we are getting every day this. And this is a precious pregnancy. Diabetes either already diagnosed or it is the first time, like not diagnosed. So a lot of complications can happen. starting from miscarriage, congenital anomalies. So what should be our take on that as clinician, as obstetricians and as endocrinologists? Should we put them on a negative foothold just because they were not really ready or not knowing or not counseled enough to be prepared for pregnancy? Like more than 10% congenital anomalies are very high. So I have come across negative counselings where they were recommended MTP and all that. So any one of you can just give your take on that. Like counseling is very important to let them know that mishaps can happen. But for MTP, you really something very gross has to be there to counsel them. So should we go in for, means we will give them the options, but as what is your take? Do you feel they should not continue or you give them hope? What should be the form of counseling?
Okay, if I understood the question, the lady who is present is already pregnant and she gets directed to have HbA1c more than 10. So let's go to the discussion which we had in the talk. So the guidelines, the NICE guidelines 2015 modified again 2020 with certain improvements, that mentioned that when a lady who is diabetic already, means having type 2 diabetes mellitus with a HbA1c more than 10 comes, then the ideal scenario, avoid pregnancy till control is achieved.
Already
pregnant. I know. Now this scenario where the lady comes, now in an Indian setup where patients come with or ladies come with pregnancy, however the HbA1c is more than 10. So it's a catch-22 situation again. Now it's important for the doctors to counsel the patient and the family members about the pros and cons of continuing with pregnancy. It has its risks, it has its merits and its demerits. But however, I don't think MTP, unless as indicated by the recently changed 2021 guidelines, I think, as given in the Gazette of, if you have to adhere to that, if it's beyond that, I don't think it will fall under the MTP criteria.
I think the message in short, sir, is that is either patient is having overt hypothyroidism or undiagnosed diabetes in pregnancy, nowhere it is recommended that I would advise MTP. You have to counsel the patient in short. Either hypothyroidism, deranged TSH or blood sugar, MTP is not advised or should MTP. There's a please
I think there should be no confusion about it. What Bodhana said rightly, that we should strive the glycated hemoglobin to be less than 7, ideally at least less than 9 before asking for a planned pregnancy. But just because the glycated hemoglobin is 10, we should not even discuss or recommend MTP. Rather, we should explain her the risks. Number 2, optimize glycemic control as early as possible if there's no problem of retinopathy. So with insulin that can be done. The HbA1c will not come down to less than 7 before 3 or 4 months. But you can control the fasting and PP. Do not look at the HbA1c. Look at the ambient glycemia. You control it within, say, 7, 10, 15 days and maintain it and go for assiduous anomaly screen as per your protocol. That's it. There should not be any recommendation for MTP or even a suggestion. Though we acknowledge the fact that we should not allow a planned pregnancy with a glycated hemoglobin more than 9. Same for fluoride overt hypothyroidism. Even if the TSH is more than standard, you may give a loading dose of levothyroxine, 300 to 500 milligram. Start on levothyroxine, go for anomaly screen, and continue the pregnancy.
Yes, thank you. That's what I want to emphasize also. As obstetrician, I'm entirely dependent on my endocrinologist colleague to help out with the sugar controls. But with the advancement of all screening tests, imaging, we can detect very early any anomalies happening in the baby. And now, thankfully, India has given us till 24 weeks. We have open way to offer them MTP if any animal is occurred. Even very bad animal is occurring, we can offer them MTP anytime. So by 12 weeks, we are getting a down screening. By 12 weeks, we are getting very early anomaly scan. We are confirming by 20 weeks. So there is no space for offering MTP to the patients, even if they are coming down with a very bad HbA1c. And we have to believe that also when we are counseling the patients. That is so important, because patients do come to me with a very high HbA1c level, and they are counseled. They are so helpless. They are counseled to undergo MTP. And nowadays, infertility is everywhere. Once they lose a pregnancy, being pregnant another time is so difficult. So we have to also believe ourselves when we are counseling the patient, because the patients also get to know what the doctor wants out of them, whether we want the positive outcome or the negative outcome. So we have to believe that we can control the sugars and have a healthy pregnancy even with a HbA1c more than 11% and 10%, which causes a lot of anomalies. So preconception counseling is perfect, but it does not happen every day. So that's what I wanted to emphasize. Thank you.
So thank you very much. That was a very great interaction from audience, chairpersons and speakers. So now I will request all the chairpersons to felicitate our speakers. So I request Dr. Sunitra Mandal to felicitate Dr. Utya Gupta.
और सर आपका एक सीवी और आपका एक फोटोग्राफ रिक्वायरमेंट है सर, तो क्या आपने वो मेल आईडी में यूज की थी? ओके सर, एक्चुअली आई कॉन्फ्रेंस.
So big round of applause. Thank you very much, Dr. Utya, for a nice presentation, and thank you, Dr. Sunitra. So now I request Dr. Urmi Sanyal to present the memento to Dr. Bodhian Das Munsi. Thank you, Dr. Bodhian. Thank you, Dr. Urmi. Big round of applause. So now I will request Dr. Pradeep Ganguly. Dr. Pradeep Ganguly to felicitate Dr. Harsh Durgia. Thank you, Dr. Harsh. Thank you very much, Dr. Pradeep Ganguly. Now I request Dr. Amitabh Biswas to kindly come to the dais to felicitate our chairpersons. Dr. Amatta, kindly, you also. So Dr. Amitabh Biswas to felicitate Dr. Sunitra Mandal. Thank you, Dr. Sunitra. Now I will request Dr. Amatta to felicitate Dr. Urmi Sanyal. Thank you, Dr. Urmi. Thank you very much. Now I request Dr. Amitabh to felicitate Dr. Pradeep Ganguly. Thank you, Dr. Pradeep. So this is the end to the session number 2. Thank you very much to all the participants, all the speakers and chairpersons. Now we will go to session 3. So it will be chaired by Dr. Professor Samuel Kundu. Sir, please come onto the dais, please. He is Professor, HOD Department of Medicine from Bakuda Medical College. Now I request Dr. Deepak Kumar, Senior Consultant Nephrology from Mission Hospital, Durgapur. Our third chairperson is Dr. Satyajit Rai, Senior Consultant, Senior Consulting Physician from Asansol. So, chairperson, kindly introduce our speakers.
Good afternoon. And this is a very interesting session. We have three speakers in this session. The first speaker is none other than Professor Nilanjan Sengupta. He is very renowned person, and he needs no introduction in the field of diabetology and endocrinology. He will be speaking on 65-year-old lady with type 2 diabetes mellitus and DKD, DKD stage 3A, and is coming with a uric acid 7.7 milligram per DL. How to manage? Sir, please start your deliberation.
Respected chairpersons, dear friends, it's always a pleasure to be at Bdcon, and I thank Dr. Amitabh Vishwas and his vibrant team for putting up this conference once again after a hiatus of 2 or 3 years, probably because of the COVID pandemic. And Dr. Biswas and Dr. Shomi Goswami have given me a very challenging yet a topic that is close to my heart, how to decode the dilemma of hyperuricemia, essentially asymptomatic, in a patient with diabetic kidney disease. So this is the problem that has been presented to us or to you before. 5-year-old lady, type 2 diabetes, DKD G3AA2, with a serum uric acid 7.7 milligram per deciliter. So where does this patient fit into? If you go in this KDIGO plot, the patient fits in here in the orange zone and warrants treatments. So what are the issues to be addressed in this patient? We do not know about the comorbidities. We do not know the state of glycemic control of this patient. We only have certain data that I have presented to you. So the issues would be to effect and maintain glycemic control if it is not, and to use appropriate medications to achieve that glycemic control, to control other comorbidities if present, like hypertension, obesity, and dyslipidemia. And also for nephroprotection, I think, which we are more interested in. And lastly, would be to address the asymptomatic hyperuricemia, which is actually my great disease. So coming to the glycemic targets, what would be the glycemic target? It can range from 8 to 6.5, depending on many factors. What her starting glycated hemoglobin is. What is the severity of CKD? Not very severe. 3A. Age and life expectancy, I think she's only 62 years old. And resources for hypoglycemia management, how vulnerable she is to hypoglycemia, and what treatment she is already receiving. However, in this patient, without other information being available, I will still try to take her to the target of 6.5% glycated hemoglobin, that if that is easily and safely achievable. So coming to the glycemic management, we have talked about SGLT2, metformin quite a lot. SGLT2 inhibitors will naturally feature here because if we also consider nephroprotection, Also, there will be GLP-1 receptor agonist if the patient is willing and able to take a costly injectable. We have the DPP-4 inhibitors, insulin, sulfonylureas, and all other agents. So we won't be discussing it in details because obviously you can well understand. I will try to focus on some other area. And of course, for nephroprotection, we have to give an S inhibitor ARB because the patient is having albuminuria and compromised EGFR, and any class of drugs that can prevent EGFR decline, prevent albuminuria decrease, grades decreasing, is RAS blockade in the form of S inhibitors or ARBs. Along with that, now this is the KBGO treatment algorithm. The patient has to be on a maximally tolerated dosage of S inhibitor or ARB, maybe an SGLT2 inhibitor for the treatment of hyperglycemia, which can give an additional pleiotropic benefit in nephroprotection. And then the question of mineralocorticoid receptor antagonist, the recently, launched finerenone also comes. It's a costly drug, costly proposition, but that can actually decrease albuminuria to a significant extent and decrease EGFR decline. Can be used if somehow the patient cannot tolerate an SGLT2 inhibitor, or the patient has been on maximally tolerated dose of a RAS blocker, but still the patient's albuminuria is quite poor enough or decreasing. So that is not what we will be discussing. And the blood pressure targets, I think we would love to keep the blood pressure less than 130/80, if again that is easily achievable in this patient. Now, so our main interest would be to targeting the uric acid. So we would be using certain drugs for management of hypertension, for management of diabetes, and the selection of drugs can be such which may have pleiotropic benefits on serum uric acid. Like, whereas the diuretics tend to cause hyperuricemia, the S inhibitors and ARBs, notably losartan, have been shown to reduce hyperuricemia. Similarly, among the anti-diabetic agents, SGLT2 inhibitors have been shown to have uricosuric properties. So these are the drugs that should be considered strongly in the management paradigm of this lady. Now, coming to the raised uric acid level. Does this patient have hyperuricemia? Now, there are very many bodies which have defined hyperuricemia differently. In 2019, we had that IDEA consensus from Calcutta, of which I was one of the members, and we had decided on 6.8 milligram per deciliter, irrespective of gender, the threshold of normalcy of serum uric acid. So if we take that, definitely 7.7 qualifies for the definition of hyperuricemia, and she apparently doesn't have any symptoms of gout or so that can be looked upon as asymptomatic hyperuricemia. So why one should treat asymptomatic hyperuricemia if at all you are inclined to treat it? Now, coming to this patient, what would be our main concern is whether we can prevent the development and progression of chronic kidney disease. Of course, the question of acute urate nephropathy doesn't arise in this patient. And coming to the cardiovascular disease prevention, like control of hypertension and atherosclerotic cardiovascular disease with urate-lowering pharmacotherapy, I think controversies are there, and majority of the cardiologists would not believe in the benefits of urate-lowering therapy in this area and would not use it. But When it comes to nephroprotection, the story may be different. So we should actually treat or address this hyperuricemia in this lady. And the treatment not only consists of pharmacological urate lowering therapy, prior to that, that would also include lifestyle modification. So certain issues about diet, there are many misconceptions among many patients and physicians alike that if the serum uric acid level is raised, you should avoid peas, lentils, beans, spinach, so on and so forth. They are not harmful. They do not elevate uric acid. What are the agents that you should generally avoid is the animal organs, seafoods, alcohol, and fructose containing artificial sweeteners. Not the natural fructose that is there in fruits, but fructose containing artificial sweeteners to be avoided. So again, coming back to our idea consensus of management of asymptomatic hyperuricemia in presence of chronic kidney disease, stage 3 and beyond, you consider urate lowering pharmacotherapy. Therapy means urate lowering pharmacotherapy. So if you use it, now the question would be which agent to choose from. Mainly two agents that are in use are allopurinol and febuxostat. I think here febuxostat would be preferred, considering that dose modification is not required with febuxostat as would be necessary with allopurinol. And we are all aware that allopurinol can cause even life-threatening cutaneous allergic reactions, which are fortunately not that much reported with febuxostat. Generally, you start with 40 milligram, may increase up to 80 milligram per day, and febuxostat is therefore considered as safe because it has a dominant hepatic metabolism. So when we actually were working on this idea consensus, this one paper again from IPGA near Kolkata that prompted us to recommend urate lowering pharmacotherapy, and in particular febuxostat in such a situation that is hyperuricemia, asymptomatic hyperuricemia with a chronic kidney disease. And this was by Dr. Orpita Rai Chaudhury's group from SSKM, where febuxostat slowed the decline of EGFR in CKD stages 3 and beyond as compared to placebo. So I reiterate, we can use febuxostat, and it is preferred over the cheaper allopurinol because considering the necessity of dose modification which is needed, which may be needed with allopurinol, just like your linagliptin in diabetic kidney disease. You do not have to look at the EGFR, the same dose. That advantage is there with febuxostat here also. So other agents, of course, are not much in use in the management of hyperuricemia, let alone in hyperuricemia with CKD. And what would be our uric acid target? So we'll start this patient on febuxostat. But how low should we go? Because we know uric acid also has certain benefits, health benefits. It is an antioxidant as much as it is a pro-oxidant. So we should not go take the uric acid level below 4 or definitely below 3 milligram per deciliter. So the dosage of febuxostat has to be so adjusted not to keep it something, of course, under 6.8 or under 6, but not definitely under 3 milligram per deciliter. So to conclude, therefore, I think the organizers had given me this conundrum because I reiterate that all patients with asymptomatic hyperuricemia do not warrant pharmacotherapy or benefit from the same. So if you think that a patient of asymptomatic hyperuricemia who has never ever had any gouty arthritis would be prevented from developing the same if you lower the uric acid from 8 or 9 to less than that, this has no recommendation. You use urate lowering pharmacotherapy maybe after the first attack of gout. Second, as I said, when it comes to cardiometabolic disease protection, there have been ample studies that with allopurinol, there may be control of hypertension in children, even in children with elevated uric acid, but that has not translated into any great survival benefit as yet. And we have a lot of agents these days to prevent atherosclerotic cardiovascular disease in diabetes, like the SGLT2 inhibitors, GLP-1 receptor agonists, not to forget about the mineralocorticoid receptor antagonists, the statins, pioglitazone, saroglitazar, so on and so forth. So, but when it comes to kidney disease, of course, we should not forget control of hypertension. We should not forget S inhibitors and ARBs. We should keep an SGLT2 inhibitor higher in our preference portfolio. We can even think of a GLP-1 receptor agonist, and among the DPP-4 inhibitors, one like saxagliptin and linagliptin have studies showing decrease in albuminuria grades that have to be kept in mind. Which anti-diabetic agents you choose, what targets of glycemic control you choose, what blood pressure targets you choose. But when it comes to the specific urate lowering management, I think there is a strong case for giving a drug like febuxostat in this situation. So why we say so? Because evidences suggest beneficial effects on nephroprotection. And again, I reiterate, our IDEA consensus recommends pharmacologic urate lowering therapy in such cases. Febuxostat is preferred over allopurinol, the reasons I have mentioned why. And of course, pharmacotherapy needs always to be coupled with appropriate lifestyle measures. Thank you.
Thank you, Professor Sengupta, for a very convincing and informative lecture on the challenging issue. We will be taking a question and answer session after the three speakers' lectures. The next speaker will be introduced by my co-chairperson.
Our next speaker is Dr. Krishna G. Seshadri. I think he needs no introduction. His topic is Ancient Rhythms, Modern Disease. And there is a big CV of Dr. Krishna Seshadri. I'm sure he needs no introduction. Please, sir.
Thank you very much. At first, let me thank Amitav Vishwas and his team for having me here. I have a very short sojourn here, and I'm hoping that I can come back next year and spend more time. My wife talks very highly of Durgapur because she comes here almost every month. And unfortunately, I'm a visitor for the evening. I want to talk about the pathophysiology of diabetes from a very different perspective. We just talk about insulin deficiency and beta cell dysfunction. And I've been talking about beta cell dysfunction for many years. But I look at diabetes as a dissonance between us and nature. That we have four-letter word nature, and nature has four-letter word us back. I think that's the way I look at this. I'll talk a little about human evolution. I'll talk a little about sleep and light. Talk about metabolic switches and flexibilities and what it means to us. Very interestingly, let me start off with this story about light, and I'll come to it. But let me ask you, who has the most fat, right? And why is it that humans of all animals have the most amount of fat? The reason is that humans are probably the most successful, other than cockroaches, animals in evolution. We have survived by two things. One, giving up reproductive proficiency for reproductive efficiency. So that is why even now I call my mom on the phone and say, Amma, I've landed, I've reached the airport. In every other situation, there is no this kind of bonding over a period of time. We leave our separate ways. And in fact, humans and chimpanzees are the only people who have puberty. Right? Below that, there is no puberty. The second thing was to sacrifice four-legged benefits for two-legged benefits, and one of those is also develop probably the largest brain in the ecosystem. Now, the brain is a very strange thing. It's like the fetus. It's an obligatory glucose controller. You can train the brain to use some of the fuels that happens in hypoglycemia unawareness, where you use the brain actually starts storing new keto and new glycogen and new fuels. But normally the brain loves glucose. And the reason that fat was getting stored so much is to make sure that in times when problems occur, it is able to divert other fuels to the other parts of the body and send that glucose to the brain. This is what happens in the fetus also. The fetus takes up glucose like that. And insulin resistance is actually a consequence of that. When you have infection, when you have any other problem, what does it do? The body does, it creates insulin resistance so that the muscle and other parts take up other fuels like fat, but the brain gets glucose. And in fact, remember that the only way that the body reacts to any injury, external, internal, is inflammation. That's why almost all diseases of humans are inflammatory in nature. On this hand, it may be antigen antibody related. On this hand, it may be THC related, but it is always has an inflammatory basis. And so what really happens is infection and inflammation get intertwined. And anytime there is inflammation, there is insulin resistance. Right? And unfortunately, this was designed for a time when we were eating less. We were eating on time, we were sleeping on time. But we changed that. We started eating. I repeat it in every meeting. We are the only species that eats for entertainment and kills for entertainment. No other species does that. We live to eat instead of eating to live. And therefore, the body senses that there is so much fat. Dr. Nilanjan was talking about SGLT2 inhibitors. Remember that the SGLT system is so redundant that almost not a drop of glucose goes into the urine, even if you try very, very hard. In diabetes, it is set lower. There's a redundant system of catching energy back. So anything you do, because in those days it was only poverty and not plenty. Now it's plenty and not poverty. We are just poor among the plenty. So what is happening is that the body stores all of this as fat. So let me talk about what has happened. We've played with nature. What have we done? We eat more food, more frequent food, change in the quality of food, processed food, and timing of food. We have more light, we have less sleep, we have disturbed sleep, we have change in the circadian rhythm. We have less physical work, we have more sedentary time, we have more screen time. I can do another session on what happens to the ultraviolet rays during this thing, but today is not it. We have less stress, we have great snow downtime. In addition, we have less sunlight, more indoor time, more controlled temperatures. We don't even adapt to the seasons. In fact, in my house, the fight is whether the AC should be on and the fan is on, or the fan should be on and the AC is on. Whether it should be 22 degrees or 18 degrees. We don't sleep in 26 anymore. So what is happening is, what the body created as a protective phenomenon has become a predatory phenomenon. What we now know is that when you have obesity, one of the first things that happens is actually insulin resistance. In the adipose tissue, the mTOR pathway gets activated. Can you see this? The mTOR pathway is the one that prevents the cell from shutting down and saying, look, I'm not going to take GLUT4 anymore. But when that happens, there is a transcription of a particular protein called MCP. Nothing to do with men. It's got everything to do with monocyte chemoattractant protein. And what this does is it goes to the macrophages. It starts getting the T cells into the abdomen. These T cells actually come into the abdomen to help. But when they come into the abdomen, in the toxic environment in the abdomen and the adipocytes, they switch. They become killer cells. And then a jugalbandi occurs, at which time the adipose tissue, which is meant to protect your body from the fat, dies. It undergoes apoptosis. When it undergoes apoptosis, the fat goes everywhere to the liver, NAFLD, but also into the pancreas. I've used a slide from 2008. This is by Mark Doneth, who showed inflammation in the islet for the first time. And I'm sure some of you have listened to me talk about what happens when this happens. The pancreas and the beta cell, they de-differentiate, or they take another identity. Not all of them die, and wait for you to become better and start eating less. But they de-differentiate. They don't die, or all of them don't die. But let me talk a little more about this. Let me talk about sleep. What is interesting is that if you look at nature, the sun has a 24-hour cycle, right? The earth is a 24-hour cycle. And almost every organism is tuned to this 24-hour cycle. We have molecular clocks. There are only about 4 genes, important ones, that have been conserved throughout history. For a million years or more, every time the organism evolves, it throws away genes that it doesn't want, or it shuts them down. But these genes have remained for over a million years. So it's important. So every cell has a clock that oscillates, and it's sort of timed with the SCN. And I talk about it, that the daylight cycle is critical for survival. And this was recognized by Charaka. Nidhrayatam sukham dukkham, pushtikarsham balabalam, vrishta khalivata jnanam ajnanam jivitam nacha. Meaning, whether you want happiness, misery, nourishment, emaciation, strength, weakness, virility, sterility, knowledge, ignorance, life, and death, these are all depend on sleep. Right? And this is the Rig Veda. Sano adhyayasya vayam yavanna vikshamahi vikshena vasatim vaya. Sleep is like the arms of a tree that embrace the birds at night. And here we are, we ignore it, right? Why is sleep necessary? Nobody knew this. I'll tell you something. I mean, throughout my fellowship, throughout all of these, I can tell you that nobody knew what sleep was. Why you need sleep? We know the body shuts it down, but nobody knew why sleep was. Till this, please, if there's one article you should read this article by Hauser et al. There was a PhD student in the lab who trained a mouse to sleep under a confocal microscope. It took her months to train mice to sleep under a confocal microscope. But what she then showed was that when you sleep, your brain shrinks to 1/3 of its size. When it shrinks to 1/3 of its size, it opens, the parenchyma shrinks, and it opens up channels that can go. These are called cerebroglimpse channels, right? These channels can go down, and the CSF can go down and pull out the toxins and allow you to regenerate. So clearly, in human life, there is a time for anabolism, a time for catabolism, but the time for catabolism is also rejuvenation time. If in the afternoon, I'm sure many of you see 30 patients a day or 40 patients a day or more, what happens at 12:30 or 1:30 after you eat? Feel like a little nap. I remember just lying down in the sofa in my office, the book falls on me, And 20 minutes later, I can hear the sound outside, but I'm fresher because the brain has shrunk. The endolymph is able to pull out some of the toxins and let me work for a few hours undisturbed. But what is the relationship with light? And again, you know, our ancients knew this beautifully. Satvasvat bhuvanadi tasyaha paka visheshanaha smritam kala visheshanam. I always, when I was reading this, I was always thinking, you know, he's only talking about heat and not light alone. But I'm writing this chapter for the ESI textbook, and Jubin's going to be very unhappy because I've still not finished it. But I read but I was reading through it, I realized that the clocks are sensitive to thermal stimuli. It is not just the light, it is the heat also that it is similar to. In fact, so every single cell oscillates, and it is to this clock it oscillates. In fact, the first thing that is lost in diabetes is the rhythm. It's only later the first phase is gone. The first thing that is lost in rhythm, and this was shown by Ken Polanski way back in 1988. When you go home late, when you don't have enough darkness in your bedroom, when you're watching TVs in your bedroom, there's circadian misalignment. When you travel across zones, there's circadian misalignment. The first thing that goes off is the glucose. When you restrict sleep, the transcriptome shows inflammatory proteins getting upregulated and cell cycle regulators getting upregulated and downregulated. Now you think of what's happening. Why are the cancers coming? Why are the coronary artery diseases coming? It's a very interesting study, and this is what made me get into this a lot. This is by Kian et al. In 2013, and they published. What they did was they changed the rhythmicity of the rat, diabetes-prone rat, and they showed that the islet cells, their rhythmicity changes, and they have beta cell dysfunction. This was our first study on sleep disturbance and diabetes, showing a relationship between HbA1c and sleep. But this is a more gross experiment that we did as an animal study that was published in the ADA, was a poster and oral in ADA last year, but it's just going into publication. So what we did was we took rats, Fisher rats that were diabetes prone, and what we did was we had them either in a regular cycle or a reverse cycle, and then we put a few rats on a nurse's shift, alternate for more light exposure. You see the glucose is going up as happening, the triglyceride going up and the cholesterol going up. But I want you to see this. This is 3 weeks of having additional light exposure for a rat. This is a normal circadian rhythm. Can you see the beta cell is quite nice? This is a reverse light period. Can you see already this adaptations is happening? The beta cell mass is expanding. The beta cell is overworking. But this is what bothered us. In the rats that were given additional light exposure in addition to reversal, there was pancreatic damage with enzymatic degradation. We didn't see much in terms of per exposure and other things, but this is something that we saw. So that brings us back to our old question: what is happening here? There is an energy cycle. There is an energy cycle that is maintained in nature. There is a sleep-wake cycle that is programmed to the sun. There are other cycles. For example, there are ultradian rhythms. There are rhythms where, for example, women work with lunar rhythms a lot. If you see women in hostels, many of them have periods at the same time. Even I live in a home with 3 women, and I know my wife's and my daughter's cycle are pretty much synchronized, maybe a few days on the side. So we respond to those rhythms. The moon does play a role. For example, in the ancients thought that crops grew because of the lunar cycles, right? So this is something that's very interesting. Therefore, the suprachiasmatic clock that we have in the pineal gland entrains other clocks. So every time you change it, it shifts the phase later, but the other clocks are out of sync. And they take a while to adapt. And therefore, the metabolism becomes abnormal. And interestingly, what happens, when we eat, glucose is a hormone of plenty. If a cell gets glucose, it loves it. But you need the time for the cell to cleanse itself of the toxic products, and that's why you have starvation. If you don't shift from glucose to fat, what happens is there is increase. You need a small amount of ROS production. But when you don't shift from glucose to fat, and glucose and fat is available all the time, because what does glucose do? It inhibits fatty acid metabolism. It promotes its own metabolism. Similarly, fatty acid promotes its own metabolism and inhibits glucose metabolism. But what really happens is you really should be able to switch from glucose to fat half the day. When you don't do that, that's what happens in diabetes. Your ability to switch becomes lower. And that's why the tissue damage becomes more. There's an increase in respiratory chain uncoupling. UCP2 is increased. I won't do this. I can do this in detail for another audience. But what you have is an inability to switch from glucose to fat. This is called metabolic inflexibility. What is happening is both glucose and fatty acids are getting metabolized at the same time. What you need is time between two meals, 1 square meal or 2 square meals. In fact, our ancients got it right. I was looking at the other day, there are only 2 mantras in the olden days, you would not eat without offering food to God, right? Only 2 mantras, one for the morning, one for the evening. Satyam tatveda parishinchami, pratam tatveda parishinchami. Only 2, not 3, not 4, not 5. And they would eat at sometime in the morning and then before sunrise, sunset, and stop. The Jains still do it. So what's the function of not having glucose at night? Autophagy. Remove the dead cells, remove the cells that are not functioning, improves longevity because it works with SIRT1, right? Does it work? I have 1 minute, so let me do this. Animal studies, lowering blood cholesterol, fasting sugar, body weight, fat, inflammation, diabetes. Dysbiosis changes. Drosophila, energy expenditure, motor endurance, cardiac function. Mixed studies and clinical studies, time-restricted eating seems to work in some studies, some not studies. My feeling is that most of these are badly designed studies. Simply because they've used, for example, in the Chinese study, instead of using a 16:8, they would have used a 14:10. I think what we really need is an Indian study that looks at it, because India has a lot of people who fast. We need to look at it a little other way. But the reason I bring this up is to say that there is a reason why these ancient rhythms are present. And it's, you really don't want to be tampering with many of these. So one of the things that we need to tell our patients is, you know what? Go home and have a good night's sleep. I mean, if you can avoid shift work. A lot of times our youngsters are working at a US time. And I always wonder, what is this economic benefit that we're going to get when half our population is probably getting diabetes by the time they're 30? Maybe we should make a balance between material wealth and happiness, which are two different things, right? Whether time-restricted eating works, we will find out in a few years. Intermittent fasting, we'll find it in a few years. Exercise sets the clock very well. If you want, you can have a ketone drink. By the way, my friend Sundar Mudaliar was telling me that for the first time, the Oxford team won the Tour de France. And the reason that they won it was they were drinking a ketone drink because it gave it an alternate fuel. By the way, stop believing literature. Remember in 1972, sugar was considered, they paid Harvard to tell people that fat is worse than sugar, right? I'm sure some of you know. Similarly, there's a big lobby that looked at Indian fatty acids and oils to say this is bad. But we now know that fatty acids is protein, which is present in coconut oil, seems to work, right? And of course, a new bunch of mitochondrial modulators will come in the next year. But till then, respect ancient cycles. At least be aware of them. and talk to your patients. Sleep well. Do not take devices into your bedroom. Reduce the light. Get some sleep hygiene. And more importantly, don't think our ancestors were fools. Just because we don't understand them, it doesn't mean that they were bad. They were probably good because we are all their progeny, right? So with this, let me stop. I hope I've not exceeded too much. Thank you so much. Appreciate it.
Hello. It's a pleasure to introduce Dr. Upal Sen Gupta. We know Dr. Upal since our PGI days. We almost trained almost same time. At PGI, one of the best faculty international time. I remember Upal joined a department. Basically, he was selected for both gastroenterology and the nephrology, but he chose nephrology to pursue the career further. And I asked why you have taken that decision. He told was the nephrology is an extension of medicine. That's why I chosen this subject. And I am congratulate him. He is doing very well at Kolkata, practicing as nephrology and very of great fame, doing very good at that place and working at Fortis. And the topic today is going to talk about is a combining state-of-art therapies to maximize efficacy of the meeting diabetic kidney disease in adults with the novel therapy we are witnessing, fewer novel therapy or horizon. So please, Upal.
Thank you, Dr. Deepak, for this humble introduction. Yes, one time in Chandigarh. And thank you, Dr. Bishas, for inviting me in this beautiful session regarding this diabetes in Durgapur. So without wasting time, I'll be discussing the state-of-the-art therapies. There are new developments over last couple of years in the field of diabetology, especially for us nephrologists. It's been an interesting part of couple of years that we have as some masters in our armamentarium, and we'll just discuss how to properly use these drugs with the best level of evidence that we have for the benefit of our patients. So we know that the CKD is just booming up throughout this, although this is an American data, but in Eastern countries, I'll show you the Eastern part, the incidence and prevalence of CKD is just roaring up. And the number of projected renal replacement therapy is going to be just doubled in around 2030. And you can see in the graph that Asia is going to lead. We also know that even in India and eastern part of the Asia, as well as in United States, diabetes is one of the leading cause of chronic kidney disease. So how bad is having dialysis? Survival is just good, better than a lung and pancreatic cancer. It's even worse than breast, prostate and colorectal cancer. So that bad is having a end-stage renal disease requiring dialysis. So we know, before discussing anti-diabetic therapies in chronic kidney disease, we should know what is our goal of treatment. The goal of treatment in chronic kidney disease is not straightforward. The HbA1c goal depends on what profile of patients you are dealing with. It's more time to be subjective with your patient than following a strict guideline. The more the severe the chronic kidney disease, the more are the macrovascular complication, the more the comorbidities, the elderly the patients, the less the hypoglycemic awareness and the resources of hypoglycemic management. You have to take into consideration all those things in deciding what should be your HbA1c target. It's varying from a range of less than 8 to less than 6.5. So we all know that the basic pathophysiology that the nephrologists think in the diabetic kidney disease is the hyperfiltration. It starts with the kidney, the glomerular starts overworking. And one of the biggest part in the overworking of the kidneys is the dilatation, the abnormal dilatation of the afferent arteriole and constriction of the efferent arteriole, more the abnormal dilatation of the afferent arteriole causing intraglomerular hypertension, leading to damage of the glomerular filtration membrane, leading to proteinuria and causing inflammation and fibrosis. This is the basic pathophysiology. So all the therapies basically will be targeting to reduce the intraglomerular hypertension and mitigating the onset of proteinuria. So we know this diagram a lot of time. From 1993 to 2021, there are a lot of studies where the nephroprotection in diabetes is targeted, starting from the captopril in 1993, then came the landmark IDNT and renal trials in 2001. Till 2015 to 17, the SGLT2 inhibitors are brought into clinical practice. There were only RAS inhibition, and the RAS blockade is so important. I'll not go into detail into the pathophysiology, but there are 3 or 4 levels: renin, AC inhibition, blockage of AT1 receptor, and finally the aldosterone receptor. There are 4 levels that we can interfere with this RAS system and address the intraglomerular hypertension. So also there are plethora of evidence where RAS blockade showed beneficial effect in preventing the progression of the chronic kidney disease, be it a prevention of ESRD and death with renal and IDNT, preventing overt nephropathy with microhop life and ARMA trial, and preventing microalbuminuria in trials like Euclid, Direct Run, and Benedict. All of them showed significant effect of either AC and ARB, both in type 1 and type 2 diabetes. But again, we do not use AC and ARB together because of reasons of acute kidney injury and hyperkalemia. So this much for AC and ARB. Now that we are into the era of SGLT2 inhibition, and once we talk about SGLT2 inhibition, how do these molecules work? So we start with tubuloglomerular feedback. The normal tubuloglomerular feedback is restored by the SGLT2 inhibition. In between, there is an impaired tubuloglomerular feedback. Why? Because there is a lot of SGLT2 receptor upregulation in the proximal convoluted tubule in diabetic patients. So there is a lot of absorption of the sodium and the glucose, and there is inhibition, the inhibition of the tubuloglomerular feedback, leading to constriction, dilatation of the afferent arteriole, leading to intraglomerular hypertension. SGLT2 receptors block them, restores the TGF, and then again there is a dilatation of the constriction of the afferent arteriole, and the intraglomerular hypertension is mitigated. Same way, the RAS blockade actually will constrict the afferent and dilate the efferent arteriole to reduce the intraglomerular pressure. Other than this, the basolateral glucose after the SGLT2 blockade, which actually causes inflammation and fibrosis, is also decreased. We also know that SGLT2 inhibitors with a natriuresis, they actually causes the ketone to get more and more absorbed in place of sodium, which will create a state of the liver will differentially use as a result of fuel and cause less amount of oxidative products and less amount of inflammation. We know the trial started with the CVOT outcome trials, the DECLARE, Canvas program, and EMPERIC. For one nephrologist, the problem is all these trials where the patient population was on the green zone. That means the patients were not so much high risk, not so much representative that we can recommend using this drugs. Our day-to-day patients, where we see advanced kidney failure patients with advanced lower GFR and more and more proteinuria, which is represented in this beautifully represented KDIGO risk category diagram, where the deeper the color, the more is the risk to progression towards chronic kidney disease and end-stage renal disease. So the CVOT trials, although they showed a beneficial renal outcome, they were not powered to be used in a moderate to severe degree of renal outcome. Then we required
dedicated renal trials. We know about the Credence trial, where the HbA1c was around 8.3, an average albumin creatinine ratio was 927, and eGFR of 56.2. We know that a primary outcome of composite reduction of ESRD, doubling of composite ESRD, doubling of serum creatinine in renal and CV death was much less than compared to placebo. In conclusion, the patients with type 2 diabetes and kidney disease, the risk of kidney failure and cardiovascular events was lower in the canagliflozin group. HR, the hazard ratio was 0.66. Again, if you see this canagliflozin, the number needed to treat to prevent a primary outcome in kidney disease was just 21, exceeding exciting results for nephrologists to use this drug. What I wanted to show is that the disease, the beneficial effect was available in all the categories of albuminuria. If you see that the separation of carb is maximum when there is more severely increased albuminuria, that means this drug is to be used mandatorily when there is a A3 category of albuminuria, ACR level more than 300. Again, another drug, dapagliflozin, we have from DEPA-CKD trial, beautiful evidence showing that around 6 to 7% reduction in the primary kidney outcome of decline in eGFR, 50% ESKD or death from renal causes, along with the cardiovascular outcomes. And again, all this risk category, moderate, high, and very high risk, all of them has showed a reduction in the risk and a hazard ratio which is less than 1. In indicating the SGLT2 inhibitors can be used in moderate and but more seriously considered almost to be used mandatorily if there is no other contraindication in severely affected diabetic nephropathy patients. So just to remind you, this is the chart. The lighter the shade, the less is the chance of progression. The red is the color. The more red is the color, the more risk of progression to end-stage renal disease. Some word about the GLP-1 receptor agonists. There are number of trials where either liraglutide or semaglutide or dulaglutide has been shown to reduce the microalbuminuria, decrease the slope of eGFR. Even in one trial, such the AWARD 7 trial, as compared to insulin. KDIGO recommends the use of the GLP-1 receptor agonist. All of them, most of them do not require any dose adjustment. You can use safely up to a GFR of 15. The exact position of this drug in the guideline of treating diabetic kidney disease patients, I will show you later on in the flow chart. So what about non-steroidal mineralocorticoid receptor antagonists? Now this is a new kid in the block. We have heard about aldosterone. We have used eplerenone mostly in the indication of the heart failure. But this drug, finerenone, is being tried in a primary kidney outcome trial, the Fidelio kidney outcome trial, where it has shown a bit less compared to the SGLT2 inhibition. They have shown that a primary composite outcome of the kidney failure, like more than 40% decrease in GFR over 4-week period of death on renal disease, significantly lower than placebo. Even in this Figaro DKD trial, where the primary outcome was cardiovascular, it has, albeit to a lesser extent than the Fidelio trial, shown renal benefits, but it has shown more, it was not powered to show the renal benefits, more cardiovascular benefits, but no renal side effects. More interestingly, what will be bothered about is hyperkalemia. There was hyperkalemia, but the hyperkalemia leading to discontinuation of the drug or the hospitalization or any other serious adverse effects were very, very low. So just again, showing this data on the KDIGO risk curve, superimposed data on the KDIGO risk curve, that both Figaro DKD and the Fidelio DKD were actually targeting A2 and A3 category of diabetic kidney disease patients, moderate to severely increased risk to progression of diabetic kidney disease. That is, they are more suitable for use in our general population, where we see a significant amount of proteinuria and lower GFR. So now coming to part of diabeticians,
that ADA guideline. ADA does not address the diabetic kidney disease very separately from heart failure. They have given position to diabetic kidney disease along with the heart failure, that you can start an SGLT2 inhibitor. If the SGLT2 inhibitor is contraindicated or not being tolerated, you can switch over to a GLP receptor 1 agonist, or whenever the GLP receptor agonist is not suitable, then insulin and all these things. But this is the limitation of ADA guideline with this cartoon. But KDIGO actually addresses it to more elaborate stage. Although the outcome of the EMPA kidney trial is yet to come out in few days, actually, in American Society of Nephrology conference, in their guideline, they have kept the cutoff for using a SGLT2 inhibitor as around more than equal to 20. So it is considered among the first line therapy along with metformin. Let me show you that the green part of this diagram is for diabetic, and the blue part is for non-diabetic patients. For the diabetic nephropathy patients, the GFR is more than 20. If you use SGLT2 inhibitor, as per the HbA1c, if the GFR is more than 30, along with metformin, if the disease is not controlled, the additional risk-based therapy is needed, then GLP receptor agonist is needed if glycemic control is not achieved. Now, if the proteinuria persists or the creatinine continues to increase in spite of these two therapies, you have to consider a non-steroidal mineralocorticoid receptor agonist if the ACR is more than 30 and the GFR is taken as low as 20 in these trials. So remember that all these therapies are to be preferably given on a maximally tolerated dose of AC inhibitor or ARB. By that, what I mean is the level of hyperkalemia or AKI or hypotension is to be kept at minimum. So the maximally tolerated dose of RAS is to be given, after which you consider SGLT2 or non-steroidal mineralocorticoid receptor antagonist as an additional risk reduction therapy in the guideline that is presently followed by KDIGO as well. So what about when you initiate an AC and ARB? Whenever you initiate an AC and ARB, you monitor your GFR and potassium every 2 to 4 weeks. What do you expect? You expect a 30%, up to 30% reduction in GFR. If there is more than 30% reduction in the GFR, so you think of the correctable causes of AKI. That is, whether you are using NSAIDs, whether it is along with diuretics, there is a volume depletion, or there is any bilateral renal artery stenosis that has caused a jump in creatinine when you have started the ACE inhibitor ARB. If there is normokalemia and less than 30% increase in creatinine, increase the dose to AC and ARB to maximally tolerated. That point, there is no hypotension. And if there is hyperkalemia, please do not stop the drug altogether. You can temporarily reduce the dose of drug. See whether the other reversible, correctable causes are there. In diets, review the diet, review the salt. Many of the patients will be taking low salt, low sodium salts, which are very high in potassium. And consider giving diuretics together. Give sodium bicarbonate. Sodium bicarbonate in CKD patients is a potent agent to reduce or control the hyperkalemia. And also you can use potassium binders. I know the present potassium binder that we have in our market is very difficult to palate on a regular basis, but there are very good molecules that are available on the western part of the world and are coming very soon in India. That is zirconium and these molecules are planned for prolonged use along with this drug so that the hyperkalemia can be controlled. So what about SGLT2 inhibitor? The GFR cutoff is set at more than equal to 20. So whenever, and the high priority are ACR is high. So potential contraindication, female sex, they're more prone to genital infection, and those females who have a recent history of the genital mycotic infections, prior diabetic ketoacidosis, foot ulcers, and immunosuppression. These drugs are not recommended for the use of kidney transplant as of now. So SGLT2 inhibitor with proven benefits, Cana, Depa, empagliflozin. Remember, you have to follow sick day protocol. Whenever the patient is sick, dehydrated, or in the perioperative period cannot drink water, or will be having a period of will not be taking water for contrast study or something, avoid these drugs for that day. Follow the sick day rule and follow up, assess adverse effects, review the knowledge, anticipating acute drop in GFR. Same as RAS inhibition, these drugs will show an acute drop in GFR up to 15 to 20%, but they will show a reversible rise to the baseline in due time, in 2 to 3 months' time. Please do not stop or reduce the dose of SGLT2 inhibitor when you should see an acute drop in GFR. So think about the volume depletion risk, concurrent diuretic. If you are using a very high dose of diuretic for reducing the edema, please hold your SGLT2 inhibitor use for some time. Once the volume is more or less stable, then you can start with a minimum dose of diuretics. You have to see the history of AKI. The patient with a recent AKI, we should avoid using, and ask the patient whenever possible to drink the maximum amount of water tolerated in that level of CKD, which is advised by the nephrologist. What about the MRA, non-steroidal MRA? The KDIGO advises using a non-steroidal MRA with a proven kidney or cardiovascular benefit for type 2 diabetes mellitus with a eGFR of more than 25, normal serum potassium concentration that they have kept a cutoff of less than 4.8, and despite maximally tolerated RAS inhibition, they have a proteinuria, albumin-creatinine ratio more than 30. So the cutoff to start, the initial point to start the finerenone is 4.8. If the potassium is less than equal to 4.8, you start with 10 milligram. If the GFR is between 25 to 59, if GFR is more than 60, you can straight away start 20. Monitor potassium at 1 month and after initiation, and then after 4 months. In my clinical practice, I have started monitoring potassium of these patients every weekly just to see, gain experience about this new drug. And to my surprise, actually, none of the patient is having a potassium as more than 5.5, which recommends discontinuation of the drug. So between 4.9 to 5.5, you have to continue finerenone 10 or 20 milligram and have to monitor potassium very closely. Remember, you have to prescribe those patients who can do a potassium test and get back to you regularly, not for somebody who lives in a remote area and do not have access to regular potassium testing. If the potassium is more than 5.5, hold finerenone, consider adjustment to diet or concomitant medications to mitigate hyperkalemia, recheck potassium. Among them, the most important is you have to see a co-prescription of, if there is a co-prescription of RAS inhibition also. If there is a RAS inhibition and the BP is on the lower side, you can also consider to decrease the RAS inhibition and keep the RAS and non-steroidal MRA together. So this cartoon is actually showing that whatever drug is more suitable in the setting of eGFR less than 15. So we know about the DPP4 inhibition, insulin, and thiazolidine, and then again, now we have SGLT2 inhibitors, GLP-1 receptor agonist, and not for the diabetic indication, not for the diabetic control, but specifically for one drug, which is not for diabetic control, but for the diabetic kidney disease, reduction of progression of GFR and reduction of mitigation of albuminuria, non-steroidal mineralocorticoid receptor antagonists. Does it decrease the list? So RAS inhibition use needs confidence and experience. Many young doctors, I have seen that with slight increase in creatinine, the first response is to stop the RAS blockade. This is not the approach. RAS is tremendously beneficial. It has been shown in studies that even in stage 4 CKD with GFR as low as 20, if you stop RAS, the overall mortality actually increases. Try to keep your RAS blockade for as long as possible. Modify your other drugs, diet, lifestyle, give potassium binders. Try to keep RAS as much as possible, RAS inhibition. SGLT2 inhibitor have immense volume of evidence, and the most tangible outcome for a nephrologist for SGLT2 inhibitor, what the patient will ask, why are you giving me the medication? The effect is going to come after 10 years. No, the most important reduction that you see is albuminuria. If you see the studies, the Credence trial, the DEPA-CKD trial, the albuminuria started decreasing in as early as 2 months.
And if you continue for 6 months, there is significant reduction of the albuminuria, not the GFR. The GFR, it's not that will not progress to decline. The GFR will decline slowly, as much as if you use SGLT2 inhibitor, start using SGLT2 inhibitor in a stage 2 CKD, the patient will gain of CKD with or without SGLT2 inhibitor. GLP-1 receptor agonists, we have to be selective in using, considering the cost and contraindication. Non-steroidal mineralocorticoid agonists can be double-edged sword, can cause AKI hyperkalemia if you do not use them judiciously. But remember, all these state-of-the-art therapies that have come in a couple of years, you need close monitoring, patient counseling. That is very important. And the basics of lifestyle modification and the diabetics goals, the HbA1c goals, must be prioritized before starting this new onset therapy. If you have forgotten about metformin and insulin and started with SGLT2 inhibitors and linagliptin, that is a long line of therapy. So my afterthoughts that things that we have not discussed is newer CCBs, that they have a potency for nephroprotection in diabetic kidney disease as well. Newer anti-hyperkalemic medications that can be used for a prolonged period for treatment, giving along with this mineralocorticoid receptor agonist and RAS inhibition, whether there is a persistent hyperkalemia, and dual SGLT2 inhibition, SGLT1 and 2, that probably has some more benefit than only SGLT2 inhibition.
Thank you, Dr. for his presentations. Now I welcome all of the speakers. Dr. Shane Gupta, Nilesh Shane Gupta, Dr. Krishna S. Shadri sir, Dr. Upal, to please stay at the desk with us for the question and answer session.
So thank you very much, our eminent speakers, and that was a really awesome talk by all the speakers. So thank you, Dr. Nilanjan, Dr. Upal, and Dr. Krishna for giving such nice talk. And now we will have a question answer session. Any question from the audience? You can have your question.
I have a question for Seshadri sir.
Yeah.
Seshadri sir, such a fantastic talk, sir. It's mesmerizing to listen to you. And it's indeed true that the loss of circadian rhythm is one of the most important pathophysiological factor for the development of insulin resistant and consequent type 2 diabetes mellitus. And you people are such a great people that you hold a position where you can influence the policy of government. So can you just simply advocate a policy that shift the office time so that people come home early, people will have less exposure to the light, and it can influence the demographic disease demographic of India.
So I think, while I've taken a leap of faith in certain things, we actually need to establish the clinical data here. That's very, very important before we go and knock the doors. For example, we do know that nurses have a higher incidence of diabetes. We know that shift workers have a higher incidence of diabetes. I think it's time, and we should talk to professional bodies to start putting in position papers about the evidence that we have, but also create a list of the evidence that is required to establish this, right? Many of us are anecdotally talking about it, that our diabetic patients are younger, our shift workers are getting more, our nurses are getting more diabetes, that there are other problems. But I think now we need some clinical trials before we go and tell the country, look, you can't code for the world, or you can't work in some other shift. But one of the interesting things is that patients themselves, and this is again anecdotal, who go back and change their shifts. They say they work with their employers and say, look, I have diabetes, I'm not able to handle this, let me change my shift back to a regular shift. they do much better in terms of glucose control. But I think it's important to get a corpus of information before we go and bang doors. But you're right. I think it's time to look at this.
Thank you, sir.
Thank you. So
If I may comment on this, what you have suggested is very right, and what Dr. Seshadri has pointed out, but staying out night or eating unphysiologically is not due to job. There is another aspect, which is the patient's choice or our choice. We can change the lifestyle for not going parties late night, not doing them that much, not using the devices, as you said, taking your device at your bedroom. For that, you do not require any government rule or any court to do it. That charity can begin at home.
Definitely, it's been well shown in C. elegans, with beautiful studies that show that genetic imprinting is, especially maternal genetic imprinting, is done for 14 generations. So we are what our mother and her mother and her mother ate. Just, avoiding eating out as much as possible and eating food at home and staying true to what your ancestors ate, not the pizza and the burgers, not processed food. In fact, one of my colleagues, Chitra Selvan, was commenting the other day, is it the reason the people who fast, is it because they're eating home food that they do well, or is it because, and avoiding processed food? We don't know. But clearly, it looks like you are what your mother gave you. Thank you.
Thank you. Thank you, Dr. Krishna. Any more questions, please?
Nilanjan sir, that was an excellent and enriching presentation. I wanted to ask one thing, that can the symptoms of gout or gouty pain can appear much below the level of 6.8 blood levels, like after 6?
Yeah, it can. And mind it, at the time of an acute gouty arthritis, you may even get a normal, so-called normal serum uric acid level. So if you have to assess it, you should do it in the intercritical period. So, and that apart, if there are other predisposing factors like alcohol or a cold temperature, even with a so-called normal uric acid level, you can get it. Yeah, sure.
Thank you.
Yeah, thank you. Thank you. Any more questions? We'll wait for a few minutes.
One question to Dr. Nilanjan. Sir, there was a nice presentation from your side. But as a nephrologist, a little bit of each from treating uric acid in our patients. The reason is being the data is not very robust. There are a few small studies, and whatever little bit data we have in form of CKD, fakes, and the Pearl studies, they were shown there's no any definite improvement in the GFR slope. They have used around 2.5 years of a study, and whatever data there is allopurinol, not the Fexa state. We are extrapolating the data from allopurinol to the Fexa state right now, and as we all know, the renal handling of the uric acid. As the GFR falls, the uric acid is for normal patients, we assume it is 6.8 is normal, but for the patient with the moderate renal impairment or even severe renal impairment, the uric acid around 7.7, it's not looks like high to treat, because there is no causal effect is not proven it, although association is there in the progression of CKD.
I think that's specifically why this topic has been given by the organizers. It's not done and dusted. But what I mean to say that with allopurinol, whatever little you have the specter of your, cutaneous reactions that can kill the patient, which is fortunately not so much with febuxostat. So it happens to be a relatively safe drug. So you can err on the side of treating, especially, that's a point, very good. Had it been 7.7, you were debating whether you would give it or not. But had the uric acid being 8.7 or 9, then there would have been that is, if the uric acid elevation is out of proportion to the diminution in GFR. So there would be some increase. So especially if it is out of proportion to the diminution in GFR, there can be a case. Of course, now we are having other agents, like at that time when we did the idea consensus, even Upal was there, we didn't have MRA. So we didn't have so much robust data, even with the SGLT2 inhibitor. So things, again, we can have a relook at it. But on the whole, I think it's not a bad idea to err on this.
Thank you.
I have one question to Dr. Upal Sengupta. Thank you, sir, for your excellent deliberations. Sir, when in our practice, when we are using a patient on metformin, when we are thinking of using SGLT2 inhibitors, what is the nephrological point of view when patient having some renal impairment, which SGLT2 inhibitor is better?
So, if you consider the data on CKD patients, the primary outcome trials, we have data from Credence trial, we have data from DEPA CKD trial. The empagliflozin trial is prematurely stopped because of the enormous success that is probably seen earlier in the March 2022, and the results will be published in ASN. So I think personally, although the risks of the limb fractures and the lower limb amputation has been not proved in this CKD Credence trial, but still, if you consider the overall profile, the cost profile, the evidence profile, at present, it looks like the dapagliflozin is the agent to start in the Indian scenario as of now to start.
Thank you, sir. Any question from the audience?
Thank you, Seshadri sir. You have opened a new horizon for all of us. My question is to Nilanjan sir or Upal sir, because my question is related to both of them. Sir, what should we tackle persistent microalbuminuria for PGDM patients? Because we know many medicine we can't prescribe at that stage. So do we wait for 10 months to be over, or so start any regimen or therapy to stop microalbuminuria?
Which patients?
For PGD.
Oh, pre-gestational diabetes. Okay. So you are asking that even after the delivery, the microalbuminuria is persisting? No.
No, during the gestational diabetes period or pre-gestational diabetes mellitus.
Obviously, pre-gestational diabetes period, if somebody has picked up microalbuminuria, whenever you pick up a microalbuminuria, you see whether the patient is hypertensive or not. If the patient is not hypertensive and if the patient is having microalbuminuria, then obviously microalbuminuria without a diabetes and indicates a kidney disease. But in pre-gestational diabetes, if there is a microalbuminuria, you have to treat them. But if you're planning a pregnancy, then the issue is that you should not be
It's just keep. I want you to look up a series of articles that was published as a meta-analysis in the Lancet, and this is by Bangalore et al. And what it showed was that irrespective of the drug use, right, bringing down the blood pressure was beneficial. So if someone's planning a pregnancy, you really can't be using a drug that will ultimately get you into trouble for it being a teratogenic agent. But you can use any drug to bring down the blood pressure and it will benefit the patient. So I think two parts. One, you really don't want to be using a drug that has not been tested in pregnancy and can cause problems. But you can use any antihypertensive in this particular patient. I think that is a lot of us give a lot of weight about the ACE inhibitors and ARBs. But the truth is that the data that separates out any of these is not very much. So in those situations, control the blood pressure.
Yes, and number of patients of those patients is also limited, very less.
But what I do in my practice, as Sheshad said, optimizing the blood pressure and giving a calcium channel blocker, because there are data that calcium channel blockers also can decrease proteinuria.
So that is what I was discussing, that calcium channel blockers, not all calcium channel blockers. In fact, if you see trials where it's the IDNT trial, if you see the irbesartan was compared to amlodipine, and this amlodipine arm was showing increase in the proteinuria as compared to the irbesartan arm. So actually amlodipine has been shown to increase proteinuria. You have to specifically use drugs that calcium channel blockers that are designed to decrease the proteinuria. That means mimic the RAS inhibition. That means that is constriction of the efferent arteriole and dilatation of the efferent arteriole, because they are both anti-calcium channel blockers. Many of these drugs are ifosfamidipine, benidipine, and azelnidipine. These drugs are known to decrease proteinuria along with good blood pressure control. They are, I'm not specifically known. Cilnidipine is studied in pregnancy patients. I'm not sure about the data of ifosfamidipine, benidipine, and azelnidipine. Thank you, sir.
Nitrendipine had data. Older nitrendipine had data.
Only nifedipine, yeah.
Upal, just a clarification.
Reduces
Just a
proteinuria in
clarification
older
in the
studies.
IDNT amlodipine, did it increase albuminuria or was it less decreased compared to irbesartan?
Amlodipine arm got increase in albumin.
Okay.
So in a patient who in that study, in a patient who was already on an ARB or an ACE inhibitor, and then amlodipine was added, there was no increase in albuminuria. It is in the monotherapy arm alone. But just to let you know that this is all really micro hair splitting. I don't think that that's solid data to say where we are. It's just a side observation we have.
Any further questions? So thank you very much. That was a very nice interaction. And now I will request. Now I'll request our chairperson to felicitate our eminent speakers. So I will request Professor Syamal Kundu to felicitate Dr. Nilanjan Sengupta. Big round of applause, please. Thank you very much, Dr. Nilanjan, for such a nice talk. Now I request Dr. Deepak Kumar, nephrologist, to felicitate Dr. Upal Sengupta. Thank you, Dr. Upal. Thank you, Dr. Deepak. Now I request Dr. Satrajit Rai to felicitate Dr. Krishna G. Sesadri. Thank you very much. Now I will request Dr. Somik Goswami and Dr. Rakesh Kumar to come to the stage, please. Dr. Sasi, yours, Sasti. So I will request Dr. Somik to felicitate Dr. Syamal Kundu, professor. Thank you, Dr. Syamal. Now I request Dr. Rakesh Kumar to felicitate Dr. Deepak Kumar. Thank you, Dr. Deepak. And now I request Dr. Yashan Chakraborty to felicitate Dr. Satrajit. Thank you, Dr. Satrajit. So that was a very nice session, very nice interactive session. Thank you all the speakers, all the chairpersons and all the audience, all the delegates, those who are present here. So it's time for dinner. So we can have our dinner, and post dinner, we will have our musical session. Our musicians are ready. They will have their part here on the stage, and hopefully we'll have a good night today. Mr. Tushar is already ready. Thank you. Thank you very much. So request to everyone that tomorrow's session will start at around 9 a.m. So I request all the delegates to attend the session to make it a grand success. Thank you. It is.
है मुझको ऐसे